संकट आमचे विलयाला जा.
स्तवितो तुम्हा संकट आमचे विलयाला जाओ.
स्तवितो तुम्हा संकट आमचे विलयाला जाओ. हे गजवदन वक्रतुंड महाकाय. हे गजवदन वक्रतुंड महाकाय. हे गजवदन वक्रतुंड महाकाय. वक्रतुंड महाकाय. वक्रतुंड महाकाय. लंबोदर पीतांबर भैवर वंदना. सरळ सोंड वक्रतुंड त्रिनयना. रामाचा वाटा हे सदना. संकटी पावावे निर्वाणी रक्षावे सुरवर वंदना.
जय देव जय मंगलमूर्ती. दर्शन मात्रे मनोकामना पूर्ती. जय देव जय मंगलमूर्ती. दर्शन मात्रे मनोकामना पूर्ती. जय देव 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 जय देव.
Good morning, everyone. I welcome back for a beautiful morning. Yesterday we have gone through all the interesting topics, and I am sure that you have enjoyed all the sepsis-related topics. Today we'll start the day with the keynote lectures. The first will be the sepsis-induced coagulopathy and the lessons learned from the COVID trials. For that, I welcome Dr. Professor Rupen Arya from London, who is the professor of thrombosis and hemostasis with extensive work. Over to you, sir.
This is Professor Rupen Arya. I'm professor of thrombosis and hemostasis at King's College Hospital in London. Thank you for the kind invitation to speak at Sepsiscon 21. Very early on in the pandemic, we realized that COVID-19 can be complicated by coagulopathy with a high risk of thrombosis. So today, I would like to share with you the lessons learned from the COVID-19 trials. First, a few general lessons. At the outset, there was very little high-quality evidence, and decisions were made very much on the basis of observational data, as well as expert consensus. So first and foremost, stick with the evidence. Don't trust everything you read, even in high-impact journals. There have been numerous retractions in the medical literature during this time, and there have been many false dawns, and many treatments have been withdrawn. We know that research can be accelerated through collaboration, particularly in the multi-platform studies. And the adaptive platform studies have enabled a very swift response to changing knowledge. We also know that incremental improvements in care improve patient outcomes, and clearly webinars have transformed sharing of knowledge and are here to stay. So during the past 18 months, there have been nearly 3,000 RCTs to do with COVID. Nearly 80% of them were small RCTs, but many large RCTs have provided very useful data. For instance, supporting the use of dexamethasone, tocilizumab, and remdesivir, which have really transformed the care of patients with COVID, and many treatments like hydroxychloroquine, azithromycin, ivermectin, and even convalescent plasma have been found to be of very little utility. There have been over 60 registered clinical trials investigating heparin alone. I will go on to discuss the headline results later on in my presentation. Very early on, we became aware of this phenomenon of COVID-19 associated coagulopathy. Nearly half of hospitalized patients with COVID-19 disease have evidence of coagulopathy. There are very high levels of acute phase proteins, which correlate with the levels of inflammatory markers like IL-6 and CRP. And there are distinct features which differentiate it from DIC. Usually the platelets and fibrinogen are not that low. There's a high rate of lupus anticoagulant positivity. And there was also evidence very early on in data coming out from China that the D-dimer levels might have a correlation to mortality and a higher odds of critical illness. So the activation of the host defense in COVID-19 disease results in a marked inflammatory surge and subsequent activation of clotting and thrombin generation. So there's a combination of COVID-associated coagulopathy and endothelial dysfunction that has been termed thromboinflammation or immunothrombosis, whereby the clotting, which is activated by the inflammatory response through several pathways, whether it's a contact pathway, whether it's a complement, whether it's the neutrophil extracellular traps, or the huge surge in cytokines, can result in endothelial injury and microvascular thrombosis. Very early on, there were studies coming out of China that demonstrated that coagulopathy predicts a worse outcome, and indeed that there might be a role for moderating the coagulopathy through the use of anticoagulation to reduce the risk of thrombosis and possibly improve outcomes. This, for instance, is observational data from North Carolina, New York, that suggested that anticoagulation might have a positive impact on survival in critical care patients. So here are the very typical appearances of a COVID-19 pneumonia on the left, and in the same patient, lower lobe pulmonary emboli. There's truly an extraordinary burden of thrombosis, which can affect both large and small vessels. In the published experience, it is about 80-85% venous thromboembolism, whether it's pulmonary embolism or deep vein thrombosis, and about 15-20% arterial thrombosis. And of course, particularly in the first wave, we were seeing a lot of blocked renal circuits as well as line-related thrombosis. Thrombosis is particularly common in critically ill patients, in severely affected patients, where very early on we realized that the thrombosis rates were about 2 or 3 times the usual rates that we are accustomed to seeing in critical care patients, despite the use of standard thromboprophylaxis. And this awakened an interest in using escalated doses of low liquid heparin for thromboprophylaxis. So I think the early guidelines were based on not much evidence, and they were produced by various societies. They were unanimous in recognizing that the VT rates were very high and that all hospitalized patients with COVID-19 disease were at high thrombotic risk. So the important thing was to assess the risk of bleeding and to prescribe low liquid heparin thromboprophylaxis. By last summer, there were many guidelines that helped direct practice. I think overall, most of the guidelines agreed that for the ward-based patients, standard low liquid heparin should be used, and in critically ill patients, because we were seeing 20-30% incidence of pulmonary embolism, some of the guidelines started recommending, through a consensus approach, intermediate doses of low liquid heparin. And generally, there was not a recommendation for post-discharge thromboprophylaxis. Low liquid heparin is the mainstay of in-hospital thromboprophylaxis because of the better absorption and the fewest drug-drug interactions, and possible antiviral and anti-inflammatory effects. Our own study at King's in nearly 1,500 patients showed that overall about 5% of our COVID-19 patients had pulmonary embolism, so about nearly 4% of the ward patients and 16% of the ICU patients, despite the use of standard prophylaxis. Nearly half of the PE were diagnosed on hospital admission, and about half the cases of pulmonary embolism were limited to the smaller vessels. Again, another very controversial area in prophylaxis is whether patients should receive post-discharge thromboprophylaxis. And this is some data my group published nearly a year ago now, where we reviewed cases of hospital-associated VTE. And we found that post-discharge venous thromboembolism was not significantly increased in patients hospitalized with COVID-19 disease. And neither did the existing literature on the role of extended thromboprophylaxis support a role for extended prophylaxis, because the number needed to treat to prevent one case was about 176, and the number needed to harm was much smaller at 60. So for us at King's and in many other hospitals, for much of the past year, the evidence has dictated this guidance that all patients are at a high risk of venous thromboembolism and should receive anticoagulant prophylaxis if the bleeding risk is low. And we have in our practice been using intermediate dose on critical care and standard dose on the wards, and we have not been using post-discharge prophylaxis. And the thrombosis risk and bleeding risk alters significantly during the course of the patient pathway. And there seems to be a need to adjust the intensity of the anticoagulation. And the standard one-size-fits-all approach to thromboprophylaxis that we are accustomed to seems inadequate to tackle the immunothrombosis in COVID-19 disease. So in the next few slides, I'll kind of describe some of the approaches and attempts to intensify the thromboprophylaxis in COVID-19 disease. You're probably all familiar with the therapeutic anticoagulation trials. And these were 3 different RCTs, REMAP, CAP, ATTACK, and ACTIV-4, that combined to look at the question of the role of therapeutic low liquid heparin or unfractionated heparin in both severely ill patients as well as moderately ill patients. Unusually, the primary outcome was not thrombosis, but organ support, 3 days. So again, these were the interim results which were shared by Twitter. One just before Christmas of last year and the other in January, that suggested that amongst critically ill COVID-19 patients, therapeutic anticoagulation did not reduce the need for organ support. And controversially, in moderately ill patients on the wards, full dose blood thinners seem to be of benefit. So this is the result from these REMAP, CAP, and the other studies showing that in moderately ill patients, the therapeutic dose appeared superior and that it appeared to cause harm in the ICU setting. As I said, the main outcome of this study was organ support 3 days, though there appeared to be a non-significant trend in reduction of thrombosis, and there was certainly an increase in bleeding with the therapeutic dose. So the NICE guidance in response to this was to offer standard dose low liquid heparin for all patients and to consider therapeutic dose low liquid heparin for those with moderate disease. And they also said not to base the prophylactic dosing of the heparin on the levels of the D-dimer, which was not predictive. So clearly, this is something, these results are open to interpretation because in absolute terms, there was a 4.5% adjusted absolute improvement in survival and need for organ support, with a number needed to treat of about 25 to reduce organ support and greater than 100 to improve survival. And there have been many points made, about the difference in the populations. Remap gap was in mainly the severe patients, and it was based in the UK, whereas the other studies were mainly in the US and in Brazil, featuring the moderately ill patients. And also the standard thromboprophylaxis arm was left to the discretion of the physicians. Indeed, in the critical care patients, about 50% of the standard care control arm comprised the intermediate dose. And lastly, we have a lack of insight into the mechanism of why heparin, therapeutic doses of heparin is causing a benefit in the ward patients, because it is not through its effect on reducing thrombosis. So I think clearly there's much more understanding required. Interestingly, another study looking at therapeutic anticoagulation, whether in inpatients or with anticoagulation following discharge, did not improve the clinical outcomes. So to my mind, I think the jury is still out on using therapeutic anticoagulation. And indeed, it makes me nervous, imagining a ward full of, sometimes even fragile COVID-19 moderately ill patients all on full dose anticoagulation. Does intermediate dose anticoagulation have benefit? Again, I do not think we currently have sufficient studies to inform our opinion. This was the inspiration study from Iran, which indicated that intermediate dose was not of benefit in ICU patients. But again, many have commented that this study is underpowered, and these are less severely ill patients compared to the UK experience, and VT rates were much lower than we are accustomed to. So I think we will arrive at a point not dissimilar from the ASH guidance, that perhaps all patients, whether it is on the ward or on critical care, would benefit from a standard dose thromboprophylaxis using low molecular heparin. And indeed, that's what the majority of the current guidelines recommend. Is there a role for antiplatelet agents? Again, there was an observational study that suggested some benefit, but the recovery RCT suggested that aspirin does not improve survival for patients hospitalized with COVID-19. So in summary, I think prevention of VT remains a top patient safety priority, and that anticoagulants are effective in preventing thrombosis, but can also make you bleed. And the right choice of anticoagulant is important at the right dose. I don't think the case for extended prophylaxis is compelling. And I think more data is required on the role of antiplatelet agents. Remap Cap will also be publishing their data in the near future. So anticoagulation is clearly only part of the jigsaw. And really in your COVID-19 hospitalized patients, there's a role for antivirals, for immunomodulators, as well as antithrombotics. And prevention, whether it's through behaviors or PPE or the use of mass vaccination, really is ultimately going to be the best strategy to get us out of this pandemic. So thank you for your attention today. Thank you.
Thank you, sir. Thank you for educating about the coagulopathy and the treatment. Now, we all know that in low and middle income countries, we are facing more of topical infections, and they present with sepsis and septic shock. Who better than Dr. Dilip Karnad sir from Thane, who has extensive experience in topical infections. So let us hear from Dr. Dilip Karnad sir regarding sepsis in tropical infections. Is it different? Over to you, sir.
Good morning, everyone. It's my pleasure to talk to you today on this topic of sepsis in tropical infections. Is it different? Before I start, I must congratulate the organizers for having such a wonderful faculty and a beautiful series of topics for this conference. And the topic that I will speak on is going to be a little different from the others in the sense that the focus is going to be more on tropical infections. So let's look at various aspects of the normal bacterial sepsis, where most of the literature and research has come from. To start with, there is host pathogen interaction. So this occurs most of the times in the infected organ, and the infected organ can be kidney or lung, like in pyelonephritis, pneumonia. Then there can be cholecystitis or cholangitis, skin and soft tissue like necrotizing fasciitis, and so on. The pathogen products that incite the sepsis is most often either a bacterial exotoxin or endotoxin or bacteremia itself. How does the inflammatory response occur? The inflammatory response is initiated by pathogen-associated molecular pattern recognition system. Okay, and these interact with the certain receptors. For example, TLRs are the common receptors which sense bacterial products. There is intracellular signaling, which results in changes which take place within the nucleus of the inflammatory cell. And there is release of inflammatory cytokines, which result in vasodilatation, endothelial dysfunction, metabolic and cellular changes in various organs, which produce the various clinical features of sepsis. So these clinical features most commonly are fever, hypotension, and organ dysfunction. So the organ dysfunction is very well captured by the SOFA scoring system. And in order of frequency, the most common organ to get affected in most patients with bacterial sepsis is the kidney, followed by septic shock, then ARDS, thrombocytopenia and coagulation. And less common is liver involvement, where it's mainly an increase in direct bilirubin. And the least common is encephalopathy, with all these manifestations being more common in the elderly. The laboratory features are very typical. There is leukocytosis, inflammatory markers like CRP, procalcitonin will be raised. And very classically, there is hyperglycemia, which is associated with the bacterial sepsis. Now let's look at all these aspects and see how they differ in patients with tropical diseases. So let's start with malaria, which is the commonest tropical disease that we see in practice. The host pathogen interaction. First of all, it's not a bacteria, it's a protozoa. The parasite is intracellular, unlike other normal bacteria, which are mostly extracellular. It lies within the infected red blood cell. What is the pathogen product which evokes the inflammatory response? It is the Plasmodium falciparum erythrocyte membrane protein, or PFEMP1, which is expressed on the surface of RBCs. And most of our inflammatory response is directed against this. What is the sequence of inflammatory response? First, the PFMP binds to certain proteins which are present on the endothelium. Okay, and these are E-selectin, ICAM, CD36, NCAM, and endothelial protein C receptor. The RBC has to bind to these endothelial cells, and this is an essential part of the replication life cycle of the parasite. As a result, there is endothelial dysfunction, which results in vasodilatation, extravasation, metabolic changes, and cellular changes. And this occurs even in Plasmodium vivax infection. Of these, the endothelial protein C receptor is also important in the cerebral circulation. So if there is activation of this receptor, it can result in a change in the blood-brain barrier, which is important in the pathogenesis of cerebral malaria. So apart from the normal inflammatory response, there is also increase, or there is also microcirculatory obstruction, which is mainly because of sequestration of RBCs. So microcirculation gets plugged with RBCs, which are bound to each other to form a rosette. And lastly, all infected RBCs rupture during the life cycle every 48 hours to give rise to intravascular hemolysis, which itself is a very important process which evokes an inflammatory response. In terms of clinical features, again, if we go by the SOFA criteria, kidney is the commonest organ to get affected along with thrombocytopenia. Less common are coagulopathy, liver dysfunction. Again, like bacterial sepsis, there's predominantly increase in direct bilirubin, and the liver enzymes are elevated only minimally. We can get CNS involvement like cerebral malaria, and lastly ARDS. How do the laboratory features differ from bacterial sepsis? There will be anemia because of hemolysis. The WBC count invariably is normal in patients with severe malaria and sepsis. There will be thrombocytopenia in almost all patients with severe malaria. LDH will be increased, indicative of hemolysis. Unlike bacterial sepsis, where hyperglycemia is more common, malaria is typically hypoglycemia. There will also be hemoglobinuria, increased creatinine, and neuroimaging will show the appropriate abnormalities. Next tropical disease is dengue. So this is a viral infection, and as we know, viruses are obligatory intracellular in their location. Typically, viruses attack specific cells of the body, like the viral hepatitis virus will attack the liver. Influenza virus attacks respiratory cells, in cells of the respiratory system, and so on. So which are the cells which the dengue virus attacks? So mainly it's the inflammatory cells and the macrophages. So it binds to dendritic cells, monocytes, macrophages, and mast cells. Okay, and the pathogen product which evokes the systemic response are viral proteins. And what is the inflammatory response? So first is it causes damage to the infected cells. Okay, these inflammatory cells then release cytokines like TNF alpha, IL-2, VEGF, and soluble phospholipase. Now, the last two are very important because they are specific for dengue infection. What they do is they cause damage to the endothelial cells in the venules and the capillaries. The phospholipase A2, soluble phospholipase A2, causes disruption of the glycocalyx, which is present in the basement membrane of endothelium of capillary endothelium, and causes degradation of sialic acid. So it exposes the basement membrane of the endothelium to which platelets bind, and this is what is responsible for the consumption of platelets and thrombocytopenia. The typical clinical features are fever. Then the predominant feature is a plasma leak syndrome and thrombocytopenia because of the endothelial dysfunction and damage. As a result of these, there will be hemorrhage. In organ dysfunction, hypotension and shock is the commonest. Lungs are affected to a little lesser extent. More often it is because of significant pleural effusion, but sometimes even extravasation of fluid due to capillary damage to the pulmonary alveoli can result in ARDS. Liver is commonly affected, and the main manifestation here is an increase in the transaminases level, and the bilirubin remains normal. Rarely we can get encephalitis, and again acute kidney injury is common because of the shock and hypovolemia. Lab features, here there is polycythemia, increase in hemoglobin because of hemoconcentration, leukopenia, thrombocytopenia, elevated liver enzymes, which are often in the thousands. So among all the diseases of causing sepsis, apart from viral hepatitis, this is the disease where the SGOT, SGPT will be the highest. And USG and X-ray will show evidence of effusions either in the chest and also in the abdomen. Let's look at scrub typhus. So in scrub typhus, it is a gram-negative bacillus, which is an obligatory intracellular bacillus. Okay, And the cells which it specifically infects are endothelial cells, macrophages, and phagocytes. So the bacterial proteins here, okay, bind to certain receptors. These are fibronectin and clathrin dependent endosomal pathway, integrin and syndecan. And after binding to this, the pathogen gets internalized into the inflammatory cells. The inflammatory process takes place at 3 levels. First is the eschar. So at the site where the bacterium first or the rickettsia first get inoculated, it infects the dendritic cells, it multiplies there, causes local necrosis, and spread also via the lymphatics to the lymph node, and then there is a hematogenous spread. The next part of the body to get infected is endothelial infection. And this is what gives rise to the vasculitic features like the typical rash which we find in scrub typhus. It also infects inflammatory cells which release cytokines and which are responsible for the systemic inflammatory response syndrome. In terms of clinical features, the commonest feature will be fever with a rash. There is also a plasma leak syndrome which is responsible for pleural effusions, thrombocytopenia. In terms of organs, the lungs are the ones which are most commonly affected, followed by liver and spleen, and less commonly affected are kidney and brain. This infection is also can cause myocarditis and meningitis. In terms of lab features, often there is leukopenia, thrombocytopenia, mild elevation of liver enzymes, X-ray may show pleural effusion, and CSF examination in patients with severe headache can show aseptic meningitis. The other infection that I want to bring up now for discussion is leptospirosis. So leptospirosis is caused by a spirochete, and it enters through some wound or mucous membrane in the body, and there is a phase of leptospiremia. During this, the organism goes and infects the intercellular spaces and parenchyma of the liver and kidney. It does not infect the cells of the hepatocytes or the kidney epithelium, but it lies in the intercellular parenchyma. The main pathogenic product here is endotoxin. Okay, and the manifestations occur in 2 phases. There is first the leptospiremic phase, which lasts for 3 to 7 days. And during this, there are more of generalized symptoms. And this is followed by an immunologic phase, which can last for up to 2 to 3 weeks, which is characterized by organ dysfunction. So the pathogen-associated proteins bind to various receptors. So the receptor for leptospirosis, the leptospira endotoxin is TLR2, which is different from TLR4, which is common in other bacterial infections. And this releases various cytokines and causes inflammation. The leptospira and their antigen in the liver and kidney can cause endothelial dysfunction by the same mechanism as in malaria. And this will cause extravasation of immune cells from the circulation to the organ. So later on, there is an immune reaction which is responsible for the classical Wales disease, which is hepatorenal syndrome or the hepatopulmonary syndrome. The clinical features are fever, rash, subconjunctival hemorrhage, thrombocytopenia in the initial phase of leptospiremia, along with the mild derangement of coagulation. And organ dysfunction is classically hepatorenal syndrome. So the liver and the kidney are maximally affected. The next to get affected are the lungs, and classically you can get pulmonary alveolar hemorrhage in addition to the features of ARDS. Lab features, the WBC count is normal or increased. There is thrombocytopenia, there is altered liver function tests, coagulation tests, acute kidney injury, which is usually non-oliguric, and ARDS with pulmonary hemorrhage. Some patients get myocarditis and aseptic meningitis also. Now, the last part of my talk is going to be about what happens to CRP and PCT, which are common diagnostic tools which we use to identify patients with bacterial sepsis. So there is this large study from Southeast Asia, Okay, 1,372 patients from Cambodia, Laos, Thailand, Myanmar border. Of these, 267 had mixed infections, so they excluded them. So 1,105 patients with a single diagnosis were studied. The PCT and CRP levels on admission were estimated. So the table on the left shows you the various diseases. The first three, dengue, Japanese encephalitis, and influenza, were viral infections, followed by rickettsia, leptospira. Bacteremia is like the other typical gram-negative bacterial sepsis, and then malaria. Okay, so we can see that how many or what percent of patients had a PCT more than 0.5. So in the three viral infections, the highest was 32%. In rickettsia and leptospirosis, it was 53 and 65% respectively. And bacterial infections and malaria, more than 70% had PCT values more than 0.5. The same is shown on the graph on the right. So we can see that the viral infections had near normal PCTs. In contrast, rickettsia and leptospira were something in between. And bacterial infection, we are already familiar with. Interestingly, malaria, the PCT value was almost the same or maybe even slightly higher than what we see in bacterial sepsis. So to conclude my talk, notable differences from bacterial sepsis are that malaria, dengue, and rickettsia are intracellular pathogens. Okay, the common organisms which cause sepsis, like other gram-negative bacteria like E. coli and Klebsiella, Pseudomonas, and Leptospira, are mostly extracellular organisms. All these, including the virus, rickettsia, and protozoa, which cause tropical infections, can cause sepsis as per the sepsis 3 definitions. So, what are the main differences between tropical infections and bacterial sepsis? In tropical infections, the endothelium bears the brunt of the damage. Okay, as a result, increased capillary permeability is a classical feature of all the tropical diseases, giving rise to third spacing of fluid, hypotension, and effusions. Adherence of platelet to the damaged endothelium, giving rise to thrombocytopenia, is another hallmark of the various tropical infections which we commonly see in India. Because of this, there will also be hemorrhagic manifestations, which will be seen in the mucous membranes or petechiae in the skin or pulmonary alveolar hemorrhages. Liver involvement is more common in tropical infections as compared to classical bacterial sepsis. Rash and myocarditis are also more common in tropical as compared to bacterial sepsis. And lastly, PCT is as high in bacterial sepsis in rickettsia, leptospirosis, and malaria. But in dengue, it can be normal. And finally, prognosis is much better in tropical infections than in classical bacterial sepsis. So friends, this in short is the main differences between classical bacterial sepsis and sepsis in tropical infections. Thank you.
Thank you, sir. Thank you. Thanks for enlightening us on the tropical infections and the treatment strategy and the identifications. Now, moving ahead, I welcome Dr. Palepu Gopal from Hyderabad, who is the head of the department from critical care medicine at Continental Hospitals, Hyderabad. We'll hear from him regarding the guidelines, the use of SOPA score, whether it is really useful. Over to you, sir.
I thank the Sepsis Forum of India organizers for inviting me for this talk to share my viewpoints on QSOPA and its relevance in current critical care practice. The QSOPA has evolved as a quick tool to diagnose, prognosticate, and take sepsis where we want to take the patient and what we want to do with it. Now, we all know that the surviving sepsis, what happened? Why it's not going forward? Yeah, we all know that the surviving sepsis guidelines of 2016 have evolved the latest definition of sepsis, and from there skimmed off the QSOPA from the broad SOPA score. Today, we want to discuss the QSOFA in these outline forms in the coming 10 minutes or so. In Q3, in Sepsis 3 conference, sepsis is defined as a life-threatening organ dysfunction caused by dysregulated host response to infection. But this was not supposed to be enough to rapidly diagnose sepsis and take the diagnosis of the sepsis and triaging forward. So to clarify this, what Derek Angus has done, he came up with this concept of zone of rarity. In zone of rarity, there has to be a gap between various phenomena of a disease. In the disease called sepsis, this zone of rarity was not seen, and there's a huge overlap between organ dysfunction, health, uncomplicated infection, and sepsis. So Derek Angus and Seymour together came up with this instrument of application of a framework to measure the validity of a predictive score or a diagnostic score, which is QSOFA. They heavily relied upon the predictive validity of phenomena seen in sepsis, applying these six criteria to the SOFA score and skimming off QSCOPA from it to apply to clinical care, research, surveillance, and quality improvement. When they did this, basically, three things came up prominently, which is altered mental status, fast respiratory rate, and low blood pressure. And they chose this to see that whether QSOFA is useful and why is it useful. While QSOFA diagnosed only 1 in 4 infected patients, 2 or plus more QSOFA points could predict 3 out of 4 deaths, that is 75% mortality. But was this true? Further research has seen to validate this. Seymour himself has analyzed 1.3 million patient records and skimmed off about 148,000 suspected infection cases from it and divided into derivation cohort and validation cohort and confirmed that QSOFA score can be skimmed out of this to prognosticate, diagnose, and triage sepsis score. When he further validated the score with area under curve concept outside and inside ICU, in ICU encounter, you could see that SOFA has scored under area under curve much superior to QSOFA and LOTS scored the highest. But in non-ICU circumstances, QSOFA has shown its strength to say that among ICU encounter suspected infection, the predictive validity for in-hospital mortality SOFA was not significantly different than the more complex LOTS or SIRS, supporting its use in clinical criteria. Among the encounters of suspected infections outside ICU, the predictive validity of in-hospital mortality of QSOFA was statistically greater than SOFA. So the difference between SOFA and QSOFA came to fore further in further studies. For example, in this study by Rudd et al. In low income group and high income group countries. Why this study was done? Because in low income group, the resources of point of care or the other lab criteria are not very available. So when they put it under area under curve, you could clearly see that the QSOFA score identified infected patient at risk of death beyond the explained by baseline factors. Probably this is where the QSOFA's importance lies. Now, in an emergency department validation study done by Henning et al. In sepsis 3 and septic shock patients, you can clearly see that QSOFA could diagnose lesser number of patients who were either died or who survived. When these two were compared to either old sepsis or severe sepsis, QSOFA detected 21% fewer patients with infection who died during hospitalization compared with SARS. Of course, we are not using SARS anymore, but SARS is part and parcel of severe sepsis and old sepsis guidelines. The impact of sepsis to be seen, impact of sepsis 3 definition on ICU admission in patients was also examined in the study by Klimpel et al., where the SCOFA score was better predictor of ICU admission, whereas the predictive value of blood lactate was unequivocal. That means in the point of care criteria, instrumentations that are available in forms of lactate, etc., it individually did not improve the QSOFA prediction of ICU admission. The prognostic accuracy seen by Freund et al. In a emergency department was further analyzed, and you could see that basically among patients presenting to emergency department with suspected infection, the use of QSOFA resulted in greater prognostic accuracy for in-hospital mortality than the SARS and severe sepsis. These findings provide support for the sepsis definition of sepsis 3 definition, especially in emergency department settings. One, what does QSOFA do to pneumonia? Basically, pneumonia severity score. There are two objectives in the Italian study done by Spagnello et al. The first objective was to compare the performance of QSOFA and CURB65 in the prediction of mortality in the emergency department presenting with CAP. The second objective is to study patients who required critical care support, that is CCS, and ICU admission, whether it would predict CCS at all. When you actually see this, QSOFA is a valuable score for prediction of mortality in the AT in the emergency department and for the prompt identification of patients with CAP requiring critical care services. The importance of QSOFA as a predictor in CAP in emergency department came forth with this particular study. But when you added CURB65, which is a traditional score for CAP, to it, the QSOFA strength further improved and became more predictable. The sensitivity of QSOFA was also calculated as a triaging tool during emergency department in rapidly advancing identifying sepsis. They tried to evolve something called triaging QSOFA and went on serially measuring QSOFA. The statistics are a bit complicated for the short length of my presentation, but here these data suggested that QSOFA cannot be relied upon to identify sepsis patients at high risk of death, even though it is done at a triage and serially during the stay in ICU. It could not identify the patient who would deteriorate or die or go to ICU in this particular study. In a comparative prognostic accuracy of sepsis scores in adults with suspected infection in both ICU and non-ICU circumstances in academic public hospital, you can see the performance of QSOFA versus SOFA. The mortality prediction, definitely SOFA performed well. In ICU mortality, again, SOFA predicted better than QSOFA. In non-ICU mortality, again, SOFA could predict the mortality better than QSOFA. So SOFA, which has got larger components in its construction, was definitely performing consistently superior to mortality prediction, ICU mortality prediction, and non-ICU mortality prediction. In this background, there was a very significant doubt about the QSOFA's usefulness in both ICU and non-ICU. But when they compared SOFA score to SIRS, QSOFA plus lactate criteria in diagnosis and prognosis of sepsis, it could clearly see that the SOFA score had a high sensitivity and negative prediction in the diagnosis of sepsis in the emergency department and in-hospital mortality estimation, and SOFA was again highly capable. Again, SOFA stands out, the bigger brother of QSOFA. SOFA again stands out as more capable of predicting these problems. Now, if you go for QSOFA assessment as a prognostic factor in infected patients outside intensive care studies, and you put all the studies together and do a meta-analysis as it was done by Liu et al. In Internal Emergency Medicine Journal in 2019, some significant facts come out. They come out saying that the sensitivity of this particular instrument, QSOFA, is low, though the specificity is high. And in conclusion of this meta-analysis found that QSOFA showed a poor performance in predicting mortality of infected patients outside ICU, especially in ED. But when it was combined with SIRS, which we have carefully taken out from the sepsis 3 definitions, the strength of QSOFA evolves. What the following few slides I'm trying to show is that QSOFA alone may sound weak, look weak in predicting or prognosticating. But when you add something to it, like SIRS here, or maybe a point of care later, the strength of QSOFA may increase. So the QSOFA again showed as a poor predictor, and another systemic review done by Lowe et al. When they put all the studies together, except for the Seymour study, which has shown a high area under curve value, other studies could not perform very well. In this study, the group found out that QSOFA is not clinically useful prognostic indicator for hospital, in-hospital, or 1-month mortality or ICU admission for all comers across the spectrum. So this was very disappointing. When they tried to predict in-hospital mortality for a sepsis comparison in QSOFA and modified QSOFA, this is what I'm coming to. When we say modified QSOFA, you're adding some other element to QSOFA. Here they added SpO2 versus FiO2 ratio and divided into 3 particular zones. They could see that performance has actually improved. So when MQSOFA, as they call it, when the score was more than 2, provided a better definition of patient outcome in terms of hospital mortality. This is total ICU and non-ICU hospital mortality. To augment all these things over the last few years, though the debate has ranged upon whether QSOFA itself is a ready-to-use tool either in emergency or in the wards, which is called floors in US, or in the ICU. The answer is unequivocal. We don't have a clear answer. So people went on adding. Our team also has actually developed something called CalQSOFA, in which we added creatinine, age, and lactate to QSOFA and tried to see the mortality in emergency. And if you look at our area under curve, our CalQSOFA, SOFA plus, QSOFA plus as we call the red curvature, has shown better results or equivocal results with Apache 2 and SAPS 2. Apache 4 and SAPS 2. So where do we stand with QSOFA now? Is it still useful? What are our conclusions? For pure diagnosing of sepsis, QSOFA may not be a great instrument. For predicting mortality in ER, the studies are unequivocal. For predicting ICU mortality, the studies are again unequivocal. In our study, we could show equanimity with other standards like SAPS and Apache 4. For triaging in ER, it doesn't prove to be, I showed you the triaging and consequential study. We could not prove that QSOFA is very useful tool. As an early warning score that sepsis is going to onset, not again. For diagnosing pneumonia, yes, the CAP study has shown that for diagnosing and predicting pneumonitis mortality, it may be a useful tool. And as far as the COVID is concerned, a lot of studies are ongoing, data analysis ongoing. Couple of small studies have come out saying that it may not be a great tool in prognosticating the outcome of COVID-19. So in conclusion or in conclusive, evaluation along with point of care test, lactate and other parameters may make SOFA more practical. We have to add something to QSOFA. That means QSOFA alone may not be very strong in this particular scenario. In resource limited setting, the low income group, middle income group country study I have shown, it may be useful tool by point of care device added or non-added. But in other wealthier hospital and wealthier studies, it may give an indication to rapidly step up to other level of care, other level of investigation. On these questions, the jury is still out. Several data analysis and several studies have to be ongoing with QSOFA with or without point of care or an additional weightage to QSOFA to see whether QSOFA is still useful. So unfortunately, the question still remains, is QSOFA still useful? I cannot say with emphaticness that yes, but yes, it can be used as a primary tool with or without additions of the further tools. Thank you for giving me this opportunity.
Thank you, Dr. Gopal, for wonderful insights on using the QSOFA score. What an year it has been, 2021. I welcome Dr. Om Srivastava for knowing about year in review in sepsis. Over to you, sir.
Good evening to everyone. I am going to be speaking upon the year in sepsis. What is it that we have seen? What is it that we have learned? And what is it that we are likely to be anticipating in the time to come? My name is Om Srivastav. I practice infectious diseases and immunology. Okay, I'm going to be touching on some of the issues that have become relevant and important at this time in the understanding of the pathophysiology and treatment of sepsis. We all know that the core of what happens after the initial infection becomes bloodborne, and that becomes septicemic. We are aware as to what happens at the most important part of the circulatory system, but we know now, at least more in the last year's time, maybe, is that the smallest parts, which is the alveolar, the capillary, I'm sorry, the smallest blood vessels at the end organs are the ones that get affected. Now, as you can see here, there is the genesis of microvascular obstruction, microthrombi, and the activation of leukocytes that leads to one process that gets really fulminant in the process of as sepsis goes on. So we were familiar as to the leak that comes at the microvascular level. But this is something that is recent in the most recent publications that have come in the last year's time. This is an example. This is sepsis on the endocardium, but this is an example only as a demonstrative slide. This is what happens in every organ, whether it is the kidneys or the liver or any other organ that is involved in sepsis. Delivery of the consumption and the utilization of oxygen, that is abnormal. Yes, we are aware of that. But the preserved blood flow, heart rate, O2 consumption, both increase. The reactive oxygen species, that is most importantly the nitric oxide, that also goes through a gigantic jump and increase. There is endothelium leukocyte interaction. Now, this is where the biggest body of evidence has been presented in the last year's time in the world literature. The total amount of endothelial dysfunction that comes out of sepsis, that leads to an enhanced leukocyte, especially the net, and I'll talk about that in just a minute's time. The neutrophil in the peripheral part of the patient's circulatory system that gets either captured or destroyed. And it is not enough to simply say that we've done a CBC or a culture and that we found that this is what is abnormal. I think it requires a far more detailed kind of evaluation, because it is something which is the key in not only in understanding pathophysiology and the immune responses of sepsis, it is also responsible. It's also going to be responsible for most treatments that come in the future. Microvascular dysfunction, as I've already mentioned in the previous slides, is the other thing that happens in a big way. So I'm now coming to one of the most important, well, it's actually a work in progress, but it is something that we have seen more and more with septicemia, and that is the immune dysfunction. Now, that pathway of immune dysfunction is something that goes through multiple channels. There are multiple channels as to what happens with a dysfunctional immune system. I'm not going to dwell too much about that, but there is evidence that the HLA type 1, the human leukocyte antigen, the HLA type 1, not 1 and 2 both, but that is one of the major reasons why the signal amplification becomes very, very difficult, in a way that infections become rampant, and the effect of infections turn out to be such that the microvasculature is disturbed in such a way that it is beyond a point, it becomes impossible to reverse. So as you can see, as I was saying here, as I was saying earlier, there are multiple parts where there is tumor necrosis factor, there is intracellular adhesion molecules, there is the endothelial growth factors. All of them have at some point or the other, will start to get elevated and stay elevated. And that leads to a lot of dysfunction at the level of the endothelium, not necessarily in the big vessels like big arteries and veins, but also at the microvascular levels. If you have a look at the graphs or the bottom part of the slides, it will be that most of the other factors, except for the TNF alpha and the ICAMs, they are mostly acceptable for the initial part of sepsis, but they tend to become really significantly abnormal as the process keeps increasing and goes on. Okay, so this is again a different representation of the things that will become abnormal. So you look at the untreated parts on the left-hand side of the slides, the lipopolysaccharides, the PEPG of the lipopolysaccharides, and the other parts of the LPS. They will all be elevated and get reduced in some way or the other. So this is really a process that is going to be uniform, and it will follow a classic pattern. It is actually undulating. There are times when the basic immune responses of the patient are going to make it a little more controllable, and the times where the immune response fails, it becomes uncontrollable. That's pretty much where we think sepsis is right now. Basically, again, you'd have to look at the stage 3, which is the most important part, and that is after the infection has occurred. Bacteria enters blood, and there is the leaking blood vessels that leads to organ dysfunction and death. It's an oversimplification of what happens, but in essence, this is what is likely to be happening with sepsis. Pardon me. All right, so this is a busy slide, but I'd like to draw your attention only to 2 aspects on this slide. On the left-hand side, you'll be able to see the toll-like receptors and the CD14. These are the 2 parts that are very big. They are responsible in getting a lot of the endothelial dysfunction to get activated. CD14 and toll-like receptors both. Toll-like receptors is something that has been capturing interest for a long time now. But toll-like receptors 4, TLR4, there is a huge amount of work which looks at receptor binding proteins that would work at interrupting the toll-like receptors 4. And CD14 is the CD14 ligand that passes on the cell-to-cell information for other ligands to get activated and start an inflammatory process that in most instances becomes irreversible. So these 2 things are to be kept a close eye upon, because I think that a lot of what we are going to be seeing as treatment in sepsis over the next maybe 2 or 3 years is probably going to be coming out of something that involves these 2 mechanisms. All right, again, a different look at all the things that I've been talking about. After the infection, which is oftentimes a gram-negative infection, which is what we are dealing with. Also, it happens with gram-positive cocci or bacilli, but gram-negatives are the most overwhelming part of sepsis that will suppress the CD14 receptor and activate the toll-like receptor. That leads to a number of things, including the plasminogen activator inhibitor and the platelet activating factor. That leads to coagulopathy and microvascular thrombi, which is where the biggest damage occurs in sepsis. Okay, this is again the net, as I was telling you, which is what needs to be actually looked at as to whether this can be something that will be a therapeutic model of diagnosis and treatment. Certainly, some evidence suggests that net is going to be important for making a therapeutic model. But of course, it's too early. It's much too early because NET again goes through a number of immune processes. It may not always be as simple as the slide shows, that this can stop the movement of number of factors that will make the capillary leak. But it is certainly worth looking at. Something might be coming out of this part. So watch the space, as the Americans would say. And so when it comes to sepsis, do remember, it is about time. All right, to look for temperature, whether it's high or low, whether there is an infection, there are signs of infection, whether there is a decline in the mentation of the patient, whether the patient is confused, sleepy, difficult to rouse, or a patient is severely ill with pain, discomfort, shortness of breath. If you experience a combination of any of these things, seek urgent medical care or go to a hospital with an advocate. Ask whether this could be sepsis. All right, I'm now going to come to the last part of my talk, which is which are the papers that were most widely searched in the last 1 year, the most widely looked at papers, and what do they have to say about what is new about septicemia. So the multi-organ dysfunction syndrome, is this a metaphor or is it an unsolved clinical challenge? It's a bit of both, actually. This is a most recent publication, September of 2021, and this came out of critical care medicine. So as would happen with most evolving conditions, there is some look at redefining what we already know about septicemia. So the multi-organ dysfunction syndrome, whether this should be something that is something else, that's a big area of discussion, but I certainly would like to draw your attention to this, that the multi-organ dysfunction syndrome may actually go into another area because this is now looked at as an unsolved clinical challenge. The Surviving Sepsis campaign, of course, that is probably one of the best guidelines in the management of sepsis and septic shock. This came out far back as 2016, but 17 actually. But this is still a very relevant document. The guidelines for management of septic shock, the septic bundle that we use in our emergencies and ICUs in our hospital still continues to be the gold standard of how to manage sepsis. So this is an enduring paper with very little revision. The syndrome criteria in defining sepsis, the systemic inflammatory response syndrome in defining sepsis, that is again something that got searched very copiously in the last 1 year's time, and that is something which will probably get redefined in some areas where we are looking at some markers that may become significant. But I think we'll have to watch the space for the next maybe 6 months' time, where we should get some kind of a newer definition about some of the things that we have taken for granted. And of course, procalcitonin. I see a lot of my colleagues who will keep sending procalcitonin on a regular basis. Do remember the biggest value of the procalcitonin is in a declining number. It cannot be used as something that should be used for making the diagnosis of septicemia, but it can be used in showing that when there is a declining procalcitonin, it is more a matter of sepsis that is resolving, and that antibiotic therapy may actually be de-escalated or stopped altogether, depending upon what kind of situation you're dealing with your patient. And so what is the future in treatment of sepsis? Is it only antibiotic therapy? Well, it can't be, because we are seeing and learning more and more about what is the immune aspect of septicemia, and we are going to have to pay attention to that, whether we like it or not. We will have to ensure that some part of immunology becomes part of our routine daily day-to-day practice. Immune monitoring, especially your patient's T-cell population, your patient's B-cell, natural killer cell population, complement studies, immunoglobulin studies, all of that are going to be important, because after you have measured those parts of the immune system of the patient and you have restricted a patient's antibiotics, you will need to consider the immunomodulation. So you could tweak the immune response of a patient. If it is not ballistically out of control, you could tweak that in a way that it would probably be helpful in monitoring a patient who is very sick with septicemia. There will be a role of immunomodulators. Already there is, and there'll be a role in the foreseeable future. There is also going to be a role of biologicals. We've seen that with septicemia and COVID, the role of number of biologicals, including Regeneron, but they have to be picked correctly, they have to be timed correctly, and they have to be done with the help of ensuring that you've got the immune dysfunction correctly with a blood test of the patient. So that is probably going to be the other part of where septicemia will be treated in the foreseeable future. And of course, the role of vaccines cannot be overemphasized. The preventive role of vaccines, not just the influenza and the pneumococcal, but another about half a dozen vaccines that people who have had 2 episodes of septicemia in the last 12 months should be offered, should be given, and that is actually going to be going a long way in preventing infections from becoming such that the patient requires to go to ICU of your hospital or be ventilated. I'm going to stop here. I'd like to thank all of you for a very patient hearing, and thank you for giving me this opportunity to speak about this very important topic.
Thank you, Dr. Om, for taking us through the year in review and reminding us about the future. We now move on to next session on more specific, from broad spectrum to the specific categories. We gram-positive infections. I invite Dr. Ayesha Soonawala, who is a consultant in infectious diseases at PD Hinduja Hospital, on newer anti-staph antibiotics. Over to you, ma'am.
I'm Dr. Ayesha Soonawala, consultant ID physician at Hinduja Hospital, Mumbai. and I thank the organizers of Sepsiscon for inviting me here today to deliver this talk on newer anti-staphylococcal drugs. So question is, do we really need new anti-staphylococcal drugs? As per the most recent ICMR surveillance network, staph ranked among the top 10 pathogens isolated from all sites across the country and constituted about a fifth of bloodstream infections and approximately 15% of CSF samples. The overall MRSA rates were approximately 41%, with a near 100% susceptibility to the current MRSA drugs. However, increasing MICs were noted for vancomycin, linezolid, and daptomycin. What then are the desirable properties of an ideal anti-staph agent? Preferably a narrow spectrum agent, so that when we use it as directed cover for staph, there would be limited selection pressure on the individual patient biome as well as the ecology of the institution. One that acts against resistant strains, although we find that this is not a current problem for us, we anticipate it in the future. One that is rapidly bactericidal for these aggressive infections, a drug that achieves adequate tissue concentrations in various sites and tissues where staph can cause infections. Biofilm activity would have to be one of the most attractive properties of such a drug because we know of the strong affinity for biofilm infections. A drug that has a wide therapeutic window as compared to the currently available drugs, and one for which therapeutic drug monitoring would not be required. An ideal drug would be one with minimal toxicity so that it could be used in the prolonged deep-seated infection setting. And clearly, an oral option with good bioavailability to be used at step down would be the most important property of such a drug. A drug that's inexpensive is clearly the need of the hour in our resource-limited settings as well. So these are the newer drugs that we have for staphylococcus, and I'm going to focus mainly on ceftaroline and levonadifloxacin, which are the two drugs present to us and available to us in the Indian market. The other cephalosporins, glycopeptides, oxazolidinones, tetracyclines, and chlorometulins are also options which I will just glance upon briefly. So coming to the cephalosporins and ceftaroline, it's a fifth generation cephalosporin which has reduced beta-lactamase inactivation because of certain structural alterations and enhanced binding to PBP2A. It has a broad spectrum activity, gram-positive, gram-negative. However, there is intrinsic resistance to Enterococcus faecium and the ESBL, AMPC, and carbapenemase producing Enterobacteriaceae, as well as the non-fermenters like Pseudomonas and Acinetobacter. It has activity against resistant strains. It has some interesting PK properties, including bactericidal and long post-antibiotic effect for Staph aureus. Unfortunately, it's available only as an IV formulation. The CLSI current breakpoints give you an intermediate or a dose-dependent susceptibility, which indicates that higher dosing of 600 milligrams 8 hourly as opposed to the usual dose of 12 hourly would be indicated in these settings. Adverse effect profile is similar to other cephalosporins, though there's less risk for C. difficile reported. And a very important finding by this group, both in vitro as well as small studies in vivo, to show that there's increased membrane binding when used in combination with daptomycin, especially for daptomycin non-susceptible MRSA, resulting in enhanced killing, especially in the presence of biofilm. So clearly very encouraging reports and something that would be very useful in complex infections where biofilm is involved. If we were to compare it to the other fifth generation cephalosporin, ceftobiprole, the properties of ceftobiprole are advantageous properties are only for gram negatives and not really for staph or any of the gram positives. The current FDA approval for ceftaroline is only for skin and soft tissue and community acquired pneumonia. And this systemic review and meta-analysis actually summed it up well, that the performance for CAP and SSTIs was similar to comparators in individual studies. However, as they assessed cumulative meta-analysis, they found a lower risk of therapeutic failure with ceftaroline, and this effect size, as you can see from this forest graph, became more pronounced and precise when the sample size increased, and it showed a sustained trend, definitely favoring ceftaroline. Rates of adverse effects were similar, again advantages for ceftaroline. As per the Sentry antimicrobial surveillance, which is a 10-year surveillance globally with thousands of isolates from across the world and approximately 400 isolates from patients with infective endocarditis, of which MRSA were 30%, they found good ceftaroline activity. However, there was some geographic variation, and this geographic variation was most pronounced for MRSA. You can see 98% susceptibility in North America versus only 68% in Europe. This considerable geographic variation has been earlier reported as well and is related to the MRSA clonality. So where do we stand in India with this clonality, and will ceftaroline work for our isolates? So this is a study from the CMC group, Dr. Balaji's group, first author Yamuna Devi, where they looked at 171 isolates. 92% of the staph aureus were susceptible to ceftaroline, although these isolates were mostly from skin and soft tissue, lower respiratory tract and intra-abdominal. It did equally well as vancomycin and daptomycin and had far more potent MICs than linezolid. And you can see here on this bar graph that most of the MIC ranges are within 1, which is within the susceptibility breakpoint for ceftaroline, and lower MICs when it was compared to its comparators. The capture data on the capture data actually captured information even on endocarditis, but we looked at it for its bone and joint infections, where they looked at 150 patients with osteomyelitis, approximately 60% with MRSA, of which a fifth had osteosynthesis or implant-associated infections. Although a majority of these patients received other antibiotics prior to ceftaroline, the cure or improvement was approximately 92%, but this was a very objective-based study based on individual physician assessment. And most importantly, very little can actually be gleaned from the sketchy evidence because the median treatment duration for ceftaroline was only 6 days, indicating that it was usually used after another agent as a step down or an alternative therapy. So still awaiting more data for bone and joint infections here. If we were to come back to that desirable property slide, it fits the bill for all other properties except for the fact that it has a wide spectrum of activity. There are no oral options, and it is expensive in our resource limited setting. The cost of ceftaroline would be approximately 5,000 to 6,000 rupees a day. Moving on to levonadifloxacin, well, a moment to be proud of. This is our first completely indigenous Indian research molecule, which is DCGI approved now. It's a new fluoroquinolone derivative with a wide spectrum of activity against resistant staph strains. It's rapidly bactericidal with a very interesting property of bactericidality at high inoculum as well as acidic pH, indicating that it would be active intracellularly. There is data to show that there is good permeation of biofilm matrix. Matching PK profile of an oral option makes it excessively attractive. The oral option has an excellent bioavailability, and there's apparently superior safety profile compared to other fluoroquinolones with no QT prolongation or phototoxic potential, etc. Important to note here that the CLSI has given MIC quality control ranges, but there are no breakpoints provided by the CLSI or the UCAST for this agent, which would enable us to say at an in vitro level whether this drug is susceptible or not for our isolates. Again, another study as recently as 2020 from Dr. Balaji's group in CMC Vellore, which compared levonadifloxacin with the comparator antibiotics using broth microdilution, and you can see how well it fared. Look at the MIC ranges of levonadifloxacin as compared to levofloxacin, vancomycin, Tike, linezolid. And they attributed this potency to its distinctive mode of targeting DNA gyrase as compared to older fluoroquinolones that preferentially targeted topoisomerase 4. Was found to be 16 times superior to levofloxacin. DCGI approval is only for acute bacterial skin and soft tissue infections and diabetic foot with bacteremia, and this was based on a phase 3 multi-center randomized trial where the clinical primary objective was met, that levonadifloxacin was non-inferior to linezolid for the treatment of skin and soft tissue infections. But encouraging data, but we still await more evidence on this agent. Again, fits the bill with most of these things. Clearly more evidence required for adequate tissue concentrations and perhaps more real world evidence on biofilm and toxicity and stuff. But otherwise, it has a wide spectrum, And again, even the oral option is rather expensive, similar to ceftaroline on a daily sort of dose. Moving on to the glycopeptides, these are semi-synthetic derivatives of naturally occurring glycopeptides, and they have a lipophilic side chain which increases their potency and half-life period. Approval is only for skin and soft tissue, HAP, VAP. They have favorable dosing intervals where you can see telavancin has been used OD, dalbavancin recommended weekly, and oritavancin even as a single dose. Ongoing RCTs are on for osteomyelitis and infective endocarditis, and early results are encouraging. Importantly, they don't require therapeutic drug monitoring. Tedizolid is the new oxazolidinone derivative, which has this hydroxymethyl group, which helps it preserve activity against linezolid-resistant organisms. It's available as a once daily dosing, found to be non-inferior to linezolid and other MRSA drugs for skin and soft tissue infections. It is expected to work like linezolid for mycobacteria and nocardia as well, but there's no real-world evidence of this. And most importantly, as compared to linezolid, as an oral option, it has a favorable adverse effect profile with reduced myelotoxicity and mitochondrial toxicity, and this would make it advantageous for prolonged use. So to summarize that, we know that our MRSA rates in India are more than 40% and slowly rising. However, our actual rates of visa and VRSA are still low. We must remember that for all these agents, there are no comparative studies done with conventional MSSA drugs. And so for MSSA, the MSSA drugs are still considered to be, the first generation cephalosporin, cloxacillin are still considered to be superior to the MRSA agents. We need workhorse drugs for deep-seated biofilm infections, ones that we can use for prolonged periods, and this is really the most important unmet clinical need. Most newer drugs are currently approved for only skin and soft tissue and CAP. The evidence for use in bloodstream infections, infective endocarditis, and bone and joint infections is still weak. Some of the drugs have a favorable PK profile and an adverse effect profile, which make them interesting options to look out for. However, an inexpensive oral step-down option is really the need of the hour and doesn't seem to be here as yet. Thank you.
Thank you, Dr. Aisha. Now, as we are knowing for the limited armamentarium about gram-positive antibiotics and for the MRSA, which will be the better choice between vancomycin, teicoplanin and linezolid. I welcome Dr. Suresh Ramasubram from Kolkata, who is a senior consultant in pulmonary and critical care medicine at Apollo Clinical Hospitals. Over to you, sir.
Hi, hello everybody. The topic that I was chosen to speak on is antibiotic choices for MRSA pneumonia. And we've had this whole session is on MRSA, so I'm going to be brief, and we have 10 minutes to decide on the choice further between glycopeptides and oxazolidinediones, that is linezolid. All right, so moving on, let me just put it in a slideshow here. All right, so we all know that pneumonias are community-acquired or nosocomials, which can be hospital-acquired or ventilator-associated pneumonia. The term healthcare-associated pneumonia is no longer used. It's a retired term. But leaving aside the definition, the etiology of these pneumonias, especially community-acquired pneumonia, if you look at staph, it's only in the community-acquired pneumonia, it's only about 2%. So it's not a very common cause of pneumonia in community-acquired pneumonia. But when you come to hospital-acquired pneumonia, especially in patients with risk factors for multi-drug-resistant pathogens, MRSA becomes a significant problem in a majority of the, in a significant proportion of patients. What is MRSA? We will go through this many times. It is methicillin-resistant staph aureus, and the characteristic is the presence of the MEC gene. So if you have a biofile, if you have a staph aureus, you will see this MEC gene. You don't even need, that tells you that methicillin resistance will be there. And the CLSI guidelines point at greater than 4 microgram per ml as the minimum inhibitory concentration as resistant, and less than 2 as susceptible, and in between as intermediate. While we no longer use methicillin, and we are using only oxacillin because methicillin is no longer commercially available. but the term MRSA somehow has still stuck to it. It's no longer, it's not called loxacillin-resistant Staph aureus. It's just it's too cumbersome to change it. All right, what happens when you have a methicillin resistance? Basically, you have a PBP2A, penicillin binding protein is encoded by the MEK-A gene that permits the organism to grow and divide in the presence of methicillin and other beta-lactam antibiotics. So this MEK-A gene is obviously located on a mobile genetic element called the staphylococcal chromosome cassette, and this can be transferred from one organism, one Staph aureus to another. So this is the mechanism of the MRSA production, which confers it resistance to being hydrolyzed by beta-lactam antibiotics, and that makes it more sturdy and ability to survive in various environments. And since the introduction in 1961 of methicillin, MRSA has quickly followed in about a year's time. If you look at MRSA cap, when do we suspect in cap? 2% of cap is only staph, and of that, when do we suspect MRSA? Is if you have a suspicious gram stain, failure of conventional therapy, pleural-based lung nodules, or cavitary lung lesions, then you suspect MRSA in a community-acquired pneumonia. Again, if you look at the incidence in patients with CAP, MRSA is only about 3%, who in majority in the big studies, and among all Staph aureus isolates, 51% are MRSA and 49% are MSSA. So 1.7%, 1%, that is the incidence. So Staph is not a major player in community-acquired pneumonia, as I just mentioned. If you look at our data from the Moser study, you find that again, as Staph is about 5% of the organisms causing VAP in our country in a majority of the private tertiary hospitals. If you look at my institution, Staph is about 3%. Of this thing, and amongst these, the 3%, 48% of the staff are going to be MRSA. So the risk factors for MRSA is that if you're in a unit like mine with more than 20% of the Staph aureus are methicillin resistance, you need to be, or if your unit don't know what is the prevalence of MRSA, you have to assume that whatever staph is there is going to be MRSA. That is the general assumption that we assume needs to be done. So the treatment is just what is the main topic is that what do we do for treatment? So if MRSA is a frequent nosocomial pathogen in the institution, that means you have more than 20% local prevalence amongst the Staph aureus. We're not talking about the entire Staph aureus, this thing. So as I showed you, 3% of my hospital-acquired pneumonia are because of staph, and out of that 48% is because of MRSA pneumonia. So in my institution, if I probably would need to cover it empirically because the organism is not very common, but yes, if you're worried about covering everything early and then de-escalating, then yes, 3%, and then I need to cover MRSA. So what are the choices that we have? We have glycopeptides, linezolid. We don't have tigecycline as this thing is a black box warning for it for the doses at which it's been approved. Clindamycin, minocycline, and the newer antibiotics, which is also a talk we're talking about. I'm going to restrict myself to the vanco, tyco, and linezolid debate as to which one to use when we have an MRSA pneumonia in the picture. So vancomycin and teicoplanin are the two main glycopeptides in the Indian market. The other newer ones are still not available. They are all cyclic glycosylated peptide antimicrobials that inhibit the synthesis of peptidoglycan by binding to the amino acids in the cell wall and prevents the addition of new units. They're hydrophilic antibiotics, and their pharmacodynamics depends on both concentration and time. And the PKPD is an AUC over MIC. They have a renal clearance, and therefore all these factors, the hydrophilic nature, the renal clearance, the fact that the PKPD is AUC over MIC, all these makes very difficult to dose vancomycin or teicoplanin without actually therapeutic drug monitoring. So the recommendation for vancomycin dosing is 20 to 35 milligram, and then a maintenance dose of 15 to 20 milligram per kilogram every 8 to 12 hours. And this is on actual body weight, and to a maximum of 3 grams. And the subsequent dose is based on, especially for AUC guided, if you have severe infection, or most of the best thing that we can do in our country is to get a trough guided serum concentration monitoring, which is also TDMs for vancomycin is not very easily available, and majority of us don't practice that. If you look at teicoplanin, the low dose regimen for non-severe sepsis is this much, which is about 6 milligram per kilogram, maximum of 400. But for severe sepsis, severe skin and soft tissue infection or bone and joint infection, or with sepsis with bacteremia, the British guidelines would say 12 milligram per kilogram, maximum 800 milligram every 12 hours for 4 doses. And then the subsequent maintenance dose depends on your creatinine clearance. And then further dosing monitoring obviously again depends on the trough level. Again, as we said, we don't have therapeutic drug monitoring to do those things. But otherwise, we do empiric drug dosing. A majority of the time, we do the 6 milligram per kilogram teicoplanin dosing rather than the 12 milligram per kilogram, even when we have sepsis. But in case of pneumonia, without bacteremia, probably we can get away with a 6 milligram per kilogram dosing is what we assume, but we don't know. So if you look at teicoplanin versus vancomycin, there are plenty of studies. The main difference is the nephrotoxicity, and the rate of nephrotoxicity varies at the trough level. As your trough level increases, your nephrotoxicity increases. And since we don't measure the trough levels, it becomes difficult to say. If you look at a systematic review of vancomycin-induced nephrotoxicity, again, as it clearly increases with the level in trough levels, depending on various studies, anything above 15 to 20 milligram per liter, the trough levels, the vancomycin-induced nephrotoxicity is higher. So if you use the newer AKI criteria, then the rates are even much more pronounced, especially in ICU admission with the trough levels being high. So your earlier and even nephrotoxicity rates are much more prominent, and it can even up to 30% of patients with the newer AKI definition will have, especially when the trough levels are high, would be more than 15 would have nephrotoxicity, especially in ICU admission. So it is a significant issue. So if you look at vanco versus teico, the nephrotoxicity is significantly a difference, 92 per 1,000 for 61 per 1,000 for teico versus vancomycin. And so it is better tolerated. Total adverse events are less, and the Redmond syndrome is obviously much less with teicoplanin. So teicoplanin is not inferior with regard to efficacy associated with a lower adverse event than vancomycin. So maybe in a situation where you have both the glycopeptides available, teicoplanin may be a better glycopeptide. If you look at clinical cure rates, there's no difference. If you look at microbiological eradication, there's no difference. So as a result of which, teicoplanin versus vancomycin, the side effect profiles probably slightly favors teicoplanin. But both require therapeutic drug monitoring, and both require proper actual body weight dosing. All right, so the next one is obviously oxazolidinons, that is linezolid, which is also a bacteriostatic drug which binds to the 50S subunit of the bacterial ribosome, inhibits bacterial protein synthesis, and they are used for treatment of patients with MRSA and VREs. And their PKPD is AUC or MIC, but the good thing is that there are non-renal clearance, making the dosing much more easier. And the main adverse effect is myelosuppression. So, of course, we have seen this in MDR-TB. We use this in long term for MDR-TBs, and we don't see that much of myelosuppression at the doses even for MDR-TB. So, yes, it is a concern, but and that maybe even with multifactorial thrombocytopenia. And those situations, thrombocytopenia is probably the more common side effect that we see. You can get lactic acidosis, and you can have a serotonin syndrome, and you have a concomitant SSRI ongoing. If you compare linezolid versus glycopeptide, there's no difference in clinical cure rates. They're about the same. And this we are talking about nosocomial pneumonia. Please remember, I'm not talking about any difference in bacteremia, which will be covered in the next subsequent lecture. So linezolid is better for microbiological diagnosis, eradication, but there's no difference in clinical cure rates as per this meta-analysis. But if you look at another meta-analysis, again published for MRSA pneumonia, linezolid is not superior to clinical, to vancomycin for clinical cure, no difference in microbiological eradication rate. So again, linezolid is not superior to vancomycin with respect to both clinical and microbiological cure rates. Again, another systematic review published in BMJ, no drug is superior for HAP, similar efficacy and safety profile. So really, there's not much of a difference between linezolid and glycopeptides as far as clinical efficacy, microbiological eradication, and the safety profile is concerned if you dose it properly. So how do we differentiate and how do I select, which is probably the most important question that we have to answer during this talk, is the selection based on other factors. It's not depending on clinical cure, it's not dependent on microbiological cure, it's dependent on renal function, it depends on monitoring convenience, do you have TDM, it depends on potential drug interaction interactions, what's your blood cell counts, you're already myelosuppressed, what's your quality of intravenous access. So for as an example, when all of the factors are equal, that means you don't have renal dysfunction, you don't have potential drug interaction, generally we would prefer linezolid to vancomycin in patients with limited intravenous access or difficulty achieving the therapeutic serum concentration because of dosing issues or lack of TDMs. And we prefer vancomycin to linezolid in patients receiving SSRIs or for patients with cytopenias. So that's the quick nutshell for all that we're talking about is MRSA pneumonia is rare, and when we are between the choice between the glycopeptides, as I said, ticoplanin may have a better side effect profile than vancomycin. So probably it is okay to dose to use glycopeptide. Ticoplanin is a preferable this thing, but this if you dose vancomycin properly, there is not going to be a problem. All right, so the summary is basically MRSA pneumonia is an emerging concern in HAP and VAP in our country, but the data that I have from my unit and data from most of the Moser study is that HAP and VAP, the MRSAs, the staph aureus is still only 3 to 5% of the problems of pneumonias, and out of that, majority of us would have anything greater than 20% incidence of staph aureus, 50% in my institution, and so on and so forth. So as a result of which, if I worried about staph, I need to cover for MRSA. And both glycopeptides and linezolid are equipotent for clinical cure. So it's the patient profile, as I said, about use of SSRIs, myelosuppression would make me choose glycopeptide. No such thing, I would choose glycopeptide, linezolid. So these are the issues that is simple, only valid only for pneumonia. That's my disclaimer. And obviously for bacteremias, the next couple of talks will be talking on those things, and I'll leave it up there. Thank you very much for your kind attention, and hope I was able to finish in 10 minutes the allotted topic. Thank you.
Thank you, Dr. Suresh, for taking us to the our own armamentarium. Now, after knowing the newer antibiotics, newer anti-staph antibiotics, and about these available antibiotics, what will be the empirical antibiotic choice for suspected staph bacteremia? I invite Dr. Neha Gupta from Delhi, who is an ID specialist, ID physician, and working at Fortis Memorial Research Institute. Over to you, ma'am.
My greetings. First of all, I'm extremely thankful to the organizers of Sepsiscon for inviting us here. And I'm going to discuss regarding the empirical antibiotic choice for suspected Staph aureus bacteremia. Staph aureus bacteremia, as we all know, carries almost a mortality of 50 to 50% in various studies, especially if the patient is presenting with sepsis or with persistent bacteremia more than 7 days. So it's very important to initiate the appropriate empirical antibiotic therapy at the earliest. Coming to the burden of the Staph aureus bacteremia, and this is the data from down south, where, as we all know, that besides its gram negatives are the most common cause of positive blood culture isolates, but it is the Staphylococcus aureus infections which account for significant burden as well. It's close to 10% of all the positive blood culture isolates, and even in our center, the Staphylococcus aureus contributes to close to 4 to 5% of all the positive blood cultures. But when we look at the absolute numbers of the total positive blood cultures of close to 5,500, the total Staph aureus positive blood cultures have been around somewhere around 220 in the year 2018. So which is a significant burden. For improving the isolation of Staph aureus bacteremia and the blood cultures, it's very important to send the blood cultures in the appropriate volume, and this should be done before the antibiotic therapy. And of course, it's clean collection, which is of paramount importance, and most of the Staphylococcus aureus grows within the first 24 hours. So when a blood culture is growing a GPC, we need to request a microbiologist to ask whether it's a GPC in chains or it's in clusters, because if it's GPC in stains, there is a possibility of streptococci, enterococci, whereas if it's GPC in clusters, then there is a possibility of cons or Staphylococcus aureus. Cons is a common skin contaminant. Single blood culture is a likely contamination and need not be treated. However, Staphylococcus aureus, a single blood culture is significant. And when we look at Staphylococcus aureus blood culture, Most important is to next step is to look at the oxacillin sensitivity. Oxacillin resistant will be a MRSA, and of course we need to do cefoxitin to avoid any heteroresistance. Now coming to the approach of Staphylococcus aureus bacteremia, most important is when do we suspect that the patient is having a Staphylococcus aureus bacteremia. Next is whether the patient is going to have is likely to have a MSSA or it's likely to have a MRSA, because the antibiotic choices for both of them are different. Next is then where is it coming from? Whether it's coming from the skin and soft tissue, like from the boils, furuncles, from the nasal carriage, or it's coming from the line in a patient who is undergoing hemodialysis, and where exactly it's going, whether it's going and seeding into the joint to the heart valves, which will help us in determining whether it's a complicated or it's an uncomplicated bacteremia, because this has implication on the antibiotic choice, source control, as well as the duration of therapy. For uncomplicated bacteremia, the duration of therapy is 14 days after the first negative blood culture, whereas for complicated, which is involving the bone and joint or the endocarditis, the duration of therapy is longer, for 6 weeks. And of course, source control becomes very important wherever there is a pus collection or there is a high inoculum infection. Again, the prior antibiotic exposure as well as the response will help us in deciding the choice of therapy. If the patient has taken prior vancomycin, teicoplanin, and it's not responding, and if it is MRSA, there is a possibility of using some newer agents like daptomycin, ceftaroline as well. Now, when do we suspect? This table briefly summarizes the probability of MSSA, community-acquired MRSA, or a hospital-acquired MRSA based on the population affected as well as the site of infection. So from the community, it's MSSA or CA-MRSA, which is likely, whereas from the hospital-acquired MRSA is more likely to be in patients who are exposed to nursing homes, prolonged hospitalization, CKD patients, undergoing with a central line, dialysis catheter, immunocompromised patient. Site of infection, hospital-acquired MRSA is to be suspected if the patient presents with acute onset fever, chills, rigors in the population which has been just mentioned, and whereas community-acquired MRSA is more likely to present with necrotizing infections like skin and soft tissue infections, abscesses, shock because of the severe toxin production, pyomyositis, necrotizing pneumonias, and of course, bacteremia. And if it is an MSSA, then it's usually abscess, furunculosis, then subsequently or leading to bacteremia, pyomyositis, sudden onset severe bone pain, endocarditis are the complications. Now, if the risk factors for the MSSA would be a patient who is having diabetes, or if it's a patient who has got dermopathy, dermatitis, psoriasis, where they are predisposed for spontaneous bacteremia with the Staph aureus, whereas CMRSA is usually suspected in the community as well in patients with some poor hygiene. And there is a high prevalence in certain parts of India of the CA-MRSA. And as I just mentioned, HA-MRSA, its indwelling devices, wounds, prolonged hospitalization are the risk factors. The antibiotic susceptibility, if once we have the report, that can give us a clue whether it's a CA-MRSA or a HA-MRSA. Susceptibility to the older antibiotics will be suggestive of CA-MRSA, whereas most of the HA-MRSA will be resistant to the other drugs like the TMP, SMX, doxy, or clindamycin. The PVL production is more than 95% in CA-MRSA, where it's lesser in case of HA-MRSA as well as MSSA. And this has implication on the choice of therapy, as we need to then add a toxin synthesis inhibitor like a clindamycin or a linezolid. Now, it's very important to know where exactly it is going, because this also has an implication on the empirical antibiotic choice. For example, if there is an endocarditis, which is possible in close to 20 to 25% of the patients with Staphylococcus aureus bacteremia, here teicoplanin is not a good choice because it has poor penetration into the vegetation. However, if there is a axial skeletal involvement, which can happen in 20 to 30% as well, then teicoplanin can be used because it has a good bone penetration. Again, hematogenous lung abscesses, here daptomycin can be used, but daptomycin, because it's a hematogenous lung abscess with Staph aureus and not a primary Staph aureus pneumonia. So this is a table which briefly summarizes the antibiotics for the Staphylococcus aureus. So we have MSSA, the drug of choice is cloxacillin, flucloxacillin, cefazolin, and not vancomycin, which is a late cidal activity and is inferior to the beta-lactams. Again, even if the susceptibility report later on shows that it is susceptible to fluoroquinolones, then ciprofloxacin and levofloxacin are not good anti-staphylococcal drugs. There is a newer drug, levo-nadifloxacin, which is available and is showing some promising results for the MRSA. The other drugs like this third generation cephalosporin, piperacillin, tazobactam, meropenem, or imipenem are not good effective drugs for the Staphylococcus aureus. When we are using vancomycin, it's very important to have a trough level of 15 to 20 for the severe infections. And the other agents have been briefly described by my previous speaker. Now, this is again a table which summarizes the various treatment options. Linezolid should not be used for bacteremia. It is bacteriostatic. Tigecycline, even though susceptible, is not a good drug for CRB for the bacteremia. And whereas daptomycin is a good drug for right-sided endocarditis, as well as it can be used at a higher dose for the left-sided endocarditis, and of course for the Staphylococcus aureus bacteremia. Ceftaroline is also a good treatment option. Now, coming to this case of a young 17-year-old boy who had no comorbidities, presented with sudden onset severe pain, which resulted in hip arthritis as well as osteomyelitis. The blood culture was growing the GPC, and that's when an ID reference was called in. So we inquired, and there was a boil on the forehead, which he had responded to the this was a Sepsiscon. So based on this history, there was a possibility of Staphylococcus aureus and MSSA likely. This patient was started empirically on flucloxacillin, awaiting the blood culture reports, which turned out to be MSSA. Source control was done with the effective debridement. The repeat blood cultures were negative, and that was taken as the day one of therapy. And it's very important for the management of Staph aureus bacteremia to do an appropriate source control because this will help in the this actually helps in improving the outcome. I hope this will help in optimizing the empirical antibiotic choices for the gram-positive infection, which we deal in our clinical practice. Thank you so much.
Thank you, Dr. Neha. After knowing all the antibiotics and the choices available, how we can improve the outcome? Let's hear from Dr. Rajiv Soman, who is an ID physician from Jupiter Hospital, Pune, and Dinath Mangeshkar Hospital, to guide us regarding improving outcome in staphylococcal bacteremia. Welcome, sir.
Infections in particular for bacteremia. So some of the practice points are as follows. So first important task is to differentiate between Staph aureus versus coagulase negative Staph aureus, staphylococci. So the important thing is the coagulase negative staphylococci actually don't produce too much of toxins. Their special property is adherence to foreign bodies as well as production of biofilm. So they become more resistant to treatment but less virulent. The next is to see whether this is a methicillin susceptible or methicillin resistant Staph aureus. Additionally, there are considerations of heteroresistance, small colony variants, and whether the bugs are actually producing toxin. The next important thing is to see what is the source of this particular bacteremia, whether that has already disseminated elsewhere and produced metastatic complications, and then what we call as complicated Staph aureus bacteremia. And finally, for the clinician, it is very, very important to look and analyze the antibiotic susceptibility report. Look at this patient who has a high-grade tibial osteosarcoma receiving chemotherapy through a port. He had an abrupt onset of high-grade fever, and his absolute neutrophil count was very, very low. It was just 186. He was treated empirically with meropenem, and the CT showed these nodular shadows with surrounding halos, which was reported by the radiologist as consistent with So voriconazole was started for that. The galactomannan in serum was actually negative. Blood culture did show methicillin staph aureus. Methicillin was continued. Neutropenia did recover, and the next blood culture done after 2 days was negative. So meropenem was given for 7 days to this patient and discharged. A month later, of course, he had this megaprosthesis, and there was pain and swelling in the knee with that megaprosthesis. And the knee aspirate, which was turbid, was thought to be due to aspergillosis, and the patient was referred for an ID opinion. So if one really re-examines the diagnosis of invasive pulmonary aspergillosis at that time, it appears really to be unlikely. In view of the abrupt onset of fever without cough, and serum galactomannan was negative while the patient was severely neutropenic. Besides, aspergillosis of the knee is an uncommon problem. So what could it be? Remember here that the patient had a chemotherapy port in place for several months, which could have produced Staph aureus bacteremia. The patient had an abrupt onset of fever without cough. While nodules with halo is characteristic of invasive pulmonary aspergillosis, the symptoms can be due to other causes such as abscesses due to Staph aureus, and this could have resulted from hematogenous dissemination. Now he received only meropenem for 7 days, which is not the preferred drug for Staph aureus bacteremia, and since the infected port was still in situ, processes could easily occur, resulting in septic arthritis. That seems to be the most likely scenario and diagnosis. And same Staph aureus was seen in the blood as well as in the joint fluid. So acceptance of invasive pulmonary aspergillosis led to actually erroneous treatment and ignoring the correct approach for bacteremia. So it should have been that the port should have been removed. Metastatic, especially in the presence of metastatic infection, is the correct approach. A single positive blood culture for Staph aureus needs evaluation, both the source as well as actual or potential metastatic sites. Alternative diagnosis such as maybe invasive aspergillosis or something like that need to be carefully ruled out. The patient needs adequate source control, needs therapy with appropriate drugs and duration, and correct management of all these aspects has to be avoided has to be done in order to avoid disastrous consequences. In this next patient, this was a patient who presented with a septic arthritis of the hip, and the hip aspiration did show Staph aureus, and the same isolate was seen in the blood. So what are the things that we need to see? So firstly, what is the probability it is Staph aureus? The next important thing is to look at the cefoxitin screen. So if cefoxitin is positive, screen is positive, it means it is MRSA, regardless of whatever third generation cephalosporins or beta-lactams are reported as. In this patient, obviously, cloxacillin was reported as resistant, again consistent with MRSA. What is very important to see is what is the MIC to vancomycin. So the MIC to vancomycin here was less than 0.5, and we should also look at linezolid, daptomycin, as well as tetracycline, and sometimes even rifampin and trimethoprim sulfa, because these might be some drugs which we might use in combination. Now, in this patient who has a septic arthritis and a bacteremia, is a transesophageal echo, is it a must in this case? Absolutely, yes. Remember here that infective endocarditis can be both the source of the Staph aureus bacteremia as well as its complication. And there are certain things which, if positive, such as osteomyelitis, septic arthritis, patient on dialysis, and so on, in these situations, the chances of there being infective endocarditis is very, very high. And therefore, in these situations, transesophageal echo is highly recommended. Indeed, in this patient, as you can see, there is this vegetation which is seen, which is indicative of infective endocarditis, and therefore appropriate treatment can be chosen. The next part of practice points 6 to 10 is related to the choice of treatment and how we would choose the treatment. So for MSSA, cloxacillin versus cefazolin, and there are lots of points in favor of one over the other. By and large, cloxacillin, it should probably be chosen for most of the patients, especially when it is bacteremia, deep-seated, and serious infections. Similarly, vancomycin versus teicoplanin, both these drugs can be chosen for MRSA. Teicoplanin should be avoided for meningitis and endocarditis, but can be an attractive choice for osteomyelitis, septic arthritis, and even for pneumonia. What about vancomycin PK/PD considerations? We'll spend a bit. There might be a role for all these other newer drugs such as daptomycin, linezolid, ceftaroline, and fosfomycin. And remember here that the duration of treatment is something which is very important. We sometimes use a shorter duration, and even shorter duration is actually 2 weeks or 14 days. In those patients where the central venous catheter is removed, there is no other prosthetic material in the patient. Patient's fever goes away in 2 to 3 days. The next blood culture is negative and the patient shows clinical improvement. In this situation, the treatment will still be for 2 weeks. However, it could be 6 to 8 weeks if there are other sites of metastatic infections. And finally, maybe there is some role for combination therapy in the refractory Staph aureus bacteremia. So in this patient, he was on maintenance hemodialysis through a permacath. He had MRSA bacteremia, and as you can see, there are these nodules. Some of them show cavitation. So these are hematogenous lung abscesses. The vancomycin MIC was 2. The patient was on vancomycin without improvement. So what we did was to remove the permacath and look at this report. And in this report, as I was telling you, vancomycin MIC of 2 is still reported by the lab as susceptible. However, when the MIC is greater than 1, it becomes very difficult to achieve targets of AUC over MIC of 400, which is actually required for a therapeutic effect. In this situation, continued use of vancomycin is difficult. It depends on good source control as well as response. However, there is also added difficulty of dosaging appropriately the vancomycin in the presence of hemodialysis. Recently, it has been shown that there are other computerized and machine learning ways of doing the AUC guided dosing for vancomycin, which might perhaps be better and less toxic. However, others have called this as a monitoring effort, which however is to achieve its objective. And rather, the focus should be on alternative agents such as daptomycin, ceftaroline, but very importantly, along with early and complete source control. Now, ceftaroline was used in this patient with modified dose according to HD. And there was one more choice. We could have also used daptomycin, but remember at a higher dose, 10 milligram per kilo post HD, 3 times a week. That also could have been used because although daptomycin cannot be used for bronchoalveolar pneumonia, it can be used for hematogenous lung abscesses because the nature of this infection is vascular rather than bronchoalveolar. Linezolid could also have been used in this patient, but it was not used due to anticipation of toxicity. Remember, again, for this, the treatment is duration is quite prolonged. So here I have set for you what are the various options really focusing on MRSA. And you have these drugs as well as these sites of infection. And you will notice here that vancomycin has been the grandfather of treatment. However, it has never been formally compared with any of the other drugs. And therefore, there might be some benefit of one or the other drug based on the site of infection, whether it is a sided drug or not, its toxicity profile, whether it is suitable for use only for 2 weeks, or maybe it is suitable for 4 to 6 weeks. Many of the deep-seated infections might require long treatment, such as osteoarticular infections, which may go on for some time even after the patient is discharged. And in those situations, maybe doxycycline, minocycline, in combination with Bactrim or TMP-SMX might be a good idea. Sometimes this MRSA bacteremia may be very, very refractory, and it becomes very difficult in spite of doing all the things correctly. The bacteremia does not resolve. So what are the options here? Maybe high-dose daptomycin with or without rifampin, especially if there is a foreign body which cannot be removed. Maybe vancomycin plus a beta-lactam such as ceftaroline, or daptomycin plus beta-lactam like ceftaroline, and a newer one which is being assessed in a trial called, which might be fosfomycin plus imipenem. So why we are continuously obsessed with resistant gram-negative bacteria, certainly that's a big problem in our country. Gram-positive infections are not far behind in resistance and are perhaps more virulent. These infections need aggressive search and source control, as well as evaluation for metastatic spread. And there is a lot of important laboratory information, some of which is now routinely available with VITEC tests and so on, which can help in fine-tuning treatment. Also remember that MICs are creeping up and there really exists a need for new therapy. So only vancomycin, only teicoplanin may not be applicable for each and every seriously ill patient. However, there are some challenges in choosing among the various available agents. However, if we do all these things right, choose the right drug, you optimize the PK/PD, do the source control, check for metastatic complications, then the purple peril may not be a purple peril anymore. With this, I will stop, and if there are questions, I'll be happy to take them. Thank you.
Thank you, Dr. Soman, for that excellent lecture. As there are no more questions, we'll move on to the next session, which is on fungal infections. The first talk will be by Dr. O.C. Abraham, who is a professor in the Department of Medicine at CMC Vellore. He'll be speaking on whether we are starting antifungal too late in sepsis. Over to you, Dr. Abraham.
Everyone who has joined Sepsiscon 2021. My name is O.C. Abraham. I'm a professor of medicine and infectious diseases at Christian Medical College, Vellore. My presentation is on early antifungal therapy in sepsis. Let me begin by sharing my screen. So I have been asked to talk on the topic, are we starting antifungals too late in sepsis? During my presentation, I will try to answer 4 questions. What is sepsis? Second question, how often is invasive fungal infection a cause of sepsis? Third question is, what are the tools available to us for early diagnosis of invasive fungal infections? We are all told that blood cultures miss 50% of invasive candidiasis and it's too late. The turnaround time is too late. And the last question, what are the treatment strategies and outcomes when you have untargeted treatment for invasive fungal infections? So what is sepsis? We all know this. It's a life-threatening organ dysfunction which occurs as a complication of infection. In other words, it's a bad infection. It progresses from colonization, infection, and when there is organ dysfunction, there is sepsis. And finally, when your patients have altered tissue perfusion, elevated serum lactate, and need for vasopressors, it's called septic shock. So we also know that timely administration of appropriate antibiotic therapy is the cornerstone of the management of serious ICU infections. So since candidemia forms the largest chunk of invasive fungal infections in the ICU, which present as sepsis, let's start with the epidemiology of invasive candidiasis in ICU patients in India. So this is the large study involving 27 ICUs across India, coordinated by Dr. Arunlok Chakrabarti from PGI Chandigarh. So what they found was that the overall incidence of candidemia in ICU patients was 6.5 cases per 1,000 admissions, under 7 cases per 1,000 admissions. And the 30-day mortality, the crude mortality was about 45%. So candidemia looks like it's an uncommon event, but associated with significant crude mortality. And when you look at the species which cause candidemia in our ICUs, 75% were caused by Candida tropicalis, Candida albicans, and Candida parapsilosis. Why am I saying this? Because these isolates are usually susceptible to fluconazole. What about early diagnosis of candidemia? Since blood culture is insensitive and takes a long time to become positive. This slide talks about sensitivity and specificity and positive predictive and negative predictive value of 2 biomarkers, beta-D-glucan and PCR. We know that BDG has approximately 80% sensitivity and specificity, and PCR has a sensitivity of about 90% and specificity more than 95%. But what I want you to concentrate is the negative predictive value. Both these tests have excellent negative predictive value. Why? Because candidemia is an uncommon disease, even among patients with febrile neutropenia. The positive predictive value goes above 20%, the usual threshold quoted when you want to start empiric antifungal therapy. Only when the patient has septic shock for more than 3 to 7 days, after more than 3 to 7 days in the ICU. So even in settings where candidemia is expected to be high, septic shock, more than 3 to 7 days in the ICU, or fulfill the criteria for prediction model of candidemia, then only the positive predictive value of this positive test become an actionable value. So what are the unintended consequences of molecular diagnosis of candidemia? Of course, you're going to diagnose candidiasis earlier than culture because the turnaround time is much shorter, and those are missed by culture, at least in some patients. But if it is ordered in a mindless fashion, every time a blood culture is collected, in the subset where NAT is positive and blood culture is negative, these are going to be large number of patients whom candidiasis is extremely unlikely, or the false positive test. Remember, when the pretest probability is low, a positive test most likely indicates a false positive result. So this will drive extra antifungal consumption, cost, toxicity, drug interactions, antifungal resistance. And in countries where you have to report every nosocomially acquired infection, bloodstream infection, this will lead to reporting of more hospital-acquired infections. So these are the three strategies of untargeted antifungal treatment: prophylaxis, empiric treatment, and preemptive treatment. And when the culture is positive, it's a targeted treatment. Prophylaxis is given to everybody who has risk factors. Empiric treatment is based on signs and symptoms, and preemptive treatment is based on positive test result. So fear-driven strategy, fever-driven strategy, and a diagnostic test result-driven strategy. As you come up the arrow, the specificity of diagnosis increases, and the treatment becomes finally targeted treatment when you have a positive culture. Again, to reiterate, prophylactic strategy, empirical strategy, preemptive strategy, and targeted treatment. So in the era before we had good randomized controlled trials, there were several observational studies which are really prone for biases and confounding, which reported that early antifungal therapy before culture results were available was associated with improved survival in critically ill patients in the ICU. But this has all changed after good randomized controlled trials have been published. I want to briefly discuss the most recent study, the Empiricus trial reported in JAMA in 2016. This is a multi-center RCT randomized controlled trial, double-blind placebo-controlled trial done in 19 ICUs in France. They included really ill patients. Patients had to be ventilated for at least 5 days, had to have at least another additional organ dysfunction, and patients were clearly septic. One new finding which indicated sepsis of unknown origin, had either an arterial or central venous catheter in place, and were treated for at least 4 days using a broad-spectrum antibacterial agent, and patients were colonized in more than one site, which did not include rectal swab, and this was a traditional culture method. They excluded patients who had proven candidemia. And their outcome was 28-day invasive fungal infection-free survival. So patient had to survive up to day 28 and had to be free from invasive fungal infection. As you can see here, the hazard ratio was 1.35, but the confidence intervals extended from 0.87 to 2.08. This was an insignificant result. So this study conclusively proved that empirical treatment with micafungin was not associated with improved fungal infection-free survival. One of the editorials said that this should be the last nail in the coffin of empirical treatment. This is a meta-analysis, updated meta-analysis published in JAMA in 2017 after the Empiricus trial, which included 22 RCTs which looked at untargeted treatment for invasive fungal infections. So they included studies on prophylaxis, preemptive therapy, and empirical antifungal treatment. ICU, and they had close to 2,800 patients, and they found that there was no significant effect on mortality with any strategy, prophylactic, preemptive, or antifungal therapy. Relative risk of 0.93 and confidence intervals extending on either side of 1. However, there was low quality evidence that untargeted therapy was associated with significant reduction in the risk of invasive fungal infections. So you have a paradox here. Untargeted antifungal therapy does not reduce mortality, but it does significantly reduce the incidence of antifungal infection. So what does this mean? This means that, yes, if you use antifungals, you see less of invasive fungal infection. However, these patients are either too sick or they die with invasive fungal infection rather than of invasive fungal infection. That's the most likely explanation. So what do I conclude? Invasive candidiasis is uncommon in the ICU. Incidence of less than 7 per 1,000 admissions. Biomarkers, because of the low prevalence of these conditions, should be utilized for their high negative predictive value. Untargeted antifungal therapy does not reduce mortality and should be used selectively among patients who have high risk factors for invasive candidiasis. Patients who had major abdominal surgery, patients who had anastomotic leak, patients who have acute pancreatitis, patients who are neutropenic, have central catheters in place, who are on TPN, remain septic despite broadspectrum antibacterial therapy. Those are the patients whom you should consider untargeted antifungal therapy. Biomarkers are negative, you can boldly stop the therapy because of their high negative predictive value. So there is no role for routine use. And you always have to remember that more drugs does not lead to better outcomes, or in other words, you have to be a parsimonious prescriber. Remember, the policy in ICU should be think fungus in a patient who remains persistently septic despite appropriate antimicrobial therapy. And you also have to remember that every milligram of an antifungal, whether it's an azole or echinocandin, counts. So I'll stop my presentation here. I will invite all of you to become members of the Clinical Infectious Disease Society. And thank you very much for this opportunity once again. And thank you very much for patient listening. Thank you.
After that informative talk on antifungals, we'll move on to the next talk, which is on mucormycosis by Dr. Atul Patel. Before that, I would like to make an announcement. If there are any questions, please send it in the chat box. This is an announcement for all the delegates. If there are any questions, please send it in the chat box. Moving on to the next lecture by Dr. Atul Patel. Over to you, Dr. Atul Patel.
For inviting me to speak on COVID-associated mucormycosis. Let me share my slide first. Yes. So when we look at the global burden of mucormycosis, it is very low. It is less than a 10 per million population. When we talked about India, the burden of mucormycosis in India is very high compared to the global burden. It is 140 cases per million populations in India. So 14 cases per 100,000. And when we looked at the total number of mucormycosis across the globe every year, it is around 10,000 per year globally. But in this second wave of COVID-19 in India, like we have more than 48,000 of mucormycosis patients. So we witnessed a very high numbers of mucormycosis during COVID second wave. When we looked at the mucor species which is responsible for the human infection, the Rhizopus species is most commonly isolated from a case of mucormycosis, attributing to around 80% of the cases. And amongst Rhizopus, the Rhizopus arizus is the most common, and the rest of the species are less important. When we looked at the risk factors of mucormycosis in India, in developed country and the developing country, the risk factors are different. In the developed country, the hemato-oncology, malignancy, and the bone marrow transplant, HSCT, these are the very important risk factors, followed by the organ transplantations. While in India, the diabetes is the most prominent and the most common risk factors for mucormycosis. Now coming to the COVID-associated mucormycosis, in last September to December, when we did this multi-center study, it was very clear that the COVID-19 pandemic has led to the increase in the case of mucormycosis, because when we compare the data of September to December 2019 with the same center in September to December 2020, there is a clear increase in the burden of mucormycosis cases to 139. And the non-COVID associated mucormycosis were 92, which were 112 in the previous year during the same time. So that means that whatever increase in the number of mucormycosis was purely related to the COVID-19 pandemic. When we also checked for the prevalence of mucormycosis in our COVID-infected patients amongst the participating centers, and we found that the prevalence is very low. It is just 0.27% in the hospitalized COVID-19 patients. So the overall, when we looked at the mucormycosis prevalence, it is very less. In this study, we found that diabetes and the new onset diabetes, these are the two very important risk factors for mucormycosis. And when we check the new onset diabetes in CAM versus non-CAM, it is 2 times higher in the COVID-associated mucormycosis, that is CAM. And in the CAM patient, the diabetic ketoacidosis was also 3 times higher compared to a non-CAM patients. This is the case control study that we have recently submitted to a journal from our center, looking at the risk factors for CAM in our patients population. And this table showed a multivariate analysis of risk factor of CAM in our center. The new onset diabetes has a very high adjusted odds ratio, that is 48.66, and which was statistically significant with 95% confidence interval of 14.3 to 116. When patient is having pre-existing diabetes, the adjusted odds ratio for COVID-associated mucormycosis is 2.93%, which was also significant. But interestingly, when we looked at the type of admission for the treatment of COVID, and we found that the patient who received home isolation, they had a higher adjusted odds ratio for development of CAM, that is 4.8, with the 95% confidence interval of 2 to 11.3. And the patient who require ICU hospitalization for their COVID care, actually they are protected. There are less chances that these patients are going to get the mucormycosis. The third important risk factors that we found in this, our case controls study, that steroid therapy. The steroid therapy is statistically significantly associated with the risk of COVID-associated mucormycosis. We also analyzed the other risk factors like the use of tocilizumab and the oxygen therapy. The reason is that, like, we know that tocilizumab is a powerful and potent immunosuppression, and while suppressing the immune system, patients may be susceptible to get the more chances of the secondary bacterial and the fungal infection. And the oxygen therapy, we also checked. We have divided these patients into 2 groups, that is high flow oxygen and the low flow oxygen. High flow was defined as the patient who requires HFNC, BiPAP, and the invasive ventilator, and the low flow is just nasal cannula and the mask, as well as the NRBM oxygen. So while looking at the tocilizumab, the control cases has used tocilizumab in higher number compared to the case, that is the case received only in 3% of the cases, and but it was insignificant. So higher number of control, that is 10.7% of control received tocilizumab, while the case that is CAM received only 3%, and which was not significant. So it clearly says that using tocilizumab is not adding or increasing the risk for mucormycosis in our case series. And in oxygen therapy, because we checked oxygen specifically because there was lots of noise into the social media as well as the print media that the industrial oxygen, the contaminated oxygens, the oxygen mask and the nasal cannula are contaminated by the mucorales spores, as well as the humidifier, which were not cleaned properly, and probably that is contributing to the risk of mucormycosis. So when we checked oxygen therapy, in fact, the higher number of controlled received oxygen therapy compared to the CAM patients, and the oxygen did not increase the risk of the CAM in our case control study. So these two factors clearly says that TOSI and the oxygen therapy has not increased the risk of mucormycosis. Now coming to what is the relationship between the COVID-19 and mucormycosis? We have 3 important risk factors for mucormycosis in COVID patients. One is the virus itself, that is SARS-CoV-2 virus. The second risk factors that we have identified is diabetes. And the third is corticosteroid therapy for treatment of COVID-19. Now this SARS-CoV-2, we know that this virus utilizes primarily the S2 receptor to produces the tissue invasions and establishment of COVID-19 infections. So spike protein combines with the S2 receptors, but this virus also utilizes the glucose regulated protein 78. And not only it utilizes this GRP78 receptors to produce its infection, but it also increases the GRP78 expressions into the tissue. While doing this increase in the GRP78 expressions, the same the receptor is utilized by the Mucorales species. And the Mucor species, the coat H3, it combines with the GRP78 and produces tissue invasion and the angio invasions. So by upregulations of this GRP78 or the increase in the expression will facilitate more angio invasions and the more tissue invasions by the mucormycosis. The other important, the metabolic changes that SARS-CoV-2 leads to is unmasking or new onset diabetes. So it is very clear now we have several publications which shows that the SARS-CoV-2 infected patients can have unmasking of diabetes or the new onset diabetes. So this new onset diabetes will contribute for a mucormycosis. And the third important thing is the use of steroids. So use of corticosteroids in the treatment of COVID-19 will also contribute to the uncontrolled or the hyperglycemia, and both these conditions, along with the SARS-CoV-2, that is virus itself, diabetes and the corticosteroid therapy leads to a qualitative neutrophil and the macrophage dysfunction. And this qualitative neutrophil and the macrophage dysfunction, a powerful and the potent innate immune system tool will not be able to take care of the spores and will facilitate the further tissue invasions and the angio invasions. SARS-CoV-2, by the virtue of producing the significant the immune dysregulation, it produces neutrophil and the macrophage dysfunction. That hyperglycemia into the tissue will facilitate the germination of the spores, and these germinated spores will further lead to the infection or the successful tissue infections by the other factors like GRP78 expressions and the neutrophil dysfunctions. So all these things like steroids, DM, and the SARS-CoV-2, they are interrelated, and they leads to more, they will allow more angio invasions by the Mucorales species. Now coming to the treatment, in our the CAM study which we published in Emerging Infectious Disease, majority of the patients, they received liposomal amphotericin B with 16% received deoxycholate versions, and the sequential therapy, that is amphotericin B followed by the posaconazole, was received by 40% of the patients. So this is a high number. And the combined medical and surgical therapy was received by more than 2/3 of the patients in both the group, that is CAM and the non-CAM group. When we looked at the outcome at 6 week and the 12 week, in CAM group, 37% of the patient has died at the end of 6 weeks, while 40% in non-CAM group, and at the end of 12 weeks, the 44% in CAM and the 48% in the non-CAM group, they died. So the mortality is almost similar, and the COVID infection has not increased the mortality in a patient who develops mucormycosis. In the same study, when we looked at the univariate and the multivariate analysis, in univariate, the combination of medical and the surgical therapy, that is the surgical debridement of the infected sinuses and the tissues, it improves the survival in the rhinoorbital cerebral mucormycosis, but it did not improve the outcome of the patient with infections at other side. While in multivariate analysis, we found that age, ROCM, ICU admissions were associated with higher mortality. And the sequential therapy, that is initial amphotericin B for 4 to 6 weeks followed by the consolidation with oral posaconazole, it improves the survival in CAM patients. Just to summarize this talk on the COVID-associated mucormycosis, the COVID-19 pandemic has increased mucormycosis cases in India. So we do have good evidence that it has significantly increased the number of mucormycosis cases in India. The CAM prevalence in COVID is just 27%. Diabetes is found to be a single most important risk factors apart from the steroids therapy and the home isolation in COVID-19 patients. The reason and the explanation for home isolation being a risk factor, I forgot to discuss, but it is mainly because these patients, they remain undiagnosed with hyperglycemia. So their new onset diabetes was not recognized for the isolation time, that is 2 weeks period. On top of that, 70% of the home isolation patients, they received a corticosteroid, so which has further worsens the sugar control. And because of this uncontrolled high sugar level for at least 2 weeks time, probably and the steroid therapy contributed to a higher number of mucormycosis in home isolated patients. And combination therapy with medical and surgical treatment and sequential treatment with amphotericin and oral agents is associated with the improved outcome. So take home message for the audience would be that we need to adopt a very judicious approach, and we should follow the treatment guideline of COVID-19, especially regarding the use of steroids in non-severe COVID-19 disease. We should avoid using steroids in a patient who are home isolated and those who do not have any oxygen requirement. And probably this will help us a lot in reducing the mucormycosis burden. And this should be coupled with the diligent blood sugar monitoring and glycemic control, even at the home isolated patients. So we have to educate them to have a glucometer at home and to monitor their sugars and to control their hyperglycemia. So both of these things, probably we feel that it will help to reduce the CAM incidence if we have a third wave or the third surge in COVID-19 cases. Thank you very much for the patience listening.
Thank you, Dr. Patel, for that enlightening talk. There are a few questions for him, but as he is not available at present, we'll forward the questions to him and we'll try to answer them. Till then, we'll move on to the next lecture by Dr. Arunalok Chakrabarti, who is head of the Department of Medical Microbiology at PGIMER Chandigarh. He'll be talking on what's new in fungal diagnostics. Over to you, Dr. Arunalok.
Ladies and gentlemen, I am Dr. Arunalok Chakrabarti. I have been given the task to discuss with you the diagnosis of fungal infection, what is new. I'd start with this provocative statement, that is delivering on antimicrobial resistant agenda not possible without improving fungal diagnostic capability. As this is Sepsis Congress, where I'm going to discuss much more in case of Candida, and in case of the Candida for sepsis issue, the question comes whether it is because of bacteria or is it because of Candida. Unless we resolve this problem, there would be always inappropriate use of either antibacterial or antifungal. So there is development of antifungal resistance. Friends, at present, biomarker tests and point of care tests have come. And this is improving the situation which was there. In case of the conventional diagnosis for invasive candidiasis, the techniques are there, but they are slow and low sensitivity. Even in case of the biomarker test, present-day diagnosis does not exceed 50%. So we need to diagnose the other 50%. So can we do better? Yes, the T2 magnetic resonance nanoparticle-based technique have come. And these particular techniques see how improvement is there in case of turnaround time. From 106 hours, it had gone only in 4 hours. But this particular test can detect only 5 Candida species. Second important difficulty is that it cannot replace the conventional technique for doing the susceptibility. And the cost is prohibitive. In comparison to that, more or less, many centers now using this multi-top technique for yeast identification, like bacteria. It can identify yeast, even mycelial fungi. Possibly within short time, it can perform also antifungal susceptibility testing. There are some molecular diagnoses that come in case of invasive candidiasis, whether it is in blood culture or in case of the extraction of the DNA from the sample. But all this technique, if you look, despite over the 2 decades use, the incorporation of the molecular methods to enhance the diagnosis of yeast infection remains limited to certain specialized centers. commercial test that needs a broader application for the validation, and we need to improve or reduce the cost. That is very important. In that perspective, I would say that molecular technique like next-gen sequencing would be very useful, possibly directly detecting microbe from the specimen, knowing about the microbiome, and also looking into the susceptibility and resistance. Friends, you all know that Candida auris is a big issue now because of the outbreak, where if you have to screen out any patient for Candida auris, especially even for colonization, before taking any patient in your ICU, you need a quick screening. There are certain techniques that come like PCR or multi-drop, but I would say that this particular technique, which is having or coming as a kit, though I have not evaluated it, but I found in literature, this is quite interesting. It can identify Candida auris within 1 to 1.5 hours. That would be very interesting. I like to evaluate this. In case of Candida biomarker, most of the people are using the beta-D-glucan test, and the beta-D-glucan test have been evaluated quite well in case of this Apollo Chennai study, which had shown that even if you have started empiric therapy, if beta-D-glucan test result shows less than 80 picogram, you can stop empiric therapy. Or even if it is more than 150 picogram, you can identify invasive candidates. But this particular test requires at least 21 patients to run a single batch, which may not be possible in a small center where you need to wait unless you have got 21 patients. But here there is a very interesting test that comes from the same company. And they say that you can do this test for a single patient. And even there is improvement in turnaround time that you can do the test within 1 hour. I have not again evaluated this test. I need to evaluate. Coming to the aspergillus, there are 2 point of care tests there. One is detecting the protein, extracellular protein. Another is detecting the galactomannan, that is the polysaccharide antigen. Both these tests had shown to be comparable because it requires small volume and the test results are very quick. And when it had been compared with the galactomannan, it shows very good result, comparable result. And when it had been looked into different patient group, as in case of galactomannan, it is showing much better result in case of hematology malignancy group. But I would say that when it had been evaluated in ICU, though the sensitivity is 60 to 70%, even then that is important because here the diagnosis is very difficult. If you can pick up 60 to 70% patient, that is quite. Now, which particular test you will choose? I tried to look into if there is head-to-head comparison. There is a single study very recently got published. It is evaluated in hematology oncology group. It shows that lateral flow assay is much better sensitivity-wise compared to the lateral flow device. But the specificity is more or less similar. And then my friend Martin has published this meta-analysis, both in case of BL sample and serum. In this meta-analysis also, if you see both the this comparison when it is there, the lateral flow assay is showing better result than the lateral flow devices. In histoplasma, where the diagnosis was much more difficult, now there are 2 kits available, and both these kits can do the test in serum and urine. And if you see sensitivity is good, specificity is also good. I would really love to evaluate this because histoplasma diagnosis is always a challenge. In mucormycosis, another challenge in diagnosis because we don't have any biomarker test. Here there is a kit Mucorgenius. This has been evaluated, shown good result in some laboratories. But when this has been evaluated in our COVID-associated mucormycosis, people found that in case of the pulmonary mucormycosis, where the results are required by this particular molecular test, it are not showing good sensitivity. So possibly it needs further evaluation. At the end, I like to evaluate or like to stress on this particular issue. My stress is going into the cell-free DNA now. You know, this cell-free DNA has been used in case of the cancer diagnosis, in case of transplantation also. Possibly it can be used in fungal diagnosis, and that would be very important because the DNA is small, it can go into the urine, so you can do the diagnosis even in the urine. And this is one study available in clinical infectious disease online. They developed a bioinformatics pipeline using the fungus which are very commonly producing the human infection, and what they have evaluated in the patient which is having invasive fungal disease and where there is no invasive fungal disease, it has shown good sensitivity, 70%, but specificity is fabulous, nearly 100%. But most important thing is that it has a positive impact on clinical management, nearly 50%. When it had been compared between the Aspergillus and Mucor, it had shown very good result in Mucor, but not so good result in Aspergillus. Similarly, for selfie DNA, another test, this also still on the pipeline in case of clinical infectious disease. And here, if you see, they have used the metagenomic instead of the PCR. And they have used in case of post hematologic transplant group of patients who is developing pneumonia. When the sample was stored over 14 days, when they evaluated, they found that sensitivity is 51%. But when the samples which have been collected within the 3 days of diagnosis have been used, it had gone up to 60%. Most important thing, if you see, when you combine with galactomannan, the sensitivity increases further. As in the last study, similarly here, if you see, Aspergillus sensitivity not good. So whether in case of the selfie DNA, we need to improve some diagnostic technique for Aspergillus diagnosis or not. At the end, I would like to say that those selfie DNA, the two techniques which I have described is good, but I am more attracted to this particular technique if it is coming in case of fungal disease. It's not only detecting the fungal DNA, but also detecting the tissue which is getting damaged because of the fungi. And that can be measured by this cytosine methylation. And you can identify specifically which tissue is getting damaged. So when or whenever it can come for fungal disease, that would be very important. But despite that, we always face challenge. If you see in case of epidemiology, there is changing host, introduction of new management, changing environment, new pathogen. So it's a moving target. And here, to develop newer diagnostic techniques is always a challenge. So friends, summarizing what I tried to tell you is that think of fungus in your patient. In case of blood culture, if you have no other technique available, please use adequate volume for culture. T2 magnetic technique is very good, but it is beyond our reach because it's very expensive, not marketed yet in Asia. But MALDI has improved the microbe identification significantly. Other molecular methods needs further standardization. Amongst the biomarker test in Candida, I would say this fungital stat I like to evaluate because it can test only single patient. In case of lateral flow, the development in Aspergillus and histoplasmosis is very encouraging. But as I said, my interest is going into the selfie DNA. That would help in case of rapid scanning, and especially the metagenomic approach, if you can also detect the tissue damage in that sense. At the end, I'd like to invite you to join in this fungal India registry. From our fungal infection study forum, we have started it. There are 3 registries, one for Aspergillus, second for Mucor, third for endemic mycosis or rare fungal disease. You can go to our FIS, fungal infection study forum website, and from there you can submit the cases. And if your case is validated, you will be given the remuneration. At the end, I'd like to invite you to this particular conference, which is going to be happening next year during the same September month. This is the World Congress. After a lot of effort, it had come to India, and there would be all the best people in the field of fungal infection who are going to join. So I invite all of you to come to this conference. Thank you for your kind attention.
After this session is now supported by Bharat Serums. After that talk on fungal diagnostic, we'll go to the next speaker who will be speaking on optimizing antifungal therapy. Over to you, Dr. Ramasubramaniam.
Consultant infectious diseases at Apollo Hospitals, Chennai. It's my pleasure to be with you today, and my talk is going to be on optimizing antifungal therapy. We have learned quite a bit in the last 2 decades on antifungal or management of fungal infections and invasive fungal diseases, and we have started applying these to ensure that we optimize the management of fungal infections adequately. The approach to antifungal therapy has changed in the last few years, and you will find that the approach can be either prophylaxis, empirical, preemptive, or directed therapy. What is also known as fear-driven, fever-driven, evidence-driven, and diagnosis-driven. To simplify the approach, prophylactic therapy is given to an asymptomatic but high-risk patient where the probability of infection is more than 10% in that population. Preemptive therapy is when they are colonized or a newer diagnostic test, especially a biomarker, is diagnosed positive. Empiric therapy is those who are on broad-spectrum antibiotics but continue to have fever, and when the risk for antifungal infections is higher, they are started on empiric antifungals. And therapy-driven is when you have a diagnosis with you. So the first question is, how do you identify high-risk individuals? We can categorize the invasive fungal infections as molds or yeasts. We find that the occurrence of mold infection is very high in hematopoietic stem cell transplant patients and yeasts a little less. Malignancy, probably there can be an equal split between molds and yeasts. In patients with solid organ transplants also, similarly, there is a high risk of both. Patients with critical care who are in the normal ICUs are more susceptible to develop yeasts rather than molds. But recently, we are seeing patients with chronic liver disease, chronic obstructive pulmonary disease can develop as invasive pulmonary aspergillosis. Concomitant lung disease in critical care, as I said, increases the risk of molds. And similarly, diabetics, but usually diabetics with uncontrolled sugar present with mucor are generally more so from the community. Intra-abdominal surgeries can also increase the risk of candidemia. So which subgroup should receive antifungal prophylaxis? We categorize it based on the risk again. The low risk are those who are neutropenic for less than 7 days, mainly other hematological malignancies. Those who are at intermediate risk are likely to be those who are suffering from neutropenia for 1 to 2 weeks, AML, ALL, MDS in consolidation phase, and also allogenic stem cell transplant patients. But those who are at high risk include those where neutropenia lasts more than 2 weeks, typically AML, ALL, and MDS, or patients on salvage chemotherapy or allogenic stem cell transplant mismatch of graft versus host disease. When you look at what antifungal agent you have to use, this recent meta-analysis concluded that voriconazole may be the best prophylactic option for patients undergoing HSCT, and probably posaconazole may be the best agent for patients with AML or myelodysplastic syndrome. It has been very clearly shown, typically with candidemia, that a delay in diagnosis has a very profound impact. You will find that with every additional day when therapy is delayed, the mortality can increase anywhere from 15 to almost 40%. And there are very good landmark studies which have shown this to be true. But unfortunately, in spite of this, our diagnosis, or shall I say early diagnosis of invasive fungal disease, is often flawed. This is because culture studies take time. And even then, for example, for candidemia, only 50% of candidemia is diagnosed with culture positivity. So we have to resort to other modalities of diagnosis. The matrix-assisted laser desorption ionization time of flight, or MALDI-TOF, is useful in diagnosing fungus and bacteria, but this also needs a culture positivity. Polymerase chain reaction, the peptide nucleic acid fluorescent in situ hybridization on PNA fish is gaining prominence. But what is more exciting is the T2 magnetic resonance study for diagnosing Candida. Is all these tests help to abbreviate the time taken for diagnosis of fungal infections. But we also need to learn to interpret the biomarkers. There are several biomarkers available: mannan and anti-mannan, cacta, 1,3-beta-D-glucan. And for Aspergillus, we have galactomannan, Aspergillus lateral flow assay, and also 1,3-beta-D-glucan. It has been shown that the negativity of 2 or more biomarkers of fungal infection supports the suspension of many empirical treatments. This needs more looking into. If you look at beta-D-glucan, which is available in several hospitals in India, we need to understand that there are several reasons we may get false positivity. Combination of laboratory materials with contamination with glucans, bacteremia due to Streptococcus and Pseudomonas, contact with surgical sponges and gauzes, hemodialysis with cellulose-containing filters, treatment with immunoglobulin or albumin, beta-lactamase inhibitor therapy, and certain antineoplastic treatments. We also need to understand that false negative results can happen with hyperbilirubinemia, triglyceridemia, and if they are already on prophylactic or empiric treatment. So based on this, if 2 consecutive positive blood tests for 1,3-beta-D-glucan are seen, then where the causes of false positivity are ruled out, then there is a high suspicion of invasive fungal disease, and its persistent or elevation in spite of treatment sometimes can be associated with a very poor prognosis. With regard to candidemia, we have the latest update which came in 2016. We found that the agent of choice in therapy would be echinocandins, typically in patients who are unstable or neutropenic. Alternatives would include azoles or liposomal amphotericin. So if you have a documented or strongly suspected Candida infection, start immediate treatment, change lines, and do a fundoscopic examination. But there is a recent evidence to say that fundoscopic examination is probably not necessary. If the patient is stable and there is no recent fluconazole use, no resistant species suspected, no intolerance, and you know the local epidemiology to be susceptible to azoles, then you use fluconazole. If not, the patient is unstable, use echinocandins or liposomal amphotericin B, and you can subsequently de-escalate to fluconazole depending on the response. With regard to Aspergillus, an individualized approach has to be taken. Bronchoscopy and an early CT-guided biopsy, especially for peripheral lung lesions. Look for the halo sign in CT scan of the lung. The role of biomarkers is gaining prominence, but still the cutoff, there is a lot of confusion between serum galactomannan levels, bronchoscopic or bronchoalveolar lavage tested galactomannan, what should be the cutoff, and for non-bronchoscopic, for example, an ET secretion or bronchial wash secretion, there are different cutoffs. You may also need to do therapeutic drug monitoring when mold-active azoles like voriconazole or posaconazole are used. It is also important to reduce underlying immunosuppression whenever feasible. For Aspergillus, empiric therapy may include liposomal amphotericin B, echinocandin, or voriconazole, even though earlier voriconazole did not have a good evidence. Recently, it is what is recommended as a drug of choice. For mucormycosis, liposomal amphotericin B 5 to 10 milligrams per kilogram, isavuconazole or posaconazole, but there is a definite recommendation to avoid use of conventional amphotericin B, which I think is very controversial, especially in resource-limited settings. The simple algorithm would be surgical debridement, control of underlying hyperglycemia or other immune compromised status if it is manageable. If there is renal impairment, isavuconazole or posaconazole are agents. Otherwise, liposomal amphotericin B 10 milligram per kilogram. If there is adverse event, you can reduce it to 5 milligrams per kilogram. If either the patient is stable, then you replace it with azoles. If there is extensive disease, you can use combination therapy. Lastly, a word on antifungal stewardship. There should be leadership commitment and accountability to ensure, similar to antimicrobial stewardship, we have an antifungal stewardship in place to ensure that antifungal resistance can be minimized. Lastly, we know that most of us go by experience, and this says a wise doctor once wrote. But recently, there is a lot of information to say that Research evidence alone is not enough. We need to keep in mind the patient's preferences and actions, and also look at the clinical state and circumstances. So I leave you with these words that evidence does not make decisions, people do. So we need to combine research evidence, patient's preferences, especially the financial status in India, and clinical state and circumstances to make sure that you take a wise decision in approach to antifungal therapy in invasive fungal disease. Thank you very much.
There is a question for Dr. Subramaniam, which will be forwarded to him. And once he answers, we'll send it on the group. We'll now move on to the next session. From fungus, we now move on to viral infections. The next talk is by Dr. Rajesh Chawla on non-COVID severe viral pneumonia. Over to you, Dr. Chawla.
I'm going to discuss today non-COVID severe viral pneumonias. You know, this has come into focus after we had a lot of COVID all around. In the last about 10 to 15 years, the highly sensitive molecular diagnostic techniques have really improved our quality to detect viral pathogens, leading to severe and often fatal infections that require admissions to the intensive care unit. That's why we are able to diagnose these viral infections much more often. The WHO has divided, according to the regions, the prevalence of different viruses. In addition to influenza, dengue, Japanese encephalitis, Nipah virus, Old World hantavirus, these are the viruses which are prevalent. But influenza and the others are the common viral associated which require ICU admissions, like influenza A and B. They're the most common, and they constitutes about 16 to 49% in the viral associated LRTIs. Human rhinovirus is the second commonest, human coronavirus, respiratory syncytial virus, human metapneumovirus, parainfluenza virus, and adenovirus. So these are the viruses which cause lower respiratory tract infections or pneumonias. Even in nosocomial infections, in different studies, they have found 13.8 to 32% in adults, the viruses being responsible for the pneumonias. The influenza takes away almost 7 lakh people every year. And Middle East respiratory syndrome, fortunately not prevalent in India, but seen in China and Arabian Peninsula. As I said, rhinovirus is the second most prevalent virus. The prevalence of rhinovirus was significantly higher in patients with severe RTIs compared those admitted for other reasons. So they have a good contribution to the RSV is detected in 12% of all medical attendant adult aged 50 years with RTIs. In France found that in the recent study, the HMEPV, that's metapneumovirus, positive in 3% in hospitalized patients. And these are now prevalent much more often because of the lot of comorbidities which predispose to these severe infections: diabetes, obesity, malnourishment, transfusion, age extremes, steroids, HIV/AIDS, chemotherapy, critical illness, sepsis, major surgery, immunomodulator, and immunosuppressive. All these predispose to severe pneumonias. The clinical manifestation of viral infection can be asymptomatic to a very severe pneumonia with respiratory failure, septic shock-like syndrome, multi-organ dysfunctions, and numerous other complications. We have been doing viral culture, electron microscopy, and serology, not easily available, but now they have been totally replaced by nucleic acid amplification test. We have seen in COVID being done, sequencing and antigen detection method, which have really increased our detection rate of viral infection. RT-PCR takes about 4 to 6 hours as compared to the days in viral cultures. Rapid antigen, 10 to 30%, although it is a low to moderate sensitivity, but a highly specific. And RT-PCR is highly sensitive and specific. Of course, many factors jeopardize the accuracy of the currently utilized and NATs like inappropriate specimen handling, manual error, etc. As far as the radiology is concerned, there is no pathognomic finding on the chest radiograph. You cannot differentiate from bacterial pneumonia. But there are certain findings, like in COVID, we saw peripheral shadows, ground glassing. They were in the presence of pandemic, we were able to distinguish, but many times it's difficult. So you can see all these patchy interstitial infiltrates. You see more often in influenza pneumonia. ARDS could also be seen in these pneumonias. Cryptogenic organizing pneumonia in many of the viral infections is seen, and then pleural effusion in some of the pneumonias. Then the pulmonary alveolar proteinosis also has been reported even in COVID and other viral pneumonias. So it is difficult to differentiate. When you see this, you should think of viral etiology. The WHO has a given name, severe acute respiratory infection due to viral pneumonias, as a SARI. Since there are no major difference in the initial management of most of the viral infections, the treatment of the viral infection is largely supportive. You know, there are antiviral available only for a very few viruses. Like for influenza, you could give a 5 or 10-day course of the antiviral is recommended. And neuraminidase inhibitors, oseltamivir, zanamivir, and peramivir, these are the drugs which are available and have been used with great success. Baloxavir is another novel inhibitor of the codependent endonuclease activities, currently recommended only for uncomplicated influenza. Adamantazes are no longer recommended due to the development of resistance. You know, people have used high dose 300 milligram of oseltamivir and in critical care adults, but no studies have proven its superiority against the standard dose of 150 milligram per day or 75 milligram twice a day. And you know, they are effective. If you suspect in a sepsis patient there is a possibility of a viral infection, you should start a viral infection, particularly the H1N1 influenza virus. You should start oseltamivir whenever the patient comes. But if you start within 48 hours of the symptom onset, the study has shown it reduces significantly the mortality. Then the management of respiratory failure and ARDS is exactly similar, like you manage the bacterial with oxygen, beta agonist, fluid, organ support, etc. You know, supplemental oxygen should be provided to these patients to correct hypoxemia and maintain about 90%. And when you use non-invasive ventilation, you know, now it has become a practice to use any patient who's breathless, given non-invasive or HFNAC. But you should use them only for in mild ARDS. If you want to use in moderate, give a brief trial and then you go on to the invasive ventilation. You must remember that if you delay the intubation, mortality is more. I personally feel it happened a lot of times in COVID. People continued with NIV and HFNAC, and it resulted in a delayed intubation and increased mortality. In viral infection, antibiotic chemoprophylactics should not be used routinely. But many a time you're not sure what is going on, so you end up giving the viral and the bacterial together. But if you give you should cover, if it is influenza, the staphylococcal, which is very severe and the commonest infection in the H1N1 infections. You know, role of steroids. We have used a lot of steroids in COVID, but it has no role in the non-COVID viral pneumonia. There is evidence that it increases mortality, prolonged viral shedding, increased incidence of bacterial superinfection, and possibly prolonged duration of mechanical ventilation. So should not be used. Low-dose steroids in septic shock, like you use bacterial septic shock, you can use it. And prolonged use has resulted in opportunistic infections. As of now, dexamethasone is the only therapeutic agent recommended for the COVID-19. And in the para-influenza virus-induced group, to reduce airway edema, there are studies which have shown the steroid can be recommended. And there is a study in SARS which has shown that antiviral and steroid was associated with a better outcome. So I think in the COVID and few studies in SARS, otherwise there is no indication to give the steroids in viral pneumonias. Convalescent plasma has not been found to be useful in the non-COVID viral pneumonias and as well in the COVID pneumonias. Pelvinizumab, 15 milligram intramuscularly, a monoclonal antibody has substituted immunoglobulin products with high NTR titers in the prevention of RSV infection in high-risk infants. So monoclonal antibodies in infants do have a role. Then you should avoid the aerosol generating procedure for any viral infection like in COVID. Mechanical ventilation, you do it like any other ARDS patient with low tidal volume and do proning when required. And when proning is not effective, you should go for ECMO. Why I'm mentioning ECMO? Because if you want to go for ECMO, it should be within the first 7 days of starting mechanical ventilation. If you delay, it is not useful. Like one of the meta-analysis published in 2014, out of the 142, they found that no definite conclusion can be drawn due to the lack of the randomized trial. But after that, we had a Caesar trial and the Olia trial. The Caesar trial also, as a primary outcome, did not show any difference in the 60-day mortality, was not significantly lower with ECMO than with strategy of conventional mechanical ventilation. But when they analyzed, they found the data showed that possible clinical benefit from ECMO over standard care, especially if used early rather than late. So vaccine wherever available for any viral, we must take it. So just to conclude, the advent of highly sensitive molecular diagnostic techniques have improved our ability to detect viral pathogens. Presentation can be from asymptomatic or mild to severe pneumonia, respiratory failure, septic shock, multi-organ dysfunctions. Treatment is largely supportive. Steroids have no role if initiate ECMO early. Thank you.
As there are no questions, we'll move on to the next session, which is on COVID. The first talk is by Dr. Prakash Shastri. It is on COVID-associated fungal infections. Dr. Prakash.
Vice Chairman, Senior Consultant at Sir Gangaram Hospital Critical Care Medicine Department. One of my favorite subjects is fungal infections, and I'm really thankful to the organizers here to have given me the chance to share my personal experience of fungal infections in the COVID pandemic. So I share my screen. Basically, I need to talk about fungal COVID-associated fungal infections. And I have the pleasure to share my personal experience that I had in the last 1.5 years of managing COVID patients, as well as managing fungal infections. So this was the landmark study, which actually changed the way we practiced management of COVID patients. Basically, the usage of corticosteroids improved survival. But that was in the first wave. In the first wave, all the steroids that were given by us in fairly controlled environment, and we were monitoring the usage of steroids, monitoring the usage of blood sugar, we were monitoring the usage of so many other things that we were doing with the patients. And I think that was a fairly controlled environment in which we gave steroids. But when we came to the second wave, and the entire healthcare system absolutely broke down, that was a time when people started taking steroids at home, probably because they were hypoxemic at home, their pulse oximeter was showing 80s and 90s and other things. And that time, perhaps the usage of corticosteroids was completely unmonitored, and that probably led to a surge or even a deluge of bacterial infections, candida infections, but more lethal infections such as the mold infections in the COVID patients, generally after or even during their stay in the ICU. So we start with COVID-associated pulmonary aspergillosis, being increasingly reported in patients with COVID-19 disease, and yes, increases the mortality several-fold. However, there's a debate if coronavirus infection is the main risk factor or whether corticosteroid therapy makes these apparently immunocompetent patients prone to develop the disease. The diagnosis is a challenge. Diagnostic bronchoscopy is avoided. Aerosol, because it is an aerosol generating procedure. We know that these are immunocompetent patients, so galactomannan in serum carries a very low sensitivity. And we know that none of the patients of aspergillosis might have a typical radiological features which might tell us that we are probably dealing with the fungal infections. So to take you through the challenges in the diagnosis of kappa, the COVID-associated pulmonary aspergillosis, I'll take you through a case. It was a 44-year-old male, had COVID disease, was admitted in COVID ICU. That was on 22nd of November. Had comorbidities such as diabetes and hypertension. The CTSS score on CT chest was 18/25. So he was aware that it was a moderately severe COVID, and he was treated as it was wont in those days with non-invasive ventilation, dexamethasone, remdesivir, azithromycin, and a prophylactic dose of enoxaparin. Over 2 weeks, his oxygen requirement decreased. RT-PCR became negative on 7th of January, and he was discharged. So quite a prolonged stay in the hospital. Unfortunately, the very next day, 8th of January, he had a sudden onset chest pain and had severe shortness of breath, and with which he came to the emergency room of our hospital again. The chest X-ray done showed a left-sided hydropneumothorax, and ICD was inserted in the emergency room itself. He was conscious, oriented to time and place, hemodynamically stable, saturation 96% on room air, liver function test, D-dimer, procalcitonin, all other tests, the routine tests were pretty normal. But you see the glycosylated hemoglobin was 10.27. So this patient's diabetes, which was probably well controlled before he had COVID, had become uncontrolled now that he was recovering from COVID. Pleural fluid was reported as transudate. He was admitted to the hospital, again into our COVID ICU, and the subsequent chest X-ray showed persistent hydropneumothorax with air leak. On the 11th, that is our 8th, he was admitted. 11th, the ICD was repositioned, but air leak persisted, so a CT thorax was done, and a thoracic surgeon's opinion was sought. And this is what you can see on the CT scan. You can see that the massive subcutaneous emphysema on the left side. There is still a residual pneumothorax anteriorly on the left side, and the lung appears to be entrapped in the left side. And that is why the surgeon who saw the CT advised left lung valve decortication and fluoridesis. He underwent the operations, and the operation was fairly uneventful. And lo and behold, the pleural tissue, which was sent for histopathological examination 3 days down the line after the operation was done, reported thin septate hyphae with parallel walls, acute angle branching, and this was fairly suggestive of Aspergillus. And the culture also reported the species to be Aspergillus fumigatus. Post-operatively, he was extubated and transferred to the ICU. Unfortunately, in the ICU, he had a rapid downhill course, and he succumbed to his illness after a week or so in the intensive care unit. The reason why I highlighted the course was that he was in the hospital for 3 months almost, and during this entire period, none of us had an inkling or even a suspicion that he would be harboring a fungal infection in his chest. And obviously, BAL was not done. The CT scan, whatever CT scan was done, revealed only COVID disease, and the patient was reasonably stable. He was talking even on admission to the hospital on 8th of January, just 1 week before his death. He was reasonably hemodynamically stable. So there was no reason for us to suspect that he would be harboring a deadly fungal infection in his chest. But actually, when we stumbled onto the diagnosis, because he underwent an operation, had it not underwent an operation, we wouldn't have sent any tissue for his pathological examination, and we wouldn't have made a diagnosis. So that is the reason why I showed this case, that we need to have a very high degree of suspicion of fungal infection in these patients, especially when they have comorbid conditions, and especially if they have stayed in the hospital for a long time, and especially if they have had a spontaneous pneumothorax and they have had a ICD placed. So even an ICD place could probably give you a diagnosis of Aspergillus. It may not be a proven diagnosis, but it's still a probable diagnosis, but that is a way forward. And that is why I highlighted this case, because the diagnosis of COVID-associated pulmonary aspergillosis is quite challenging, and we need to have a very high degree of suspicion to even suspect this. Then we come to COVID-associated mucormycosis. The clinical presentations of mucormycosis depends upon the anatomical localizations. So we classify it as rhino-orbital or rhino-orbital cerebral mucormycosis. It could also affect the lungs, the gastrointestinal tract, the cutaneous manifestations are there. Renal mucormycosis has been reported in the literature, and obviously we have disseminated mucormycosis across the condition, except perhaps for rhino-orbital mucormycosis, the mortality or the outcome is very, very poor in all of these cases. With treatment or without treatment, they ultimately succumb, especially if the brain is involved. If there is renal or disseminated conditions, the mortality is almost 100%. While we know that uncontrolled diabetes is a risk factor for mucormycosis, the entity COVID-associated mucormycosis was hitherto unknown. So this is something which came to our knowledge only towards the end of last year, that is end of 2020. And then, of course, in the beginning of 2021, there was an absolute deluge of cases. Bombay, Delhi, Rajasthan, Gujarat, all over the places, there was a deluge of the cases, to the extent that even the drugs to treat them went into short supply. And in my hospital, I remember when I was doing another Zoom meeting, we had connected to this surgeon, the ophthalmic surgeon in the operation theater itself. And I asked her how many exentration has she done on that particular day. And she said till now 6 and counting. So you can imagine what a devastating condition this was. And so we did a retrospective analysis of data from September to December. Mind you, this was not the period when the deluge did come in. This is prior to that. And we included all proven mucormycosis cases who had had a recent COVID infection. When I mean recent COVID infection, it was less than 2 months of the presentation of symptoms from mucor. So we defined proven mucormycosis in subjects as compatible clinical radiological presentations. So the chest, the CT scan, and especially more than CT scan, we went in for contrast enhanced MRI to actually not only diagnose the condition, but also to decide upon the course of action that we would follow, whether we would do exentration, we would save the eye, whether we would go for really extensive FESs in these patients. And of course, for making the diagnosis, we had to demonstrate the fungi either in the biopsy or in the positive culture in sterile body fluids. So we enrolled. This was September to December 2020. That was last year. So we enrolled 90 patients at that time. Most of them were males. The median age was 55 years. The diagnosis was made after a median of 30 days after the first positive RT-PCR for SARS-CoV. Majority known cases of diabetic mellitus, but more than that, the median glycosylated hemoglobin level was 8.4. So most of them were uncontrolled diabetes, and there the possibility of steroid-induced diabetes comes in. So among other risk factors, steroid therapy during COVID episode was the most common, seen in 18 patients out of 19. The median storage dosage that was given to this patient, but this was before the time that we actually cut down on the amount of steroid given to the patients. So 2,400 milligram of prednisolone equivalent, and the range is huge from 800 to around 12,500. And the median duration of steroid therapy was 14 days. And this was again before the recommended duration was around 10 days. And you can see the range from 6 days to 29 days. And this was the duration of steroid that the patients got. And that is what I said, that during the second phase, this became even more pronounced, and we have seen patients getting steroids for longer than 90 days for some reason or the other. Since most of the cases were anorbital mucormycosis, you can see facial pain, facial swelling, visual disturbances, ptosis, fever, proptosis, ophthalmoplegia. These were the most common presentations that the patients showed. The other conditions, the rhino-orbital cerebral mucormycosis, where the mortality is very, very poor, the numbers were a bit less. We got a pulmonary mucor in one cases, sinonasal and sinopalatal, again, a very disfiguring kind of situation, especially after the operation. And they really had to undergo a lot of cosmetic surgery after this episode, in which we literally debrided all the tissue, just removed all the tissues almost ruthlessly. So diagnosis was confirmed by histopathology, either by the endoscopic nasal biopsy that was sent after debridement. Direct microscopy was positive in 14, so around 73.5%. Cultures, unfortunately, positive only in 5 patients. Around 25% of the cases, we could show a culture positive mucor. And as naturally, when we cultured very few cases, we could only make species level identification only in 5 patients. 4 of them were Rhizopus arises, and that was what we saw as the most common mucor species in this particular study. Liposomal amphotericin B was issued in all the patients, and surprisingly, of these 19 patients, 12, that is around 63%, or 3 out of 4 patients probably received posaconazole along with liposomal amphotericin B. There is no evidence as of now to suggest that combination therapy works better than liposomal amphotericin B alone. But in this particular instance, even in my hospital, most of the patients did get, probably the surgeons were a bit too, or we were a bit too, we didn't want to take any chances. We dumped them with 2 antifungal drugs. Isavuconazole was also done. Was also given in 1 patient, and surgical endoscopic debridement, we were very ruthless in that, was done in almost all 17 out of 19 patients. So the prevalence, as we calculated by the total number of COVID-associated mucormycosis divided by the total number of COVID-19 cases treated during that time. So we had a burden of around 5.47 CAM patients per 1,000 COVID patients. And majority, 15 out of these 19 patients were discharged. 3 patients succumbed to the infection. 1 patient left against medical advice. So we can say that 4 out of 19 patients died, leading to a mortality of 21.05%. And this mortality of 21% was compared to 13.9, or roughly 14% among all COVID patients. So you can see that the addition of COVID-associated mucormycosis, even in our series of patients who were reasonably well managed, even there, 1 out of every 5 patients died. And most of these patients were rhino-orbital mucormycosis, which is amenable to debridement and surgery. And obviously, in ophthalmic cases, they were amenable to exenteration. 7 patients also had exenteration in this series. The remaining 15 patients are alive at 6 and 12 weeks follow-up, which is what we did. And the number of COVID cases diagnosed were 9 in the same time during 2019, that is 1 year earlier, suggesting a rise of 2.1 times during the pandemics. And this was only the tip of the iceberg. And now we have seen in 2021, almost a deluge of patients of COVID-associated mucormycosis with horrendous mortality. And those who have survived with a lot of disfigurement, and they're undergoing plastic surgery for cosmetic corrections of their face and nose and palate and so on and so forth. So what I need to mention here is that the reason why probably we had a better outcome in this patient was because we were very proactive in taking up these patients for surgery as soon as we got a clear picture of mucormycosis. And that is, the patients were seen almost on an outpatient on a bedside basis. And an endoscopically biopsy was taken and was sent over for KOH mount. And this KOH mount, because of the close coordination between the entire mucor team that we had developed in the hospital, we got the report from the KOH mount within an hour. And the next morning, or even later during the day, we scheduled this patient for surgery. And we were very helped by the anesthesia department, who actually kept one operation theater running all the time, 24 hours a day, to take care of these patients. Culture and histopathological reports are not required for making the decision for intervention, and that is what we do. But yes, clinical finding and imaging. And imaging, by imaging, I mean a contrast enhanced MRI of the head, of the orbit, of the sinuses. All these things have to be done, and really it needs to be seen by a person who is constantly at it. And we have developed a team of radiologists who have developed their own protocol in which they mention what is the condition, what is to be done, whether exenteration has to be done or not, whether the sinuses have to be cleared, what extensive surgery is it, has the invasion gone into the cavernous sinus, into the brain, in which case they advise us not to go in for surgery and going for palliative cases. And as commonly expected, liposomal amphotericin B is the preferred treatment in the dose of 3 to 5 milligram per kilo. And after 3 to 4 weeks of amphotericin therapy, for which the patients generally stay in the hospital, the consolidation therapy with azoles, which could be either posaconazole or isavuconazole, is continued for a period varying from 3 to 6 months. And the decision whether to discontinue or to continue with this azole therapy is dependent upon the progress that we made on the contrast MRI report. And again, we were helped a great deal by our radiologist colleagues who actually told us the activity is still continuing. Our activity has come to a halt, but the lesion is still persisting. And only when the radiological clearance came through, we stopped the therapy. So what we concluded from this study that the number of cases of COVID-associated mucormycosis has gone up in the pandemic is presumably because of poor sugar control, presumably again because of high-dose steroid therapy, and finally, COVID-induced compromised immunity due to immune dysregulation and hyperinflammation in COVID-19 patients. And this predisposes these patients to the deadly fungal infections. With that, so these are my personal experience that I had in COVID-associated mucormycosis. I know there's a lot of literature going around and a lot of things, a lot of recommendations, a lot of guidelines have come in, but I wanted to share my own personal experience to this august audience, and I thank you for your patient listening. Thank you.
After that lucid talk on COVID-associated fungal infections, we'll go to the next talk, which is landmark research papers in COVID that changed clinical practice by Dr. Susruta Bandyopadhyay. Over to you, Doctor.
Myself, Dr. Susruta Bandyopadhyay from Kolkata. My topic today would be the landmark papers in about COVID-19, which actually changed our practice. Landmark research papers in COVID that changed our clinical practice. As we are going through this traumatic experience of COVID pandemic, and it was ravaging like anything, papers started pouring in, and there were, several thousands of papers which came into publications, some as research papers, some as even later, some observation studies, etc. But we had to pick out a few papers which actually made change in our clinical practice. The most important paper which I'd first bring your attention to is this was published in New England Journal of Medicine, and all of you think I've gone through it. It's the recovery trial. This is one of the largest trials in COVID-19 therapeutic trials, which compared dexamethasone as a steroid versus standard of care without steroid in serious COVID-19 patients. And this was mostly done in UK, and it was a double-blind, placebo-controlled trial, randomized. And hospitalized patients with COVID-19 were assigned to receive standard care or dexamethasone in 2:1 ratio. The primary outcome in this trial was 28 days mortality. Secondary outcomes were length of stay, need for NIV or IV in non-ventilated patients who were not initially ventilated, and successful weaning in ventilated patients. So the result verdict was very clear. You can see basically, if you go by mortality in all participants, dexamethasone had a definite lower mortality than usual care. And if you go by patients who were having invasive mechanical ventilation, the difference is even more marked. So more serious the patient were, more marked were the benefits. And this was only, the patients who were only on oxygen, they also had mortality benefit. And this was the patients who were not requiring oxygen. So here actually dexamethasone caused increased mortality. So the message was loud and clear that it was proven beyond doubt that steroids save lives in COVID patients. But it also gave another strong message that it should be only used in patients who are at least requiring oxygen. So patients who are not requiring oxygen, till they're not requiring oxygen, steroid actually caused harm. There was no scope of blanket prescription of steroid to patients who are not hypoxemic at home or outside hospital or something like that. Hospital-led patients requiring oxygen or ventilator support should be treated with oxygen. This was done with a dose of 6 milligram per kg once daily dexamethasone, oral or intravenous. We do not know whether this is the best dose or whether we could do with higher doses like DexA-ADS trial, or we could do with methylprednisolone, whatever it is. But the standard of care has changed our practice, and we are using steroids in all serious hypoxemic COVID patients. This is the mortality benefit. You can see across invasive mechanical ventilation patients, dexamethasone was much better. Oxygen only, even then dexamethasone better. No oxygen received, the dexamethasone, it actually was worse. Usual care was better. So the message is very definite, and we have changed our practice. I know there's a standard practice. Everybody uses steroid in the serious COVID patients. Next this is called the REMAP-CAP trial. This is basically, we knew that the two main pathologies in COVID were, one is uncontrolled inflammation, which actually killed the patients, and another one was possibly extensive thrombosis inside the vessels, which actually changed our physiology and which also killed patients. So many of the target therapies were targeted against this uncontrolled inflammation. And this study was really studying the IL-6 inhibitors, IL-6 being one of the main mediators of inflammation in patients. So there they studied two IL-6 inhibitors, sarilumab and tocilizumab, with control. And this were trial, you can see that this was a probability of survival and probability of survival in days. You can see basically this is the standard care, and this is the standard care control, and you can see tocilizumab had the best results. It was probability of survival was much higher. Tocilizumab in 31 days it has showed more survival benefit than standard of care. Even sarilumab was okay. And this was also initially the cutoff limit for this was the patient should show some signs of inflammation. They were usually used in patients with CRP of more than 70. So that was a strong message that these interleukins receptor blockers save life. Next, when we are having a shortage of this tocilizumab, a second drug came to the market. This was also targeting the inflammation, uncontrolled inflammation in the COVID. These were basically called Janus kinase inhibitors, and one good drug for this was baricitinib. It was previously used for other purposes, mostly arthritis, but now it was used for COVID. And this is the COVE barrier trial. In fact, another trial was done before this, which was called the ACT-2 trial. In that case, this baricitinib was used along with remdesivir, but without steroids, and showed some benefit. But the main criticism was that it did not show a difference in the primary outcome, and it was not used with the standard care, that is a steroid, which was standard care by that time. So people were arguing that whether it is a steroid sparer or whether steroid at all, adding to steroid to this would make any difference ultimately or not. So to alleviate these doubts, we had this trial. This is called the COVE barrier trial. This was a double-blind randomized placebo-controlled trial. Baricitinib and placebo were given in 1:1 ratio for patients who needed oxygen. So again, the cutoff was that patients should require some oxygen, otherwise no use giving them. Already it was proven in ACT-2 that patients who do not require oxygen may not benefit from baricitinib, will not benefit from baricitinib. All patients receive standard care, that is dexamethasone, antivirals. And composite primary endpoints were the patient's need for going into HFNO support or non-invasive ventilation support or invasive ventilation support or death. So you can see that baricitinib in the placebo group, this progressed to high flow oxygen, non-invasive ventilation, invasive mechanical ventilation, including more death by day 28. Definitely there was a good trend towards benefit with baricitinib, although it was not statistically significant. But the key secondary outcome, that all-cause mortality, there was a definite statistically significant difference between the baricitinib group, almost 764 patients, and versus 761 placebo group patients. And this was, again, beyond doubt that this baricitinib makes a difference, that it was an oral tablet given for 14 days. So that also changed our practice. Overall population, you can see the placebo group, blue, and baricitinib group in red. You can see a definite difference in mortality. and this NAID score 6, that means people who are receiving NIV or high flow nasal cannula oxygen, this group, the difference was even more marked between the control group and the baricitinib. So again, the message was loud and clear, and we right now are quite free to use baricitinib in patients who are receiving oxygen or receiving higher ventilatory support. Next, 2 papers came back and back. This was the other part of this COVID pathology, which tells us that the major pathology may be uncontrolled inflammation and uncontrolled thrombosis in smaller vessels, and which causes the main damage to the body in COVID patients. And maybe our ARDS may be also maybe because of this too much of thrombosis. So here the studies were done with therapeutic anticoagulation with heparin in non-critically ill patients, and another one was therapeutic anticoagulation done with heparin critically ill patients COVID-19. By this time, these patients, our practice was like that when they compared with standard care. Many of the standard care patients were receiving heparin. If not full therapeutic dose, they were receiving an intermediate dose, say 40 subcutaneous to SDD of enoxaparin. And to that, this was compared. The study results were a bit surprising in the sense that in the critically ill patients, there was no mortality benefit, but this therapeutic anticoagulation heparin non-critically ill patients, moderate ill patients, it had definite therapeutic benefit. But there was an editorial which argued that it might be so that the critically ill patients were already so advanced in their disease process, and at that time adding heparin or low molecular heparin. In fact, most of the patients that received low molecular heparin in these studies did not make much difference. Another argument was that already these critically ill patients were receiving at least intermediate heparin that was in the standard care group. So they again that did not show much mortality. But definitely both these trials, they tell us that we should be using heparin in patients with COVID, and if they're moderately ill patients, it should be either intermediate or full dose of heparin or equivalent, that is low molecular heparin. So these were the papers with positive results. And I don't have the time, but there were some papers which made us to change our practice with negative results. One was the uselessness of HCQ hydroxychloroquine. And then there was the solidarity trial from WHO, which right now shows possibly remdesivir does not make much difference, though we have not taken any decision of that, but that is one trial. So these are the significant landmark trials which have changed our practice or may change our practice in the near future in relation to COVID-19 patients. Thank you.
After that informative talk, we'll now move on to ECMO in COVID and whether it is futile. The talk is by Dr. Sandeep Diwan. Over to you, Dr. Sandeep.
Hello, I'm audible? Yeah. Good afternoon, everybody. In the next 10 minutes, I'll be talking about ECMO and COVID, and my aim is to just throw some light on what the literature says, whether it's a modality that can help or whether it is futile. So we all know the pathophysiology of refractory hypoxemia in COVID. It's basically the invasion of pneumocytes by the virus leading to viral application, fluid accumulations, and leading to forceful breathing, hypoxemia, and in certain cases, it involves other organs leading to shock. Historical perspective has shown that ECMO has worked in various kind of pandemics, starting way back in 2009 from H1N1 to a Caesar trial, which showed the benefit of ECMO, in 2009, then its benefits in influenza in a cohort study in 2011. Then came the Eolia trial in 2018, which was a multi-center trial. Although it was a negative predictive trial, but still threw a lot of light on ECMO and its use. And then in 2018, there was a retrospective study on MERS, which shows that it has benefits in managing these patients. Coming specifically to COVID, this is a meta-analysis and a systemic review of literature, which came as early as last month by a group of investigators from Singapore and their colleagues, where they actually identified about 3,000 PubMed database and came across 22 studies, which they ultimately included in the meta-analysis to show whether ECMO has been till now proven to be of any benefit in patients with ECMO in COVID. So their outcome was that in-hospital mortality in patients receiving ECMO was 37% during the first year of pandemic. So please remember, whatever literature has come till now is showing the first year of the pandemic. Increasing age was definitely a risk factor for mortality. Venovenous ECMO appears to be an effective intervention in selected patients with COVID-19 ARDS. To outcomes from VV ECMO in COVID-related ARDS are similar to those related in non-COVID, but this was the first year. The duration of ECMO, it says, was definitely prolonged in patients with COVID-19 as compared to patients where there was non-COVID hypoxemic patients. And in their data, when they did the meta-regression analysis, 3 factors came out to be independent predictors of mortality, which was the duration of ECMO, age, and body mass index of more than 40. So these 3 parameters were clearly, according to this meta-analysis, throwing some light of what kind of patients would not do well on ECMO during COVID. So obviously, selecting the younger population and preferably age less than 65 would be the ideal category of patients according to this meta-analysis. This is another study which throws some light on ECMO in COVID-19, and it's a cohort study from ELSO registry. Again, a large study which actually enrolled patients, about 1,035 patients, again a retrospective cohort from 36 ECMO centers all across the world. And if one looks at this study closely, if you look at the left side, patients who were discharged alive to home were approximately 30%. So it divided patients into 2 cohorts, full cohorts, which had ARDS but had other problems also. And then there was about 780 patients who were pure ARDS cohort, who met the criteria of ARDS. 34% was the overall patients who were survived to home or acute rehab centers. Approximately 10% patients were sent alive to long-term care centers. 12% were discharged to another hospitals, or we can say LAMA, and about 5% remained in the ICU at the time of this study, and 47% and 37% were the in-hospital death. So overall, this study had shown that yes, a lot of patients did get benefit from ECMO, but there is a whole cohort of patients that we are dealing with, and this is what we have seen in India also, that although the ECMO runs are very long, a lot of patients will maybe be weaned from ECMO, but they will continue to stay in long-term associated facilities and may ultimately not make it, but that cohort has not been factored into this study. So they only looked at the mortality in the hospital, from the hospital, and discharged to home at 90 days. Overall, if you see, they said that the mortality in COVID and ECMO is less than 40%. Looks like a overstatement, because it doesn't factor, as I told you, the patients which are going into long-term care facilities. And they also said that our results are consistently with previously reported survival rates in acute hypoxemic respiratory failures, which supports the current recommendation that centers experienced in ECMO should consider its use in refractory COVID-19 related respiratory failure. This is a very small study in perfusion, again came in 2021, study of 16 patients, but a very good center in Germany, which did a retrospective analysis of its outcomes of patients put on ECMO. So they had put ECMO in 16 patients, and they looked at a 6-month survival of these patients, and 11 had survived. Out of that, 4 patients required short-term ECMO, which was less than 28 days, and 7 required prolonged ECMO support, which was more than 28 days. So although survival was good, but they also said that viral load during the first few days on ECMO tended to indicate worse outcomes, and seroconversion had nothing to do with the ECMO outcomes. So to conclude, this group said that VV ECMO in COVID-induced ARDS is justified if initiated early and at an experienced ECMO center. Prolonged therapy might be required in these patients. And when we look into the details, some of the patients have actually been on ECMO for 2 months, 2.5 months. So they said that decision to stop therapy should not be made dependent on the length of ECMO treatment, because a lot of patients after long ECMO runs do come out. Another study which came in August, this is 20, ECMO in respiratory failure. This was in JAMA. Again, shows about the experience of this ECMO group in the first wave of pandemic. And they showed extremely good outcomes, which actually were not there in the second wave. And they showed 73% were discharged after ECMO support and not even requiring oxygen therapy. The group said the complications had been minimal. There were very less ischemic strokes, inotropic support and tracheostomy requirements, and mortality was only 15%. In this study of retrospective analysis of 40 patients, they used single access dual stage ECMO cannulas, and they said that ongoing studies are required to further define the long-term outcomes of this approach. So fairly successful ECMO run of 40 patients, but as I said, all these are during the first wave of pandemic. This is again in JCTBSA, Journal of Cardiothoracic and Vascular Anesthesia, looking at 6-month survival after ECMO for severe COVID, and said that about half of the adult patients with severe COVID-19 can be managed successfully. So this study shows about 50% patients did well and 50% did not make it. So overall mortality was not as low as has been documented in certain studies, but not as high also. Survival is not as high as we aim in influenza or H1N1. What does the ELSO say about this? So ELSO came up with a consensus document for interdisciplinary group of ECMO providers, and this is the umbrella organization which takes care of the ECMO outcomes all across the world. And all the studies that I have shown till now are from that registry which ELSO runs. And they said that ultimately the ECMO has to be decided by the facilities that the institute has available, the staff safety, whether they have people or the equipment to manage such a high load of ECMO cases, and ultimately there are ethical issues also involved in what would be the right patients to select for ECMO. As per the ELSO, these are the current indications: refractory hypoxemia with worsening hypercapnia despite lung protective ventilation or prone positioning or high PEEP. They have included inhaled nitric oxide and HFNO also, HFOV. And ARDS or ongoing requirement for vasoactive drugs, whether it's septic shock or cardiogenic shock. They've also listed a whole lot of contraindication, and the most important they have seen is mechanical ventilation of more than 14 days before ECMO initiation. And this is where I think in India, we had a lot of difficulty, because most of the time that we got ECMO calls, the patient had been on BiPAP or NIV for at least 14 to 15 days. And the physician, the intensivist were afraid of putting them on ventilators. I think this is where one needs to change one's clinical practice to ventilate them early, and if they are not able to maintain on mechanical ventilation, go for an ECMO in preferably less than 14 days. Coming to ethical issues, it's a very technical therapy, very resource intensive. So every institute will have to think whether they want to run a program which uses so much of the resources rather than concentrating on managing the general critical care COVID patients, which all institutes were overloaded in the pandemic. So the ECMO also recommends involvement of supportive therapies, palliative care teams, and in which have been done in VA, VA, and VV. All kind of ECMOs have been tried in various scenarios, right from hypoxemic respiratory failure to cardiac shock to multi-organ failure. As for our experience in COVID in this wave 2, total runs we have done in about 34 centers, because we at Fortis Gurgaon are not a transplant center. The patients who survived before transplant were 11, which is about 30%. Early stoppages were there because of unwilling family. As I told that in COVID, the ECMO runs have been really long, and they have been extended to as long as 1.5 months, 2 months. So 8 families actually did not agree to continue ECMO, because neither they wanted to consider transplant, neither they wanted to continue with the therapy. So these patients ultimately died. So we never know what would have happened to these patients. 5 patients we sent to transplant centers. Out of this, 1 improved on waiting for organ transplant. So, and the 2 received transplant and 1 were discharged, and 1 is still in the list. So overall survivor is about 40%. But if we include these 8 patients where we stopped early, because in US or Europe, the cost is not an issue. They don't stop the ECMO runs. In India, the situation is different. But yes, we are still learning in our ECMO journey. But definitely we believe that ECMO can be an alternative if given early in the patients of management of refractory hypoxemia. So my take on ECMO in COVID, data is still evolving. It is not a futile exercise, but yes, it's very extensive and laborious exercise. It's a modality which requires a lot of resources. Long ECMO runs will be needed, unlike H1N1 or influenza. Cost is a very, very big issue as the duration increases. And ultimately, if these patients persist with the ECMO, patients pays in the end. With that, I thank you, the organizers, for giving me the opportunity to give this talk.
Thank you, Dr. Sandeep. As there are no more questions, we'll move on to the next topic. Thank you. The next session is on sepsis epidemiology. We have a talk by Dr. Balaji on prevalent resistant genes in gram-negative sepsis, Indian perspective. Over to you.
Good afternoon, everyone. I am Dr. Balaji from Christian Medical College, Vellore. For the next few minutes, I am going to talk about the prevalent resistant gene in gram-negative sepsis, Indian experience or Indian perspective. Okay, for the next few minutes, I am going to talk about gram-negative pathogens, the most common problematic pathogens such as E. coli, Klebsiella, Pseudomonas aeruginosa, and Acinetobacter baumannii. So first, I will start with the E. coli. You all know that E. coli is the most commonest gram-negative sepsis causing organism. As of now, today, it looks pretty safer to treat compared to Klebsiella, Pseudomonas, and Acinetobacter baumannii. But however, we are having certain concerning issues which I will be narrating in the next slide. Okay, so in the Indian scenario, the E. coli, currently the ESBL rates is 70%, and this 70% of ESBLs are due to 50% due to TEM1B, and the remaining are CTXM15. Apart from ESBLs, E. coli possesses OXA1 inhibitor, that is, it is resistant to clavulanate, sulbactam, and tazobactam. So this is a quite big number, where the combination of clavulanate, sulbactam, tazobactam antibiotics may not be very effective. Then along with the OXA1, majority of the isolates has got inhibitor-resistant TEM. So it's a variant of the TEM which resists the inhibitors like clavulanate, sulbactam, tazobactam. So in this situation, the MIC of piptazo and amoxiclav seems to be elevated. And when you try to treat with the piptazo or amoxiclav, there won't be a success. So that is contributed by OXO1 combination with IRT enzymes. And now moving on to the carbapenem resistant E. coli, close to 70% of this carbapenem resistant E. coli also carry penicillin binding protein 3 insert. It's a modified insert which prevents the binding of cephalosporin or carbapenem or penicillin. When the binding of antibiotics to this penicillin binding protein 3 is prevented or modified, its effectiveness drastically comes down. And you all know that frankly, the carbapenemase itself is very challenging, especially in India, where NDM, metallo-beta-lactamase, New Delhi metallo-beta-lactamase is present. And in India, we do see commonly the variant 5, NDM5. And 20% of the E. coli with the NDM, they too have OXA181, which is a variant of OXA48. Absolutely, hardly we come across KPC in India, and colistin resistant is close to 8%. This is the Indian scenario. Compared to this, globally what we see is in the United States, you can see that ESBL rates are 16.4. In Europe is much lower. Whereas in Asia Pacific, New Zealand, Australia, those countries, the PSBL rates are much, much lower. In certain countries, it's a high up to 15.2%. So India and China are the epicenter of antimicrobial resistance. Again, something similar to India, we do have TEM and CTXM15 as the enzyme responsible for ESBL. And the OXA1, again, like India, elsewhere also it's quite significantly seen. Anyhow, inhibitor-resistant TEM is rare. And there is no much data available from the global scenario on penicillin binding protein 3 insert. However, it's started increasing over the time. In the last few months, I could see many papers appearing in all the leading journals. And you can see among the carbapenemase, United States is predominantly KPC, and in Europe, it's predominantly OXA48. No NDM is in. It's unique to India, NDM, Indian subcontinent especially. Why we have to insist is there is no specific drug to treat NDM. And colistin resistant is less than 1%. And targeted therapy, how to treat is with the high prevalence of OXA1 and IRT in India, it's better to avoid piptazo in critically ill patient. And if it is E. coli has got only one enzyme, OXA48, then the best drug to treat is ceftazidime avibactam. However, if NDM or PB3 insert is found, then ceftazidime avibactam is not going to be good. If NDM and OXA48 is there, both ceftazidime avibactam may not be good, but however, when you had ceftazidime avibactam plus aztreonam, it will be very effective. So as of now, colistin, tigecycline, ceftazidime avibactam, aztreonam are the three leftover choices to treat carbapenem resistant E. coli in our scenario. However, there are other two drugs. One is already FDA approved, that is cefiderocol. If it is available, then it will be very effective. Cefepime ziribactam, it's in the phase 3 trial. It's not available. If it comes, the in vitro studies is very promising. That will be very effective for Indian scenario. Of course, the alternative at present to ceftazidime avibactam plus aztreonam in India is either tigecycline or colistin. I'll move on to the Klebsiella. Klebsiella, the trend as of now is Klebsiella resistant is predominantly due to OXA48. But gradually over the time, what we are, the trend is seen is the OXA48 is also seen, means OXA48 is accompanied with NDM. So two powerful enzymes are there. And NDM alone, the incidence is also increasing. So all this, the two components of the three components, two components are in the rise. And compared to E. coli, 15% carbapenemase resistant, for Klebsiella pneumonia, we do see 40% carbapenemase resistant. Unlike E. coli, we don't see OXA1 PB3 insert or KPC. However, in Klebsiella specifically, apart from the carbapenemase, is seen accompanied with outer membrane protein deficiency K, that is porin deficiency of 35 and OMPK 35 and 36. And this is mainly seen along with the NDM and NDM plus OXA48, but this OMP deficient is not seen with OXA48 alone secreting enzyme. The common among the OXA48 in Indian is OXA232 and 181. This is very important because the OXA48 enzymes are borderline, closer to the susceptible or just above the resistant. Whereas for 232 and 181 variant, the MICs are quite high. So it's quite challenging to treat. Global scenario, something what we see in India only, across the globe we are seeing. However, the enzymes are different. In Europe, it is KPC. Sorry, in United States, it's KPC. Europe, KPC followed by OXA48. But no NDM is seen. Only in tourist and in isolated pockets, you do NDM. It's more of an epidemic than endemic. And of course, porin loss, as I mentioned to you, 40 to 50% elsewhere also seen. So as of now, if it is OXA48 alone, ceftazidime-avibactam is the best therapy. If OXA48 is combined with NDM or outer membrane protein K35-36 deficiency, porin deficiency, then the best choice will be ceftazidime-avibactam plus aztreonam. The alternatives is tigecycline and colistin. So a very limited choice we have for both E. coli and Klebsiella for carbapenem-resistant bugs. Most important thing what I would like to advise is the solution for this is you need to give ceftazidime-avibactam as a best choice for both E. coli and Klebsiella if OXA48 alone is there. Suppose if OXA48 is combined with the NDM and other mechanism is also found, then the best choice is ceftazidime-avibactam plus aztreonam, the first best choice. Second is tigecycline, third is colistin. And depending upon the nephrotoxicity and the severity, you can take a call. So when you are giving ceftazidime-avibactam plus aztreonam, the importance is it needs to be given concurrently. Even the IDSA guideline says that both needs to be infused together, and the infusion should go for 3 hours, and the dosage is Q8H. So there are many number of studies have been done, and they have ruled out that there won't be any problem when you are mixing up these two drugs. So physical compatibility between these drugs are there. And if you fail to mix up this drug, give together, infuse together, then definitely there won't be any protection of ceftazidime-avibactam from either of the carbapenems, OXA48 or even NDM. NDM means aztreonam will not be protected against OXA48. So vice versa it happens. It's very important that you need to give both together. Now I move on to the Pseudomonas aeruginosa, which is difficult to treat. I know 80% of the isolates earlier it used to be susceptible and only 20% resistant, but things are changing over here. Now we are seeing gradually more and more percentage of isolates are becoming resistant to drugs across all the classes. So that is the important point you need to know. So usually it is across all the classes, resistance is rising for Pseudomonas aeruginosa. The common ESBLs we see in Pseudomonas aeruginosa is Web, TEM, and JES. And among the carbapenems, both are metallobeta-lactamase, that is WIM and NDM. Apart from this carbapenems, the Pseudomonas aeruginosa, apart from this metallobeta-lactamase, it has got an additional 3 more resistant mechanism, that is inducible AMPC or intrinsic AMPC, porin loss, and hyper-efflux expressions. So all these 4 mechanisms causes 70% of the XDR resistance in India, whereas globally, we don't see this much of 4 mechanisms combined. Usually it will be efflux, porin, and inducible AMPC or intrinsic AMPC. Usually they don't see metallobeta-lactamase. This Western profile is seen in India only to 30%. Majority of them are associated with metallobeta-lactamase. So our experience is it's quite challenging to treat this variant compared to the non-metallobeta-lactamase variant. So there is a huge difference between the occurrence and the treatment approach we carry out. So the experience for this type, even in abroad in the literature, are very minimal. So as I explained to you the Indian and global scenario, I move on to the targeted therapy. Here, beta-lactamase inhibitor cannot alter resistance due to porin loss and hyperreflux. So the beta-lactamase inhibitor role are very minimal, and it's restricted only to two BLIs. That is, one is ceftazidime avibactam and ceftolozane tazobactam for only non-metallo-beta-lactamase variants. That is this 30% alone. So it's very imperative for a clinician when they have a Pseudomonas aeruginosa either as a bloodstream infection or ventilator-associated pneumonia, you need to look for the presence of VIM or NDM. So this will determine the approach of giving therapy, the choice of the therapy. If it is metallo-beta-lactamase, then ceftazidime avibactam is of no use. Ceftolozane tazobactam we don't have in India, and it won't work against metallo-beta-lactamase also. So you have left with no choice other than colistin and other combinations. The suitable drug as of now is best choice is cefiderocol. Unfortunately, it's not available in India. Earlier for Klebsiella, we said for metallo-beta-lactamase, we can combine ceftazidime avibactam plus aztreonam. But that combination, what works in Klebsiella may not work in Pseudomonas aeruginosa, because this hyper-efflux and porin loss pumps out all the aztreonam. So no way this combination will work for Pseudomonas aeruginosa. So none of the beta-lactamase inhibitor is going to work against this hyper-efflux and porin loss, as I mentioned to you earlier. The only choice is cefepime-zidibactam, which will take time to come to the market, and the cefiderocol, which has been approved. If it comes, that will be more useful. So that is the current Pseudomonas aeruginosa trend. Now I move on to the last bug, Acinetobacter baumannii. It's a giant killer. The Indian scenario, almost 70 to 80% of the carbapenem resistant isolates produces OXA23, almost 90% I should say. Almost 100% are having OXA23, and this OXA23 is promoted by the insertional sequence, upstream insertional sequence, where the MIC goes really high. And apart from this OXA23, 30% of the Acinetobacter baumannii is accompanied with the NDM1. So it's becoming a double whammy to treat both the enzymes together. We know that we don't have antibiotic specific to NDM1, and more so we don't have for OXA23 also. So it's really very challenging to treat XDR Acinetobacter baumannii. And
There is some technical issue in this talk. So we'll go on to the next topic. The next session is on sepsis diagnostic. And we have an interesting lecture by Dr. Jean-Louis Vincent on detecting early sepsis clinically. Let's move on to the next topic.
Oh, it's a pleasure to be with you, not in India, but in some part of the world, to discuss the important topic of early identification of sepsis. The point is that we need to identify sepsis early if we want to prevent complications. Sepsis kills if recognized too late. We need to act promptly and efficiently with infection control, with antibiotics, source control, and if needed, with hemodynamic stabilization. Before sepsis becomes what the ancient Greeks called putrefaction. Sepsein is a Greek word to indicate that things are really close to death due to an infection. So it's a bad infection. Microorganisms do not kill so fast. We have learned it over the years. It is a dysregulated army, dysregulated host response, which is responsible for the organ dysfunction associated with the infection. When we are called for a septic patient, the resident is likely to insist it's a septic patient, indicating the seriousness of this problem. And if you like to ask any resident what he or she means by sepsis, it will be an infection plus some form of organ dysfunction. People sometimes confuse definitions and criteria. Pneumonia is a lung parenchymal infection. There are specific criteria. For meningitis, likewise. For myocardial infarction, what is a myocardial infarction? We will not say it's an abnormal EKG associated with high troponin levels. So why do we do it differently for syndromes like ARDS or sepsis? The definition of sepsis is a deleterious host response to an infection leading to organ dysfunction. Now, if you want to have criteria, then you move on, as we did in our consensus meeting, and you may say that for a scientific publication, you need to have some increase in SOFA score. For the general public, you could simply say that sepsis is a life-threatening condition that arises when the body responses to an infection injures its own organs. So that's the very important concept. Colonization, no host response. Infection, there is a host response. There is typically fever, an increased white blood cell count, an increased CRP level or procalcitonin level, reflecting the host response. But sepsis is more than that. There is now organ dysfunction associated with it. And in the most severe condition, we will speak about septic shock, where there are signs of altered tissue perfusion, increased blood lactate levels, and need for vasopressors. Shock will be characterized by an altered mentation, by altered skin perfusion, by decreased urine output, and increased lactate level. So hypotension is usually present indeed, but it is not the only sign of circulatory shock. And of course, sepsis can occur without septic shock. This is the most important slide of my talk. We need to recognize that sepsis is sometimes identified because the patient develops signs of infection. as I mentioned, fever, possible alteration in organ function, host response, positive bacteriology. And then we look for an associated organ dysfunction. But sometimes, as we all know, it is the other way around. The patient developed some form of organ dysfunction, and we do not know really why. Then we look for the possibility of an infection. We could draw some blood cultures. We could do another CT scan or a simple X-ray to try to identify an infection. So we start from organ dysfunction, and if it's not well explained, we look for an infection, because that would be sepsis. And when we say we look for organ dysfunction, there are 6 organs that we evaluate. Circulatory, of course. Is there hypotension? Is there an increase in lactate levels? Respiratory, of course. Renal, of course. It could be neurological, an alteration in mentation. It could be very minor, but that could be an important sign. Sometimes it is just a hematological problem, typically a decrease in platelet count. And sometimes there is some liver dysfunction, not liver failure, liver dysfunction, with some increase in bilirubin levels and maybe liver enzymes. That's all. 6 organs to consider. You may say it could also be an increase in blood sugar, reflecting a metabolic alteration, but this is really very poorly specific. So my colleagues wanted to simplify the recognition of organ dysfunction. And that's how we introduced the quick SOFA, the Q-SOFA, which includes simply tachypnea, hypotension, and altered mentation. This would help to identify patients with a poor outcome so that we could start additional tests to evaluate organ function, could promote intervention quickly, and it could increase surveillance with the possible need to transfer to ICU. I am not really a keen supporter of quick SOFA. First, because people tend to forget what it is. What was it? Tachypnea and tachycardia? No. Hypotension. Okay. And then, altered mentation. And second, it's not specific for sepsis. Not at all. But, is looking at the 6 organs so complicated that we need to simplify it? I prefer our young residents, students, nurses to keep the 6 types of organ dysfunction in mind. It's not so much to learn. But the Q-SOFA actually brought some confusion because people thought, SIRS is over, now it's the Q-SOFA. No. SIRS has never been helpful and has been now abandoned. We can forget about SIRS. And Q-SOFA is not part of the sepsis criteria. It is a simple alarm signal. So sepsis is a form of severe infection. Q-SOFA may be a sign of severity of sepsis, but it could be found in severe heart failure, in pulmonary embolism, in hypovolemia, like in trauma. I was pleased to read that paper showing that in trauma, the Q-SOFA has an excellent prognostic value. Of course, if your trauma patient becomes confused, hypotensive, tachypneic, of course, it's not very good. So, you could use the Muse, like in the UK or other countries. It's also the respiratory rate, the blood pressure, the conscious level, and here they add the hourly urine output because the information can be collected on the floor. This is another interesting paper showing that nurses in that institution could actually collect data like capillary refill time, blood lactate level, platelet count, urine output. And by doing it, they could improve the outcome of acutely ill patients on the floor. So it's a team approach. It's not just a medical approach. We need to tell our colleagues from any department in the hospital that they must understand the concept of infection plus organ dysfunction or organ dysfunction plus infection. And our nurses at the bedside should be able to identify a problem and call us. Even the relatives may identify the altered mentation. My mother, my father is now confused, and it was not the case before. Aha, listen to them. It may be sepsis that is ongoing. Now be careful. I'm speaking about elderly patients. All patients in sepsis are not in their young age, like this lady. It's not always like this. There are people who may develop sepsis at the very end of their lives, and they may not need resuscitation. Muhammad Ali developed sepsis at the end of his life, but he had terminal Parkinson's disease. So, at some point we will all die. And if it's at the end of our life that we develop sepsis, we need to let it go. Does my mother really need that central line? My mother has terminal Alzheimer's disease. Let's be good doctors. Pneumonia is the old man's friend, as William Osler told us more than 100 years ago. So I'm telling you, I would like to die from sepsis in 35 years from now. So in summary, colonization, no host response. Infection, there is some host response. C-reactive protein, CRP, PCT are markers of the host response. We call sometimes them sepsis markers, but they are actually infection markers. Sepsis is a severe infection associated with some degree of organ dysfunction. Can someone be infected and non-septic? Of course. Can someone be septic without an infection? Of course not. Sepsis is a bad infection. If you work in an emergency department, a patient with fever and tachycardia, with malaise and muscle pain, forget about COVID. If you think it's viral, just send the patient home. If it's fever, tachycardia, dyspnea, increased white blood cell count, and a localized chest infiltrate, probably pneumonia, send the patient to the regular floor. If there is peritonitis with oliguria, hypotension, sent to the ICU unless there are therapeutic limitations. Sepsis is infection plus organ dysfunction. How do we recognize infection? By three paths, really. Is there an organ that may be a source of infection? Is there a systemic host response? Do we have some microbiological findings? Recognizing infection is very important because it will require antibiotic therapy and sometimes source control. If there is associated organ dysfunction, we need to send the patient to the ICU. We need to consider a better hemodynamic management to improve tissue perfusion. But sometimes it is the unexplained organ dysfunction that comes first. The patient doesn't seem well. Are you sure it's not an infection? Maybe we need to go over the source systemic host response, microbiological finding. Because if there is an infection associated with the organ dysfunction, we will speak about sepsis. It is as simple as that. There are 6 types of organ dysfunction. They are all, again, represented here. Keep them in mind. It's not very complicated, and it's very helpful. Thank you.
After that entertaining and informative talk by Dr. Louis Vincent, we'll move on to the next talk in sepsis diagnostic, increasing yield of blood culture by Dr. Pallab Ray.
Blood culture. Now, what I am going to talk about, it will be applicable to the automated blood culture systems, which are much more standardized, quality controlled, rapid, and more sensitive, and they may not be equally applicable to the in-house standardized manual methods. Blood culture is considered as the gold standard and the first-line tool for detecting bloodstream infections, identification of pathogen, and antibiotic susceptibility testing. Physicians significantly overestimate likelihood of bloodstream infections, which is reflected in the fact that only 5 to 13% of blood cultures are positive, and of those 20 to 56%, they represent contaminants. Consensus guidelines and recommendations for optimization of blood culture has been available for a long time. CLSI has got a dedicated 47A document for optimization of blood culture. It ensures optimal procedures, but practices often deviate from recommendations. When do we order a blood culture? The most common indications include fever, chills, leukocytosis. These are the signs and symptoms of a host of syndromes, most of them non-infectious. Of course, infection also gives rise to any one of these or all of these. The other indications include sepsis, infective endocarditis, and before preemptive or empirical antimicrobial therapy in elderly or immunocompromised patients. Let us come to timing and site of blood collection. Blood specimens should be collected before starting antimicrobials around the time of fever spikes. It has been seen that bacteremia precedes the fever, and therefore, if we wait for blood cultures to be collected at the peak, which is again unpredictable, then we might miss the peak of the bacteremia. And after the peak, the organisms, they rapidly decline because they're removed by the phagocytic cells. And therefore, they should be collected rather without delay whenever there is an episode of chill or fever. So, the subsequent blood cultures can be collected at intervals of 30 to 60 minutes between sets. The sampling site can be peripheral venipuncture or intravenous catheters, but peripheral venipunctures have a contamination rate which is half that of intravenous catheters, and therefore is the method of choice, with the exception that in central line associated bloodstream infections, both are simultaneously collected. Meticulous skin antisepsis diminishes contamination to 3% or below our target of contamination rates. Alcoholic antiseptics are better than aqueous products. Alcoholic iodine tincture is better than alcoholic povidone iodine. Alcoholic chlorhexidine gluconate is better than aqueous povidone iodine. Even studies have shown that alcohol alone is not less than any iodine products in efficacy. CLSI recommends chlorhexidine in alcohol for infants more than 2 months, children and adults. There are studies which have shown that choice of antiseptic has a minor impact on contamination. Rather, a dedicated phlebotomy team has got a much better impact on reduction of contamination rather than choice of antiseptic. Blood volume has got an immense impact on sensitivity of blood culture. The higher the blood volume cultured, higher is the sensitivity. Volume of blood culture is the most important parameter because bacterial and fungal load in blood is pretty low, of the order of 0.01 to 1 colony forming units per milliliter in half of the cases of bloodstream infection. So if we take a median value of 0.1 CFU per milliliter, and we consider that when we have 3 CFU sampled, we get a sensitivity of 95%. Mathematically, it comes to the fact that we need more than 30 milliliter of blood to be sampled. And there are many studies which has tried to correlate the volume of blood with the percent positivity. And you can easily see that to get a 90% sensitivity, the blood volume has to be 40 milliliter or more. Recent studies have shown the relationship between blood volumes and sensitivity. 20 milliliters, 2 bottles, 70%, 40 milliliters, 4 bottles, 85%, 60 milliliters, 6 bottles, more than 95%. Most of the international societies for microbiology or critical care medicine, they have also shown that we need at least 2 sets and a maximum of 4 sets. Each set is 1 puncture and each set should have at least 2 bottles. So at least 2 bottles per set, between 2 to 4 sets for a proper blood culture. In the developing countries, including India, only 2, rather more often only 1 bottle in 24 hours in adults, which is also called the solitary blood culture, is discouraged in all guidelines. And it has a sensitivity much below 70%, often below 50%. How do we ensure the adequacy of volume of blood? For optimal sensitivity, there are 2 strategies. One is the multi-sampling strategy. By increasing the number of venipunctures, we have 2 or 3 events. In each event, we collect 1 set of blood culture bottles. So each set should have at least 2 to 10 milliliters each. So in 2 to 3 sets, we collect 20 plus 20 or plus 20, 40 or 60 milliliters of blood. The other strategy is the single sampling strategy, where at one go, we collect 40 to 60 milliliter of blood and distribute it equally to 4 to 6 bottles. The multi-sampling strategy is based on repeated samples will increase volume of blood cultured, will increase sensitivity. Separate samples also improve BSI detection in intermittent bacteremia and discriminate contaminants versus pathogens. Now, some of the organisms, they are nearly always true pathogens. Some of the pathogens are nearly always contaminants or rarely true pathogens, like the diphtheroids, the Bacillus species, Propionibacterium or Cutibacterium. The main problem arises with the indeterminate category, the coagulase negative Staphylococcus, the commonest and most confusing. It can be significant, may not be significant. Some people also add viridin streptococci and enterococci in the same group. So we differentiate on the basis of number of positive blood culture samples when a common contaminant like coagulase negative staph, diphtheroids or micrococcus grows. Multi-sampling strategy has got problems. It has a poor compliance because it increases and therefore it increases solitary blood cultures. More difficult to distinguish contaminants from pathogens because each venipuncture leads to additional risk of contamination. And the concept of intermittent bacteremia or fungemia, it's considered to be more theoretical, never has been proven with evidence. The single sample strategy, it collects the total volume of blood from single draw, 1 set of 4 to 6 bottles. It ensures sufficient volume of blood, which is the key determinant of sensitivity. It decreases contamination, workload, risk of exposure to blood transmissible pathogens, decreases risk of solitary blood culture, leads to more compliance, decreases cost, increases comfort for patients, and it gives you a chance for early initiation of empirical antibiotic therapy. Sometimes we get false positive blood culture bottles. That means there is a false positive signal flagged positive by the system, but no microorganism grows after subculture. It happens in 1 to 2% of the bottles. It requires quick handling and re-incubation. The major causes include high level of leukocyte counts, overfilled bottles, errors in incubation or inappropriate algorithm by the system. And when we have fastidious organisms which show limited growth in the bottle, but on subculture, they have very exotic demands of either anaerobic environment, microaerophilic environment, or some nutritional supplement or prolonged incubation. We regularly grow Campylobacters, Helicobacter by providing microaerophilic environment when incubating the plates. Anaerobes in anaerobic environment, we regularly grow the nutritionally deficient streptococci and the Haemophilus species by providing only a Staphylococcus aureus strict to compensate for their nutritional demand. Very rarely we do get false negative signal, which is actually the main cause is pre-incubation delay. False negative signal is greater when the pre-incubation duration is more than 24 hours, temperature is very high, around 35 degrees centigrade, and certain organisms are known to be more common in false negative signal bottles. But in hospital practice, where the lab and the wards are pretty close by, false negative signals are extremely rare. Very often we get a request from the clinician, please incubate the bottle longer than the required because we are expecting unusual pathogens. Truly speaking, there are enough number of studies which show that prolonged incubation has got no significant advantage in overall sensitivity. In fact, a standard 5-day incubation recovers all the difficult pathogens, the HASEC group from infective endocarditis, the Brucella species, and also the rapid growing mycobacteria like Mycobacterium abscessus, which grows frequently in blood culture in our experience. So, coming to the conclusions, blood culture is among the most common microbiological tests. The first and essential diagnostic tool for detection of bloodstream infections. But the best practices of blood culture require a thorough understanding of appropriate ordering of blood cultures, timing of blood culture collection, skin preparation, sample site preparation, impact of the volume sampled, subculture conditions, and all. Both sampling strategies, multi-sampling and single sampling, are acceptable by most of the recommendations. Multi-sampling strategy is the most commonly followed or practiced one. Single sampling strategy has the advantages that it's more convenient for patients and healthcare workers, better compliance, less cost, less risk of occupational exposure to blood transmissible pathogens, and it gives us a chance for earlier initiation of empirical therapy when indicated. But it has very little practice and it needs more attention and evaluation by multicentric studies. Thank you very much for your kind attention.
Thank you, Dr. Pallabre. As there are no more questions, we'll go on to the next topic. The next session is a pro-con debate, whether procalcitonin is useful to rule in or rule out bacterial sepsis. The pro will be taken up by Dr. Vivek Nangia and it will be rebutted by Dr. Subramaniam Swaminathan. Over to you, Dr. Vivek Nangia.
Sepsis is a life-threatening clinical condition which can progress from a dysregulated immune response to a life-threatening multi-organ dysfunction and multi-organ failure. Our diagnosis for sepsis relies mainly on quick SOFA and SOFA score, especially in the initial period. But when you look at the performance of these scores in a real-time world, we actually see that the accuracy of quick SOFA and SOFA is around 68%, 63%. There's a study from Thailand which has been published in patients with sepsis. But in patients with, the surgical patients with possible sepsis, the performance of these scores is even worse, where the authors of this study, which was recently published, actually concluded that none of these scores, SIRS, SOFA, quick SOFA, were valid enough to diagnose the presence of a bacterial infection. In certain classes of patients like the elderly, those on hemodialysis, HIV patients, immunocompromised, post-transplant patients, sepsis can present atypically. They may present even with no fever. The symptoms may be non-specific and overlapping. The counts may not be high. On the other hand, CDC has labeled sepsis as a medical emergency, like an ACS, like stroke, like polytrauma. Early intervention seems to improve the outcomes. That is why the reason that from the 6 hours bundle that was propagated in 2016, we moved on to now 1 hour bundle, which in 2018, in which administering a broad spectrum antibiotic seems to have a very major role in modifying the outcomes. We know very well that with every hour delay in antibiotics in patients with septic shock, the mortality could go on increasing. But on the other hand, inappropriate use of antibiotics could lead to increased failures, increased risk for opportunistic infections, increased resistance to multiple antimicrobials, and very toxic side effects. MDR pathogens are probably a result of inappropriate use of antibiotics only, which could finally result in increased mortality and increased healthcare costs. So antibiotics serve to be a double-edged sword. The only gold standard of diagnosis of bacterial sepsis would be a blood culture. However, it is negative in nearly 40 to 90% of the cases. And of course, there are always problems with contamination of the blood. Therefore, there's a need for a reliable biomarker which could help in management of the antibiotic therapy and improve the outcomes. Procalcitonin is one such marker, which is actually a precursor of the hormone calcitonin synthesized physiologically by the thyroid C cells. In the presence of an infection, a bacterial endotoxin, the inflammatory cytokines, it tends to be synthesized from lungs, liver, pancreas, intestines, and so many other extrathyroidal neuroendocrine tissues, resulting in a significant rise in their levels. If it's a localized viral or an intracellular infection, which inhibits the TNF, then there's a lower or a negligible rise. So they're able to differentiate between a viral infection and a bacterial infection. Especially so looking at the kinetics, which are really very impressive, that the moment there's an exposure to the endotoxins, the procalcitonin levels start to rise within 2 to 3 hours. This level rises rapidly, reaches a plateau for the next 6 to 12 hours, and remains at that level for about 48 hours or so before falling down to their baseline when the infection starts to come under control. This is one of the early meta-analysis that was published on procalcitonin, about 30 studies, where the mean sensitivity was 77%, specificity about 79%, and area under the curve was 85% for procalcitonin being a diagnostic marker for early sepsis. Now, a more recent study, which has actually correlated it with sepsis 3 definition, where they've actually gone on to differentiate it between sepsis, pre-septic shock, and shock, taking different cutoff levels, and the sensitivity and the specificity has been plus of 60%, touching 75%, 79% also in shock kind of a situation. So they actually felt that with the severity of the illness, the procal levels were also high. So the cutoff levels have been taken as significantly higher. Based on this and many other studies which have been published in the past, Dr. Vijayan actually came out with this algorithm, which actually says that if there is the procal levels are less than 0.1, then the antibiotic should be strongly discouraged. If it is 0.1 to 0.25, then they should be discouraged. But when it is above 0.25, then antibiotics should be encouraged. And in fact, they also believe that with the severity of infection worsening, the procal levels also increase, maybe indicating towards the severity as well. Now, when you compare it with the various other biomarkers like the CRP, the TNF-alpha, IL-2, IL-6, IL-8, procalcitonin again scores superior to all of these. The sensitivity is anything between 85 to 91%, the positive predictive value touching 89%, and negative predictive value touching 95%. And even comparing it with SOFA more than 7, the PCT was significantly better as compared to even the CRP and the WBC count. This again is one of the older studies when we look at a more recent study published just in 2019, comparing it with CRP, ESR, WBCs, again, procalcitonin had a much superior role in predicting the presence of bacterial sepsis and bacterial infection. In this study, in fact, they've actually compared it, PCT compared it with SOFA, quick SOFA, the SIRS, second consensus conference criteria, the modified consensus conference criteria, and amongst all these, PCT seems to be better, if not, it seemed to be equal, if not better, than the other predictors of bacterial infection and sepsis. If we look at the epidemiology of sepsis in India, then respiratory tract infection seems to be the predominant infection, and probably this is the predominant infection worldwide, especially with gram-negative bacteria. And there are a plethora of articles, meta-analysis, Cochrane reviews that have been published, which have shown that use of procalcitonin to guide initiation and duration of antibiotic treatment in patients with ARI was not associated with higher mortality rates or treatment failure, and the antibiotic consumption was significantly lesser when procalcitonin guided antibiotic therapy was being done. That means if the procalcitonin levels were high, only then it was recommended to give the antibiotics. If they were low, then antibiotics were withheld. So there was no increase in mortality with this policy at all. Based on this and several other studies, it is actually proposed that when you are not certain of the bacterial infection, when bacterial infection is uncertain and the procal levels are less than 0.5, then there's a very low probability that there would be an infection there. So you should start antibiotics only if you must. If the procal levels are more than 0.5, even if the bacterial infection is uncertain, you are safe in starting the antibiotics. If the bacterial infection is highly suspected and the procal levels are less than 0.5, again, probably do some more tests, think before you start the antibiotics. But if the procal levels are 0.5, then do not hesitate, but start the antibiotics right away. Of course, the choice of antibiotics would depend on the site of infection, the kind of flora that you get to see in those infections, and your own personal choice amongst the various antibiotics that are available. So finally, to summarize, sepsis management includes early diagnosis as well as timely and specific treatment in the first few hours of triage. Procalcitonin is a reliable marker for diagnosing bacterial infections. It has a short turnaround time and fares better than so many other available biomarkers and the scoring tools that we have at our disposal today. Thank you so much for a very patient hearing, and I'll be happy to take any questions if you have.
Good day. This is Dr. Swaminathan, Director of Infectious Diseases at Gleneagles Global Hospital System. First, let me thank the organizers for allowing me to be part of this symposium. And I'm going to be talking about why procalcitonin may not be the knight in shining armor that we all would like to think that it is. And obviously, I have an eminent person who's going to be speaking on behalf of procalcitonin. Let me make this very clear. It's not that I do not use procalcitonin, but we need to be aware that there are problems with it. And you need to understand whether it makes sense in the ultimate decision of whether it can be a valuable part of your treatment algorithm. So for that, I decided I will use a slide deck which has been prepared by the Agency for Healthcare Research. It was earlier part of the United States Preventive Services Task Force, which is a not-for-profit organization which looks at preventive issues and things which are useful in the clinical domain. And this is basically an unbiased review of the literature. So these are my disclosures, obviously not AHRQs, and I'm going to underline some of the areas which I think are worth discussing. So obviously there are some uncertainties when it comes to procalcitonin guided antibiotic therapy. Yes, the data suggests that there could be a value in either starting therapy or in monitoring therapy, but again, utility in diagnosing, managing patients with suspected infections is still quite unclear at many different points of time. So the question is, does procalcitonin guidance help us in identifying systemic or local infection? And does it lead to meaningful endpoints in terms of, does it reduce antibiotic therapy? Does it help us decide the correct antibiotic therapy or the length of use or stay? And of course, bigger outcomes like morbidity, mortality, and adverse events because of antibiotics. So when we look at the review very carefully, physicians in many of the studies were allowed to use their clinical judgment. So in a hospital, especially if you have specialized interventions or input which is available, you may be able to take a better call without just using procalcitonin. And very often clinicians do tend to override the procalcitonin data, mainly because they have clinical judgment and an astute reasoning, which can serve them better than just numbers. So obviously you need to be careful about that. And we know, when I see a mucoid lactose fermenter, I don't need microbiology to tell me it's Klebsiella. I already know it's Klebsiella. So there are certain tips and tricks that we use in regular care, and these often override these kind of numbers. So what is important is that when you look at discontinuation of antibiotic, except for one study, there's been nothing which has shown that it does not increase mortality. But the question is, does it decrease mortality? It did not increase mortality or morbidity, which is great. But the question is, does it change that? Does it decrease that? So the problem is, very often what happens if the procalcitonin doesn't behave the way we want it to, very often the clinician is forced to escalate therapy. And this happens fairly often. And this kind of escalation, which would not have happened if we did not use procalcitonin, ends up in unnecessary and increased use, both in terms of the magnitude and also the duration of therapy. And this can lead to more morbidity, more ICU stay on ventilator, and more end organ damages, especially renal dysfunction. So yes, we know that in renal respiratory tract infection, it can be useful in early diagnosis of bacterial versus viral. And the point is that they can send the patient home without antibiotics. But physicians can consider clinical decision information and override algorithms based on their judgment. So the problem is, let's say if you have a rapid antigen test and comes back positive for COVID, you really don't need an antibiotic. You don't need a procal to tell you that it's COVID, and therefore it's a viral infection. So, and the problem is many times the procalcitonin is not in-house. When they have to send it out and comes back 24 hours later, the whole purpose is defeated. And unless it's a point of care test, you can't really make rapid diagnosis either in the emergency or in the outpatient. And therefore the clinical decision to give the antibiotic is very often forced from your hand, and you don't have much of a choice. So while it seems nice, is it practically implementable is another issue. Right. So the point is, even with all of this in respiratory tract infection, procalcitonin guidance has not been shown to reduce mortality, length of hospital stay, or ICU admission rates. And again, while people love to say that it probably reduces antibiotic-related adverse events, the studies so far have not shown a significant benefit, which we can really tout as a big advantage of that. So these are clear issues with regards to using procalcitonin in the respiratory tract infections, either in the ambulatory or the emergency setting, which is probably the most important recommendation as far as early procalcitonin use is concerned. Again, when you come to specialized situations like pediatric population, yes, there is some data to suggest that in early neonatal sepsis, it could be used. But the problem is that there is not enough data, especially in the most critical time of life, between 1 and 36 months of age. Up to 3 years of age, the data is still very, very poor about whether it can reduce antibiotic use. And remember, the majority of illnesses happen the first 3 years of life. And obviously missing that means there is a lot of early antibiotic exposure, which is what we are trying to prevent in the first place. And this is an area where more data is required. And what about patients who come in with a surgical issue? Either they come in with trauma or burns, or they have surgery, and then you were thinking of an infection. As of right now, procalcitonin guidance is now insufficient to tell us who is at risk of developing infections or who's developing an early infection, and when preemptive antibiotic therapy can make a difference. And this is an area where a lot struggle, and a lot of our surgical colleagues would be really very happy if we can give them a clear bump steer on what it is that they can do to reduce their antibiotic usage rates, and also to decide when it is not prudent to wait and watch. So what we basically the guidance says is that as of right now, procalcitonin guidance it's unclear whether it really decreases mortality. And the problem is, like I said, procalcitonin-guided antibiotic intensification very often results in excessive antibiotic abuse and can be associated with increased morbidity, mortality, and end organ damage. And obviously, yes, there is data to that you can initiate and discontinue therapy, especially in respiratory tract infection. But again, it does not seem to make a difference in terms of endpoints, in terms of morbidity, mortality, and things like that. And like I said, the practical difficulties in our country are something we need to keep in mind. This is an idealistic situation which does not exist in most centers, in 99.9% of centers in India. And again, the data in pediatric population, in neonatal population is still very, very poor. And that's an area that requires a lot more attention. But there are other areas as well where there are gaps. For example, immunocompromise. I have a lot of patients who have HIV, who have organ transplant, things, and who are in dialysis and things like that. What about in those patients? The data on that is as yet not very robust, and that also needs more data. Whether it's applicable to them, we don't know. I often have this question coming from my stem cell transplant colleagues, oncology colleagues, and so on. The problem is also that in pediatric population, like I said, in initiation and discontinuation, we need more data. And again, we need more hard data on whether this kind of approach can reduce adverse events, superinfections, or even antibiotic resistance. And again, does it reduce mortality? Now, that's the most important question. All the endpoints finally can all be washed onto this. Does it reduce antibiotic resistance from happening? And does it reduce mortality in the patient? So far, at least, there is no data to suggest that it is a robust effect on mortality. And again, you need to ask yourself, what's a comparator? The comparator cannot be no procalcitonin. The comparator has to be what is the standard of care. So if I have an astute clinician who can look at the patient and say, I think we are done with antibiotics and stop, will procalcitonin add value to that? So are we trying to say that we should all be dumbed down to the level of a computer which makes blind algorithms and we don't have to do any cerebral work? No, that's not it. So obviously, a person who's very smart and can figure it out, will procalcitonin help them even further? Now, that's the kind of stuff we need to do. And also remember that all of this will not work unless you have robust antimicrobial stewardship in place. Many centers suffer because they don't have a very robust AMS in place, and they are not able to push the agenda in terms of reducing antibiotic use. So if that doesn't happen, all this procalcitonin data is not going to translate into any meaningful differences, even if they are there. And that's a significant problem in many centers. And again, we need to have these kind of cutoffs in different populations, whether it's neonates, whether it's post-op, whether it's burns, whether it's crush injuries, whatnot. And those kind of data we still need information on, because without knowing that, we don't know how to interpret all of this. So in summary, what I would say is this, that procalcitonin is a very interesting molecule. It has certain positive attributes going for it, but the large-scale applicability is something that we need to consider. There are practical issues in implementation of that because the turnaround time is not necessarily easy. And more importantly, without a robust antimicrobial stewardship system to back it up, all of this data is not going to translate into many meaningful benefits. And I think it needs more data on varied patient populations in terms of immunocompromised and things like that, or surgical patients, for it to be something which can be a one-stop shop, which can be applied across the plate. As of right now, there are probably some areas where it is useful, but the problem is, given the amount of interpretation that needs to go into it, it often ends up confusing the clinician and causing unnecessary harm as a potential downside, and therefore needs to be used with a lot of caution. So what I would say is that unless you're very well trained and you have all the other systems to back you up in place, procalcitonin may end up harming your patient rather than helping your patient. Thank you.
After that interesting pro-con session, we'll now move on to the next session, which is supported by Cadila. It is a panel discussion which is moderated by Dr. Dhruva Chaudhary, and the panelists are Dr. Kapil Borauke, Dr. Channaraya, Dr. Sai Prasad, Dr. K.K. Pandey, and Ashutosh Bharadwaj. There's a change. It is moderated by Dr. Yatin Mehta, and the panel discussion is on early interventions to prevent severe sepsis and the possible role of immunomodulators. Thank you.
Hello, everybody. It's indeed a pleasure to be here. I'm Dr. Yatin Mehta, and we are going to follow a very interesting talk by Dr. Sai Prasad from Kolhapur. We have gone through several lectures on the etiology of sepsis and severe sepsis, and how immunity plays such an important role in which way the disease progresses. Most of the immunomodulators which have been used for therapy of sepsis or as adjuvant therapies have demonstrated, the studies have demonstrated that earlier you intervene, the better it is, and then the better the outcome. So there are several studies which have come out about Sepsivac, Mycobacterium W, which large studies, some of them more than 150 patients, multi-center studies, and which have shown, many of them have shown, that earlier intervention, that is less than 3 days, significantly improves the outcome. Mortality, ICU and hospital length of stay. So we look forward to talk by Dr. Sai Prasad, and I would invite now Dr. Ashutosh Bhardwaj to take over the moderation. Thank you.
Yeah, now we shall discuss an important topic, the possible role of immunomodulators in management of sepsis, because we always know that stitch in time saves 9. So just to give a roadmap, let's see first what is sepsis, what we know so far, and what's the role of immunomodulators in sepsis, and whether a drug like Sepsivac, which is known as attaining immune homeostasis, is helpful in sepsis, and about its benefit and risk analysis, and also about the cost benefit analysis. So to begin with, we all know that to fight infection, you need adequate innate immunity. So when there is dysregulation of innate immunity, then it leads to organ dysfunction, and the infection goes into sepsis, and then there is increased mortality. So how to handle this? So what differentiates sepsis from infection is an aberrant or dysregulated host response and the presence of organ dysfunction, which leads to severe sepsis. So how to handle this, we'll see in the next few minutes. We know that when there is increase of 2 or more points of SOFA score in an infection, it leads to sepsis and then worsening, and then definitely this leads to increased mortality. So the earlier we tackle, it's better, because the delay is definitely dangerous. The hospital mortality and severity is actually related to how early you tackle this sequence. So when the patient is in sepsis, or whether is already gone into hypotension, whether the lactates have gone up, so whether the patient has gone into severe sepsis. So this is what we need to be looking for, to pick up these patients early and then intervene early. So the same thing is being documented in even surgical patients also, and even intra-abdominal sepsis also. So any delay in picking up or managing these sepsis patients is always dangerous, and it leads to higher mortality. In sepsis, the mortality is proportionate to the number of organ dysfunction. So we know that more the number of organs involved, definitely the mortality goes up. That's how the SOFA score is well correlated with the mortality and hospital outcome in sepsis patients. We know that any change in SOFA score of more than 2 points during ICU stay leads to 22% rise in mortality. So this is well documented. So any increase in SOFA during ICU is attributed to higher mortality. The same way, increase in SOFA score following admission on day 7, it is well correlated. If the SOFA score decreases on day 7 from baseline to more than 25%, your mortality is below 10%. But it drops below 25%. If the drop is below 25% of the admission value, then your mortality is significantly high. So how fast the SOFA score drops is also correlated with mortality. Any change in SOFA score, whether it is rapid or slow, is also correlated. So survivors of sepsis, they've had a rapid fall in SOFA score in the initial 7 days. We all know that early appropriate administration of antibiotic is very crucial in the management of sepsis. So that is why we say it's a golden hour of administration for antibiotics. Even each hour of delay in administration of antibiotic linearly increases the mortality rate. So that's how it is very important to pick up early and administer appropriate antibiotic. The choice of antibiotic is also very important. So now we have a molecule which, when combined with an antimicrobial drug, leads to faster clearance of infection, whether it's viral, bacterial, or mycobacterial, or parasite. So this is attained by immunomodulation. And we know that in all clinical phases of sepsis, the factor which influences outcome is the immune program. So immune homeostasis is the key for overall outcome across disease journey, from infection to sepsis to severe sepsis. So whether it is in the pre-sepsis stage, acute stage, or in the recovery stage, so managing immune program is very crucial in having a good outcome. So that's what we mean as stitching time saves 9. So you target your infection with antibiotics, source control, and other infection control measures. At the same time, the immune regulation, which is leading to organ dysfunction, has to be managed by attaining a immune homeostasis, which is taken care of by Sepsivac. So earlier you combine these two, antibiotics and Sepsivac, is better for the patient. So how does this Sepsivac correct immune dysregulation? So what we have is macrophage. When it comes in contact with either SARS-CoV-2 virus or any gram-negative bacteria, these macrophages get activated and leads to release of multiple cytokines which storm like IL-6, IL-1 beta, IL-10, IL-8, tumor necrosis factor alpha, ferritin, etc. So this Sepsivac attacks or tackles all these things, but it is not just managing the cytokines. It leads to upregulation of genes that are downregulated and simultaneously downregulation of genes that are upregulated. So that is how it is a near perfect fit for management of sepsis. It is not just immunosuppression or the drug which affects a specific cytokine, but it's a drug which leads to immune homeostasis. So it takes care of the host immune response also. At the same time, it doesn't cause any suppression in the immunity. So that's how this Sepsivac has a multi-pronged approach which helps to achieve immune homeostasis in a patient. So it acts at different levels and ultimately leads to a stability to the immunity of the patient. Even we know that just administration of this Sepsivac, within a couple of hours, there is reversal of endotoxin-induced pyrexia. So this has been well documented in studies in Indian Institute of Science, Bangalore, and this ultimately has led to survival benefit in associated with E. coli. So Sepsivac, along with antimicrobial regimen, it has led to faster clearance of infection, whether it's viral, bacterial, mycobacterial, or parasite. We have well-documented studies with this molecule. So this is a randomized trial of Mycobacterium W in severe presumed gram-negative sepsis in Chest Journal. So 200 patients were randomized to treatment arm and the control arm 100 each. And in addition to standard of care, there were 50% of them were administered Sepsivac. So there was an absolute difference of 11 deaths which was avoided. So this is about treatment benefit is in 55% of the people. So what you need is to treat 9 people to save 1 life. So this is very encouraging and impressive outcome of this trial. So what we have is a Sepsivac, a molecule which has got all these benefits, which attains immunohomeostasis, which works synergistically with antibiotics, which leads to faster recovery, lesser number of ICU stay, faster discharge, and this ultimately leads to financial benefits also. But what is at stake? So absolutely no systemic side effects. We have used this molecule extensively in COVID era also, and even in gram-negative sepsis. So these are all, even when you consider this risk-benefit analysis, these benefits outweigh risk in a very big way. So a stitching time saves 9. So this is a molecule which attains immune homeostasis when combined with antibiotics. It leads to a different dimension and improvement in the patient outcome. Thank you.
So it was an enlightening talk, very succinct from the sepsis perspective regarding early intervention in sepsis and the role of immunomodulator, the options we have by Dr. Sai Prasad. We all know that sepsis has been around since the dawn of time. It has been described in literature for more than 2000 years, although clinical definitions may be very recent. And it is one of the conditions which remains still as intriguing as it would have been 100 or 200 years ago.
it is still one of the most common cause of death in our ICUs. So now I will open the panel for discussion. We have very prominent names from all over India. We have Dr. K.K. Pandey from Delhi, Dr. Kapil Guravake from Pune, Dr. Sai Prasad from Kolhapur, and Dr. Chanaraya from Bengaluru. I welcome all of you, my esteemed panelists. So I will start with Dr. Kapil. Dr. Kapil, my first question would be that what are the early clinical signs of sepsis that you are looking at in your patients, and how are you optimizing your patients in ER or in wards if they are in early phase, and what are the IC protocols for us so that we can follow them and we can identify the patients early. Over to you, Dr. Kapil.
Yeah, thank you very much. As we have taken up very important issue in intensive care unit, that is sepsis, and very important question that to identify sepsis as early as possible. That is why Dr. Sai Prasad has probably ended his talk with the slide that a stitch in a time saves a lot of lives. So here, what we do normally, we know that the most common response by a clinical response will be fever or chills. But we will be not all the time lucky to have a patient who has got such clinical symptoms. And probably we either overdiagnose or underdiagnose sometimes a subset of patients if we just rely on a fever as a probably history. If definitely there's a fever history of fever, definitely it helps us to think about sepsis as early as possible. Second will be to look at what is the biological response, to look at the WBC count, whether it's increased or severely decreased, look at the inflammatory markers, look at CRP, look at procalcitonin. And on our floor also, we have probably geared up our system to have these reports as early as possible. We get procalcitonin in 2 hours. We have geared up our system in such a way that our residents have been trained to identify the source of infection and to think about every patient that has been admitted, that a possible septic patient. Suppose somebody has got smelly urine, had a history of dysuria, respiratory symptoms with positive findings on auscultation or abnormal x-rays, or somebody who has got purulent wounds with a history of some chronic disorders like diabetes. Probably there, probably our residents are more keen to pick up it, because when we say we have to administer broad spectrum antibiotics early, we have to think about sepsis as early as possible. But particularly as a fever, we are not all the time lucky in a subset of patients who are immunocompromised, who are on high dose of immunosuppressants. So fever may not be there, still we have to think about sepsis. And here probably I'll say that hemodynamics will also helps us. Somebody who is hypertensive landed 2 casualty with a blood pressure of 110 by 70, 100 by 70. We have already taught them that thus don't be happy with looking at those normal numbers. That can be, patient can be in a relative septic shock. So with these kind of systems, we are trying to pick up sepsis as early as possible. Sometimes we overdiagnose also, but I always feel that overdiagnosing is always better than underdiagnosing. So we have a protocol in place where we monitor these symptoms and signs, and we have our own scoring system on based on that. We go ahead and think about sepsis, particularly in every patient. And probably we overdiagnose in particularly post-operative patient when we rely about like WBC count and fever. So that can be reactionary, particularly trauma and post-operative patients. But by training them in such a way, we are trying to identify septic patients as early as possible.
Good. I can't agree more on that. So very insightful. So now, I'll move to Dr. K.K. Pandey. So Dr. Pandey, what are the markers of sepsis, and how often should we use it or send it in our clinical practice? And in your view, is there any ideal marker?
Yes, Dr. Ashutosh, good evening to all of you. And I feel there's no ideal marker as such in a sepsis. As Dr. Kapil said, good clinical acumen, I feel, is the most important thing. But in last, COVID pandemic, we have seen, yes, definitely there are markers like in COVID, we use CRP, D-dimer, IL-6. They were really helping. As far as this sepsis is concerned, yes, I considered three markers like PCT, CRP, and serum lactate. Especially pertaining to sepsis, they are very, very important. Not only to identify whether the patient with a sepsis-like symptoms has real infective sepsis or not. In this regard, PCT is procalcitonin is a very, very important marker. In fact, it not only identifies whether the given patient with so-called sepsis is an infective sepsis or it is something non-infective disease like autoimmune disease or other hyperimmune processes, and it also helps us in assessing the severity of a disease. Like in one of the studies, they found that patients who were admitted to general ward with sepsis and having PCT level above normal, around 0.12 nanogram per ml, they were having around 2.6 times higher mortality in comparison to patients having normal PCT. So PCT not only help us in segregating patients from infective sepsis from non-infective, but also help us in segregating, triaging these patients whether they need ICU or a high intensive care or they can be kept in a general ward. The other important parameter is in monitoring the patient to response to therapy. That what we practice in our hospital also. And PCT really guides, CRP and PCT guides us in de-escalating the antibiotic regime. If your PCT over a time is coming to normal in 5-6 days, I really stop antibiotics, especially in patient with pneumonia. If I feel that PCT has come normal and clinically also patient has shown but still, having said that, I think is in a clinical context, not only these markers, we see patient in totality, patient's clinical response. And what I've seen is if the CRP is not coming down after your antibiotic therapy within 48 hours, please consider. We had a patient recently with a ANCA positive, vasculitis who presented with a extensive pneumonia and ARDS-like features. But despite initial antibiotic therapy, his CRP was rising, patient's CRP was normal. So that sometimes hints to you that you need not to treat this as an infective sepsis.
For the clarity, Dr. Pandey. Now back to Dr. Sai. Dr. Prasad, what is the usual mortality which is seen in the clinical practice? What do you feel? Especially if we talk with respect to early diagnosed cases versus late diagnosed.
Yeah, well, this is a very important question. We do see that when you pick up sepsis early and do appropriate interventions, whether it's administration of antibiotic, fluid resuscitation, source control, whatever it is, it makes a change in the outcome. But what consistently the trials have shown is that people who have got multiple organ failure, people with high SOFA score on admission, they definitely have a higher mortality rate. So this is definitely reflected in our clinical practice also. So that's how picking up sepsis early before they develop organ failure and appropriate intervention, whether it is antibiotic administration or immunomodulators. So intervening early is definitely going to make a change in the outcome. As I said earlier also, a mortality of around 50 to 60% can be brought down to 30% if you pick up early and do appropriate intervention. So we have a case here to argue for early intervention and early picking up of sepsis.
Yeah, that's true. And in my view, if you incorporate some mortality predicting score like Apache 2, in our routine practice, that also gives you a lot of insight regarding the further management, the prognostication and the other issues related to the patient.
Yeah, that's
So
right.
now-
Only advantage with SOFA-score is very simple, even for the paramedical staff and our junior doctors to monitor it and follow it up. But Apache score needs a little cumbersome calculation. So that's how it is clinically more relevant.
True. So now I'll come to Dr. Chennaraya. So sir, what is the usual care in sepsis, especially when patients land up to you in the early phase? Do you follow any SOP or the protocols for your patient? Any bundle care? What are your views?
As soon as the patient arrives either in a ER or in ICU, we need to know that if he is in sepsis, first and foremost is to get into IV axis, draw the blood for routine blood investigations like blood counts, and then draw the blood cultures. And if you find the source of sepsis, you need to get the cultures of other secretions, maybe respiratory or maybe urinary. Cultures has to be done as soon as the patient arrives. Immediately, then you have to decide what antibiotic you are going to choose and appropriate antibiotic, probably right antibiotic and right dosage should be administered quickly. That is, without wasting much time. That is golden hour, what is described. Definitely will reduce the mortality. Benefit is very much has been shown in various trials. And also you need to assess the perfusion status of the patient and organ dysfunction. After that, the antibiotics are immediately after that, you need to assess that and start the perfusion IV fluids. Then if there is an organ dysfunction, you need to tackle that organ dysfunction. These based on what organs are dysfunction. So you need to assess these carefully and start the therapy. So early intervention with these antibiotics or perfusion improvement and protecting the organs will definitely have good outcome in sepsis if we do early.
So if may I ask you, Dr. Chennaraya, do you have any team deputed for managing patients early in the course of the disease, like in the ER or in the ICU? Do you have any designated area for such patients?
No, we do have some designated area for sepsis. Especially if they are MDR and other things, we isolate them and start them quickly and identify them and treat them early. I think we have definitely in ICU. IER, we generally do the routine and shift the patient to ICU if required.
Sure, Dr. Chandra. Thank you for that. Now I will again come to Dr. Kapil. So which group of patients do you think progress from sepsis to septic shock, from moderate to severe disease, if they are not identified and managed properly and early in the course of the disease?
So we always triage our patient, particularly here in sepsis, because we will be very much keen to know if patient's age is more than 65, the elderly, who have previous comorbidities like diabetes, on multiple drugs, uncontrolled, patients who have a high dose of steroids or any other immunosuppressants, or cancer patients, or patients who have got chronic kidney disease, cirrhotic patients, or patients who have been recently hospitalized for some other disease. Probably this subset of patients will be very keen, and on our trial will be putting a very priority list because they are the potential candidates which can probably progress to severe sepsis or septic shock. And particularly retrovirus also, but to be very frank, we are seeing very less patients. I would like to know from the panel also that these kind of patients coming like retrovirus HIV positive who are landing into sepsis. Probably post-COVID hospitalization also is very important risk factor for us now to consider as because they might have received larger doses of steroids also. So we have a triage system in place for this subset of patients.
Okay, that's very much true. So Dr. Pandey, again to you, sir. So what is the role of immunity as a whole? It has been talked a lot about in recent times everywhere in the media and every kind of platform during this pandemic. So what is the role? What do you think is the role of innate and the adaptive immunity? We talk both of these separately, and the role of immune dysregulation.
Yes, I feel immune system plays an important role. We have seen in COVID also that why some subset of patients were doing so well and others were succumbing to the disease and such a hyperimmune state. And traditionally, sepsis was believed to be a hyper-inflammatory response resulting from unabated innate immunity and suppression of adaptive immunity. But now the evidence suggests that both pro-inflammatory and anti-inflammatory processes goes on simultaneously. There's no definitive channel, and both of these anti-inflammatory and pro-inflammatory processes are going on. And the predominant response, that is pro-inflammatory or anti-inflammatory, is primarily driven by post-comorbid state. As Dr. Kapil said, that if the patient is a diabetic, the patient is immunocompromised, and the immune response is going to behave accordingly. So the infective agent and your timely intervention to the sepsis also plays a lot of role. And this process is the immune response process is a very complex process, and I think the immune homeostasis plays a key role of the host in fighting against infection and sepsis.
Thank you very much. Dr. Sai, because of the paucity of time, I would like all my panelists to, just be in little crisp and brief answers. So what is your usual experience of immunomodulator in sepsis? Have you personally used them, Dr. Sai?
Yeah, definitely. This, as just now Dr. Pandey said, immune response of the host plays a key role, and people have been come to know about this IL-6, IL-8, all that after COVID. But we have been using these markers even before COVID era, and definitely these markers are much on a higher scale in sepsis compared to COVID patients, and there have been multiple attempts to target these cytokines. So if you recall, we have had many drugs like Zygris activated protein C and telectoferrin alpha, cytofab, or even antibodies against TNF alpha, which have come in a big way, and ultimately none of them proved to have a great mortality benefit. One of the reasons for failure of these drugs is that they target only one component of inflammatory changes in sepsis. But as we all now understand, this context of this inflammation is basically a necessary evil. So it leads to activation of both innate and adaptive immune system in a host. But blocking this pathway by any of these leads to increased susceptibility to infection because of losing the innate immunity. So therefore, now we should have an agent which targets the cytokines which are prevailing in excess, but at the same time, which doesn't affect the immunity of the host. So that is a need of the hour, and definitely I think this molecule Sepsivac, this fills in the gap in this case. And we have tried in significant number of patients in COVID and even gram-negative sepsis also. So this is a unique mechanism of action, and definitely this is an ideal drug as a immunomodulator with multi-pronged action. So without affecting the immunity, suppressing the immunity of the host, this achieves immune homeostasis. So I think this is has a place in that.
Just to take it further, Dr. Pandey, what are your views? Can it be used along with the antibiotics in early course of sepsis?
Yeah, definitely. Historically, we have seen that this MVACI, is quite effective in patients with tuberculosis. We have used in past patients have, category 2 tuberculosis, in leprosy, in, anogenital warts also. It has shown a good response. And recently, there's a few studies, in a patient with gram-negative sepsis, and we know that this immunomodulators act on toll-like receptor 4 agonist, and it is I feel is a promising immunomodulator along with antibiotics. And because
Thank you. Yes, sir. Dr. Chanaraya, sir, your views on Sepsivac, which is already a DGCA approved drug. What are the risks versus benefit? Which way it goes?
Now, Sepsivac is definitely a safe drug contrary to the drugs what we use in sepsis. Maybe steroids, maybe antibiotics sometimes. They work differently, but this Sepsivac has both innate and adaptive immunity. With the strong innate immunity, it can recognize the organisms and tackle the organisms, especially pathogen-associated molecular pattern. And also this can be used at different stages of sepsis, from sepsis, severe sepsis, or septic shock. In all stages, it works wonder, and probably it alters the immunity, thereby without much side effects, systemic side effects as described earlier, except for the local reaction. Otherwise, there are no systemic side effects. And in view of its strong immune modulatory action without much risk, I think this is a wonder drug for Sepsivac as an add-on drug in sepsis.
Yeah, that's true. So, Dr. Kapil, I think there are no big interactions, drug-drug interactions. If I am not wrong, what are your views?
Whatever, I have extensively used this Sepsivac in all subset of patients, even in gram-negative infections also, and in COVID also. Till now, I have not come across any such issue where the drug has been interacted or some abnormal adverse effects due to Sepsivac. So till what I know, there's no drug-drug interaction due to use of the Sepsivac.
So, thanks everyone. Just to summarize a few points. So early recognition and early interventions remains the cornerstone in the sepsis management and also are associated with much better outcomes. Sepsis can present, vaguely, as Dr. Kapil was telling us, in very subtle ways, especially in, at extremes of ages in elderly patients. So we have to be very vigilant. We have to keep the index of suspicion very high. The juries still out to find out the ideal marker for sepsis, MW, with what we call as, Sepsivac, is actually both immunotherapeutic and also immunoprophylactic agent. And it can help in better bacterial clearance. If used early in the course of the disease, it is a safe and cost. So I thank all my panelists and speaker for such a thought-provoking and very good and lucid discussion on such a pertinent topic, which is still pertinent from all aspects. We are dealing it day in, day out. Goodbye, everyone. Thank you very much.
After that panel discussion, we'll now move on to a presentation on Sepsivac with publications. Mycobacterium W, an adjunct immunomodulator in sepsis, and it will be discussed by Dr. Subhadeep Pal and Dr. Rajat Agarwal.
And that is about purposeful repositioning. Drug repurposing is a process of identifying new therapeutic uses for old, existing, and available drugs. And the COVID era has really seen a lot of such efforts. The Mycobacterium W vaccine is a heat-killed suspension derived from a non-pathogenic bacteria, the Mycobacterium indicus pronine. And Mycobacterium W vaccine is one of the two experimental immunomodulators most extensively tried out in COVID throughout the country. Now, what is the rationale behind deploying such MW vaccine in COVID? Remember, a novel experimental immunomodulator should be safe and easy to incorporate in the regime with least interaction and systemic side effects. And that is exactly what is offered by the MW vaccine. Dysregulated immune response and cytokine storm are central to the pathophysiology of gram-negative sepsis as well as severe COVID-19. So it was in the MIST study that we first saw that it works wonders in gram-negative sepsis. And the same promise was upheld in the subsequent ARMY-1 trial. The mechanisms of actions of MW are unique. TLR2 agonism, antagonism of certain toll-like receptors, MAPK modulation, downregulation of upregulated inflammatory genes, and all of these takes care of production, cascading, and inflammatory effects of a host of pro- and inflammatory cytokines. It intercepts and interferes with the cytokine storm at different levels. So whom did we choose? Hospitalized adult patients with severe COVID-19 in terms of pulmonary infiltrates and oxygen sats below 94% on room where air were actually the targets. They were willing to try a novel and experimental immunomodulator, and that was confirmed. Multiple comorbids, fast increasing oxygen demand, worsening signs of impending organ dysfunction were all the prompters which actually turned our focus to the usage of Mycobacterium W vaccine in severe COVID. Now, a quick word on the posology. 0.3 mL of the drug is to be injected per day around about the same time. And this has to be done intradermally at different sites, which means that we have to split the 0.3 ml dosage into shots of 0.1 ml each, and that is to be given intradermally at 3 different sites at the same time. The exercise has to be repeated for 3 subsequent or consecutive days. But remember, the person giving the intradermal injection has to be trained properly to give the intradermal injection at the right site and not the subcutaneous site, because that is the simplest way to avoid some local injection site reaction. But be assured that such local site reaction is also very benign and self-limiting. A 0.1 ml injection is supposed to raise a wheel of about 6 to 10 millimeters. Now, I'm going to present our real-life experience with the Mycobacterium W in severe COVID. But before I do that, is a disclaimer that this is only a fact sheet. There's no detailed data or statistically analyzed values, no conclusions, or no take-home messages, which means we are not trying to implore or drive home a fact about the efficacy of Mycobacterium W vaccine. We are just presenting the figures just as observed by us and leaving the rest on your fine sense of judgment. So, observations. We have used it during the second wave of COVID only. 42 prescriptions across 3 units in Bardhaman and Kolkata. 3 patients were transferred and could not be traced. 2 patients received it for 2 days only due to non-availability, and one of these 2 patients did not survive. 4 patients died on us. All patients were above 65 years of age and had multiple comorbidities. One of the 4 patients who did not survive declined ventilatory support. One received Mycobacterium W vaccine for 2 days due to the non-availability. Remember, it is that patient who did not survive. So one of the 2 patients who received it for 2 days only did not make it. One patient was transferred and died. We did trace that patient. But subsequent standard of care received by that patient in the second setup is not known to us. He was less than 55 years of age, and this unfortunate gentleman had diabetes mellitus, hypertension, and presented to us with a CT score of 22/25 on the 9th day of illness. Finally, 13 patients were discharged after a stay of 10 days, one after 3 weeks, and another on day 47. We'll come about that day 47 case later. But that sums up to 19 patients who could be discharged in less than only 10 days of hospital stay. Coming to the last patient, the 26-year-old male who had a CT severity score of 25/25, also had a procal of 27. His bowel fluid and blood culture isolated Klebsiella, and he was in a florid septic shock during presentation. And this was a price case for us where there was concomitant severe COVID as well as severe gram-negative sepsis, where we had hued Mycobacterium W vaccine. So that is all about what we saw. That is all about the facts and the figures. I will end up saying the bottom line is immunomodulation in gram-negative sepsis and COVID-19 disease is a concept that needs further digging. Mycobacterium W is here to stay. The more we give it a chance, the more lives we save. I will take this opportunity to sign off with salutation to our colleagues who lost their lives in line of duty during the COVID pandemic. Thank you.
Hello, good afternoon, everybody. I'm Dr. Rajat Agarwal from Fortis Escorts Heart Institute. I'm going to present my data on clinical experience of Sepsivas in gram-negative sepsis as 0.3 ml intravenous for 3 consecutive days. First of all, I must thank Cadila Pharma for giving me an opportunity to come on this wonderful platform and discuss about a new cutting-edge technology which might prove a game changer in times to come in the sepsis management. I also thank organizers of this conference, Sepsiscon. For the past 2 days, there has been a wonderful amalgamation of all aspects of sepsis management. And to continue it forward, we'll be discussing briefly about Sepsivac and its role in gram-negative sepsis. So basically, the pathophysiology of gram-negative sepsis, we all know it's a infection by gram-negative bacilli, leading to the initiator of sepsis by lipopolysaccharide phospholipid protein, which is present in the bacteria, which causes the pro-inflammatory cytokines production and eventually leads to stimulation of pro-inflammatory cascade. This stimulation of pro-inflammatory cascade eventually causes cytokine storm and all manifestations of sepsis, septic shock, and eventually leading to multi-organ failure. So on the right side, as you can clearly see, this is the first is the gram-negative bacteria having LPS and other proteins in their cell walls, which produces the pro-inflammatory cytokines. Various cytokines are produced. You can see here IL-1, IL-6, TNF-alpha, IL-10, which are pro-inflammatory, which stimulates cytokines of the body and causes the cytokine storm and all manifestations of septic shock. So basically, now the concept is that the imbalance in the cytokine levels and storm is considered to be a major culprit in sepsis. This holds true, as we all know, in COVID-19 infections and subsequent problems as well. So current treatment for septic shock as per the surviving sepsis guidelines and various recommendations are resuscitation, giving timely antimicrobial therapy, source control, and hemodynamic support and adjunctive therapy in terms of vasopressors, inotropes, steroids, etc. Other supportive therapy for severe sepsis, we all know are equally important, like blood product administration, ARDS, ventilation, glucose control, renal replacement therapy if indicated, DVT prophylaxis, stress ulcer prophylaxis, and nutrition. So this has been so far the complete management of sepsis in a nutshell. However, the current guidelines do not focus much upon the immunomodulation or treating the cytokine storm. So there have been various agents which have been discovered recently over the past couple of decades to contain the inflammation of sepsis, like unilastatin, activated protein C, steroids, anti-TNF-alpha, COX-2 inhibitors, GM-CSF, and TLR4 antagonists, etc. They have their own benefits and side effects. So, but certain limitations are present with them. For example, unilastatin, it acts only on IL-1, IL-6, TNF-alpha, not having any effect on the hypotension as evident on vasopressor usage. Activated protein C is now no longer recommended because there was a significant bleeding side effect. COX-2 inhibitors have again side effects or have not found to be very effective. And TNF monoclonal antibodies increase chance of secondary bacterial infection. Other agents besides steroids, steroids have so found to be very effective in management of septic shock, but besides that, other agents have so far not shown to be clinically effective in management of cytokine storm in sepsis. So again, none of these agents have shown any improvement in mortality benefit. So basically, there exists a therapy gap in the management of sepsis and septic shock. So we know that we treat the infection by focusing on giving timely antimicrobial therapy, resuscitation by crystalloids or albumin, and supportive measures. But simultaneously, we should also target systemic inflammatory response syndrome to effective management of septic shock. Unfortunately, no definitive treatment is available so far, and is going on. Still, we are lacking quality. So, as I said, nothing is available to deal with the inflammation. Therefore, a relatively newer molecule called Sepsis has come up for the management of gram-negative sepsis. Basically, it's a heat-killed Mycobacterium W. It's also known as Mycobacterium indicus pranae. What exactly is this? It's a saprophytic, non-pathogenic strain of Mycobacterium. It's an immunomodulator and known to contain multiple antigens. So basically, Sepsivac, how does it act? It acts as a potent TLR2 agonist. TLR, I must say, is basically it's a toll-like receptors. These receptors are present inside the body, and they are responsible for stimulation of innate immunity of our body. It's also an antagonist of poly-TLR, MAPK modulator, cytokine suppression, and gene profiling. So all the aspects of cytokine storm in balancing the various cytokines is done by this Sepsivac, and hopefully it will meet the challenging needs in coming times. So effects of Mycobacterium W on sepsis and on gene profile, as we can see on the left side of the curve, it upregulated genes which are increased in production are downregulated by Sepsivac, like IL-6, STAT3, TNF-alpha, IL-7, IL-10, etc. And obviously there is the certain anti-inflammatory genes which are downregulated are upregulated so that there's faster healing. So like S-adenosyl hydrolase, IL-8R, TIMP1, S800, etc., etc. So basically the mismatch between the upregulated genes and downregulated genes is controlled by the use of Mycobacterium W. Currently, as per the DGCI, the drug is approved as a 0.3 ml injected intradermally at different sites for 3 consecutive days. So this is as the DGCI approvals. However, we felt the unmet need because intradermal administration has certain like presence of an ulcer in duration, which may not be very benefit for the patient as well as for the clinician. So we started using Sepsivac as 0.3 ml diluted 100 ml saline once a day for consecutive days in patients with gram-negative sepsis. And how did we arrive at this dosage? We had certain studies to back us up. Like this was a study, the first one by 5 ml intravenously as a single dose, which was well tolerated and provides symptomatic relief in some patients with refractory cancer. This was published in Journal of Clinical Oncology in 2008. The second was the Mycobacterium W 5 ml in 500 ml NS in patients with optic neuritis, which showed clinically benefit without any safety concerns. The third study, which has been come up and published recently this month in Indian Journal of Critical Care Medicine, about it's a brief case series of 6 patients who were given Sepsivac 0.6 ml intravenously for the management of COVID-19. It was published in IJCCN by Parth et al. So all this, we had a robust data supporting us when we started contemplating the use of intravenous use of Sepsivac. So this was the study which we planned at our center. So objective was to explore and evaluate the use of Sepsivac as an IV infusion in patients with gram-negative sepsis. So instead of COVID-19 patients, we took the patients of gram-negative sepsis. It's an observational study. It was started in January 2021 and will be completing by the end of September 2021. The total number of patients data planned is 30. We'll be presenting the data here of the 12 patients on whom we have analyzed the data. The other already 26 patients have been enrolled, and their data is being analyzed currently. So this drug was used on a compassionate basis, looking at the safety of IV published in the literature. So the literature which I just mentioned, the 3 studies which have been published about the safety of IV use of Sepsivac. So briefly, I'll be sharing what were the key outcomes of findings of our 12 patients. So first of all, IV administration was safe. There was no major adverse reaction which was found in any of the patients who were administered IV Sepsivac. the CRP levels. Now we are all in the habit of monitoring CRPs, IL-6, etc., and various parameters. So CRP levels are shown as a reduction from baseline of 35 to 9, which is an average on day 7 in patients of gram-negative sepsis. The SOFA score baseline was 14, average SOFA score, and it showed a gradual decline, but statistically significant decline to 4 after day 14. So this is a significant reduction of SOFA score. That means the clinical severity of organ dysfunction was much less after Sepsivac was used in patients of gram-negative sepsis. Effect of Sepsivac on saturations. So the Sepsivac, as you can see here, the Sepsivac increased the SpO2 levels in sepsis patients on day 4, 7, and 14 after administration. And this again was a statistically significant finding for us. The mean SGPT levels. So again, because these patients have multi-organ dysfunction, so they had deranged LFTs and transaminitis was present. So baseline SGPTs, which were high because of sepsis, reduced almost to normal range after 2 weeks. Obviously, this may not be the direct effect of Sepsivac. This may be the overall improvement in the patient's general condition and hemodynamics. Important point clinically for intensivists is the vasopressor requirement. We clinically observed that there was a fast reduction of vasopressors and tapering off of vasopressors like noradrenaline and vasopressin in the patients in whom we use Sepsivac. There was also a faster lactate clearance. We all know that septic shock patients have high lactates, and lactate clearance and serum lactate levels are usually taken as a marker for improvement or deterioration in patients with septic shock. So we saw there was a faster reduction of lactate levels and vasopressor requirement in patients in whom Sepsivac was used. However, the data analyzed so far is only of 12 to 13 patients, which we have not analyzed so far for statistical significance, but it has shown a clinically significant outcome in such on such parameters. Absolute mortality. The mortality of the patients we analyzed so far was 23%, and the survival rate was 77%. This is as per the surviving sepsis guidelines and as per the data available for septic shock. But the numbers, again, I must emphasize that the number of 12 or to 13 patients still not enough to we can conclude effectively whether it has significant aspect on mortality. But so far the trends are promising towards improved survival in patients whom we use Sepsivac. So just to conclude that Sepsivac has shown promising trends in the management of gram-negative sepsis. However, large multicentric studies are needed to corroborate our findings, and IV administration was found to be safe with no major adverse drug reaction observed so far in any of our patients. Thank you.
We will now move on to the next session, which is Sepsivac clinical evidences. It is a panel discussion on dysregulated immune responses, the real world evidence. The panelists are Dr. Subal Dikshit, Dr. Kapil Jhirpe, and Dr. Yatin Mehta. Over to you, sir.
Yeah, thank you, Dr. Khalid. I request the host to give me the screen share, right? I'll have to share my PPT.
You can share, sir.
Yeah. So thank you, Dr. Khalid, and thank the organizing committee for inviting myself, Dr. Yatin Mehta as the president, and Dr. Kapil Jhirpe as the secretary to have the last session. And I thank Cadila for supporting this session academically. So I've been asked to present the role of Mycobacterium W in dysregulated immune response, the real world experience. And if you really see any infection, innate immunity plays a very important role. And the innate immune response and the viral infections also depends upon if there's a good amount of an innate immune response, then the chances of replication of the virus is less. And therefore, the chances of getting infections is on the very less side. So Sepsivac, as you have heard from the previous two speakers, it causes a downregulation of the upregulated genes and the upregulation of the downregulated gene response. So from that perspective onwards, most important, let's see where Sepsivac stands, and that also been approved by DCGI into gram-negative sepsis. Where does it fit a role into COVID management, into gram-negative sepsis, and how useful it was in COVID? The innate immunity, as I told, it is our body's first line defense against the invasion by the pathogens. And the innate system is always ready to react. It is always acting as the first armamentarium, because in any response to injury by any means, it is acting as a first weapon. Secondly, it is quite broadly specific. It recognizes the common patterns which are associated with different kinds of pathogens and different types of injury. And more importantly, it is quite consistent and it reacts in the same way, even if there's a repeated amount of exposures which have been done by the similar viruses. The innate immunity usually starts immediately within the first few hours, and this innate immunity is the key cells. The key cells are the host cells, play a very important role, and the importance of these innate immunity includes the several types of the WBCs or the leukocytes, as well as the various cells which are residing inside the tissues. So therefore, innate immunity is the most important aspects, and we'll see if this innate immunity fails, how further progression of sepsis, or for whether it's a gram-negative sepsis or whether it's a COVID storm or a cytokine storm, and how does Sepsivac really play a very important role in it. We have seen that, yes, different types of respiratory epithelia, they have got the TLR proteins, the mRNA proteins. I won't go into the details of this. It is a microbiological slide. But most important, the nasal one is the TLR2 and the TLR4, as well as the tracheal bronchial is the TLR4 and the lungs is the TLR4, which plays a very important role as far as the receptors are concerned. Now, the innate immune response and the pathogen clearance, most important, if there is a good amount of innate immunity, we have seen that there is a good amount of clearance of these pathogens, and these clearance of these pathogens is very well taken care of with the help of macrophages and the various dendritic cells. And at the same time, it also clears the pathogen on its own by various activating of the adaptive immune responses, which come up later on course if the innate immunity does not, even not be able to clear up. Now, TLR2, what is due, is most important is the cytokine release from the macrophages, which is occurring. And there is an enhanced maturation of the activation of the beta cells and the CD4 T cells, which is there. But most importantly, it is also be seen that there is also a prophylaxis which plays a role against the envelope viruses, and out of which SARS-2, the various simple rhinoviruses, the herpes simplex, and the simple influenza virus, it is also acting as a prophylactic part of it, and therefore it's important. So the importance is most is the innate immunity. If the innate immunity is good, you will not have any infections. If the innate immunity is failing, or the innate immunity tries to overcome it with the help of the various armamentarium, you'll just be asymptomatic, or you'll just have a mild amount of an infection. But if there is a failure of the innate immunity, the infection can progress into a moderate infection, or sometimes can progress into a severe infection if there is a severe immune dysregulation which occurs. And therefore, if not treated properly, there's a release of the various cytokines, and these cytokines can then compromise the organ hypoperfusion, as well as precipitate sepsis, as well as lead to multiple organ failure and organ dysfunction. I won't go into the details of it, into this, because these also have been covered up into the previous two talks. And as we said that once the organ hypoperfusion and the liberation of these cytokine occurs, in COVID specifically, the lung functions get affected, the alveoli get affected, and therefore there is a precipitation of acute lung injury, affection of the PF ratios, need for oxygen requirements go up, and possible need for invasive mechanical ventilation or non-invasive or HFNO requirements. Now, Sepsivac we have also covered up in the previous two talks, but I would like to cover up in short here again. It's a Mycobacterium W or Mycobacterium insidious. It's been manufactured and made in India. It is indigenously made. It is approved by the DCGI for gram-negative sepsis. And yes, it is quite effective, quite cheap as compared to other immunomodulators, quite safe to use. And most importantly, it's a very potent TLR2 agonist. At the same time, a poly-TLR agonist, it produces a good amount of a cytokine suppression, and it produces gene profiling by upregulation of the downregulated genes or a downregulation of the upregulated genes. The various TLR2 antagonist action is being seen by the activated macrophages through this, and also it prevents leprosy as well as in tuberculosis. It's also been a vaccine which was used in tuberculosis and also been used as a part of prophylaxis against COVID, and certain studies also have been going up on this. Various Sepsivac, as I told you, various as far as the nasal part or into the lungs part, we have seen that TLR2, the NOT2, and the MYDD8 is important, and they have got suppression onto it, they act various it. An important part of it is the poly-TLR antagonist against the 4, 5, 7, and 9. So this antagonism action is very important to produce a suppression of the cytokine storm and the various liberation of the inflammatory markers, and thus prevents the progression into multiple organ dysfunction. Sepsivac, again, it induced the MAPK modulation by inhibits the cytokine production. And we saw that intermittent, most important is the interleukin 168, as well as the tumor necrosis factor APLA, even in the control group, as well as in the Sepsivac group, which you can see here in the orange group, there is a significant amount of suppression, which can be seen in the inflammatory markers which were there. Now, the effect in cytokines, most important is the cytokine 6 as well as the interleukin 1, 12, 5, and 4. Even in the control group, it produces a cytokine amount of suppression. And along with the pro-inflammatory markers, the anti-inflammatory markers also get suppressed. The various gene profiling, as I said, most important by means in simple terms, it produces a good amount of a gene balancing which occurs. This gene balancing is very important. I won't go into the details of it, but most important is the good gene profiling plays a very important role. And if compared with the control group, we have seen here that definitely over a period of time, we can see that from the pink dotted line, there is definitely the pyrogen test is significantly less. The suppression of inflammatory markers is also low, and it produces, and these studies were also produced into 2 different laboratories. And the mechanism of action of Sepsivac, I won't go into the details. This is a very excellent molecule. It's very simple. The TLR2 agonism, the TLR4 antagonism, whereas the gene profiling, the P38 downregulation, and immune homeostasis and direct suppression of the cytokines, and it also kills the intracellular organisms. The various COVID-related, as I saw, basically the liberation of lung injury because of the liberation of various inflammatory markers. The site of action of Sepsivac is very important, which has been highlighted, is by the MYDD88, and also it also acts as the expression and the direct suppression of the inflammatory markers of the interleukin 6, the CRP levels, as well as the acute phase reactants which are there. So all suppression of these inflammatory markers is suppressed. I won't go into the details, and I won't touch into the tocilizumab or the asalizumab or bevacizumab. And important for us is that the action is quite prolonged. It has got multiple levels of action. It also produces a suppression of interleukin 6 tumor necrosis factor and interleukin 10. And most important, it produces a good gene transcription, good amount of a gene profiling, and direct suppression. Now, Sepsivac is related to COVID as well as in gram-negative sepsis. Yes, we really came across the word of cytokine storm, really speaking, as and when this COVID really came into the way. But yes, any kind of infection really definitely has got a precipitation of these inflammatory markers, and these precipitation of inflammatory markers could be because of a gram-negative sepsis or because of COVID. All we as intensivists really became aware of it during COVID. And most important is the suppression of this, and it's a direct suppression and a very rapid and potent amount of suppression which is produced by Sepsivac, and as a result of which it takes excellent results into cytokine storm. In critically ill levels, we have also seen, and this was published way back in JAMA in 20, that the cytokine levels in critically ill patients, especially with COVID ARDS or in sepsis with ARDS, even in patients of trauma, it was also taken into consideration. Definitely the interleukin 6, the tumor necrosis factor, as well as the interleukin 8 levels was significantly reduced. And these, again, the innate immune responses, as I said, it plays a very important role. And the innate immunological sensing of coronavirus and viral invasion strategies are important. The innate immune receptor patterns and the TLR4 and the NLR synergism in COVID. And as I said, the liberation of inflammatory markers, the direct suppression of these inflammatory markers with the help of Sepsivac, it plays a very important role, and gene profiling is the key. The use in COVID treatment, Yes, these were studies which were published, and this study was published by Interpol and by Dr. Guleria, and they saw the primary outcome was the distribution of the clinical status on a 7-point ordinance scaling to death, and the change in the SOFA scores on day 7 and 14, and the secondary outcome they took into consideration the time for clinical recovery, the 28-day mortality, and the time to RT-PCR negativity and the adverse events. And this was the original article which was published. And this was here with Mycobacterium W, the primary subjects were 22. The clinical status for reference range and the clinical outcome 7.84 were 30. And the difference between the clinical states and the distribution as compared to the placebo, they were much more statistically quite significant. And this study was again published by Interpol in Lung India. This was a case study of about 4 patients. They did see that in all these 4 patients, the use of Sepsivac definitely over a period of time, there was a good amount of a reduction in the CRP as well as radiological resolution. And this was published in Lung India. Similarly, Dr. Ingray, he also saw and told us about the observational model in the treatment of COVID patients. And he studied the status of 10 days of post-hospitalization, discharge 116 and total 117. He had 1 death. Along with this, he also found similar amount of inferences that there was a change in the CRP values, the interleukin-6 values after 1, 2, and 3 days of treatment of suppression with the use of Sepsivac, thus saying that it's a very potent suppression of the inflammatory markers and a very potent suppression for the cytokine storm which is being produced. I won't go into the details of it. This was again published in Journal of Immunology, that it's a very potent TLR2 agonist and also antagonist and produces a good gene profile. I'm very happy to present this interim analysis of which myself and along with my friends, Dr. Jirpe, Dr. Kapil Boroke, Sai Prasad, all of it and are a part of this study. And this study was conducted into 5 different hospitals in Maharashtra. This is the interim analysis. And the primary objective was to compare the clinical differences and the clinical outcomes of COVID patients between Sepsivac. And this was compared with the standard of care. And the secondary objective was to see the difference in the clinical outcome of lab results among COVID patients in the Sepsivac as compared to the standard of care without compromising the standard of care. This is the interim analysis not yet been published, and about 213 patients have been analyzed as of now. The study is still being analyzed into the final stages. 186 were there as it was compared with 27 control, and 0.3 ml of drug was given per day at 3 different sites, and this was given intradermal, and almost equal distribution of medications was seen into both the groups. There was tocilizumab was used, remdesivir was given, steroids was also given, and this p-value is insignificant between both the arms in all the parameters shown here. But at the same time, the standard of care was given here, and even anticoagulation was used. Now, Sepsivac into this, definitely we saw that there is a reduction in the death in the ICUs as well as reduction in the death into the hospital, which is statistically significant, which was seen. There was also a 3.1 times reduction in the death if Sepsivac was initiated within the first 3 days versus after 3 days of admission, and the reduction in the death by 2.6 times if Sepsivac is given definitely early within first 2.3 days. So therefore, Sepsivac plays a very important role. Early introduction of Sepsivac was associated with better outcome mortality. And Sepsivac, there was a significant reduction was noted in the duration of hospitalization, the duration of ICU stay in the Sepsivac as compared to the standard of care. And you can see here from the Sepsivac arm that definitely the duration of hospital stays was less, as well as duration of ICU stays was also less. And this was statistically significant into the current analysis, interim analysis. And use of Sepsivac was associated with significant amount of reduction into the CRP values, which was statistically significant. And immediately, as compared to the standard of care, we also saw that the interleukin-6 values were also statistically quite significant. There was a reduction in the interleukin-6 values, as well as the LDH values were statistically significantly less. The inflammatory markers, in short, were less, and the ferritin levels was also noted. And in the Sepsivac arm, it also went down as compared to the standard of care. The procalcitonin value was significantly lower in the Sepsivac arm after treatment, while the standard treatment arm shows the higher levels even after treatment. It also shows that, yes, it can also be used into a part where procalcitonin or gram-negative sepsis has induced a cytokine amount of storm. And therefore, this is also a statistically significant and important kind of value. Is it safe? Yes, Sepsivac is safe. It is quite easy to give. It is definitely well tolerated by the patients and did not lead to any systemic side effects. There was a local reaction which developed in a few percentage of people, even after 1 month, in the form of circular area, certain scaling and crusting occurred. But the injection site immunological reactions is a known phenomenon. There were no systemic side effects which were seen. And there were also, Dr. Sharma reported that injection site reaction, 82% of these were mild, and only 12% of these patients had about a moderate amount of infection in the formation of such kind of small pustules or small kind of inflammatory lesions. But mind you, oral anti-inflammatory drugs and local steroids were sufficient for about 8 to 10 days. But most important is the intradermal injection. If it's given subcutaneously, then these problems occur. It has to be given intradermally. You really need to spend time. You need to train your paramedical staff for the exact delivery of this Sepsivac, and thus in order to save the lives. Is it beneficial? Yes, the immune homeostasis, definitely. Risk to benefit ratio, we have definitely seen that, yes, because of the various multiple levels of action, good amount of gene profiling, good amount of suppression of the inflammatory markers, and synergy with antivirals and the standard of care, it helps to improve the recovery faster and produces faster recovery. Thus, to summarize, yes, innate immunity is very important. The cytokine storm is a strong predictor of mortality in patients of sepsis as well as in COVID. And Sepsivac is being approved by DCGI, and it has been repurposed, and again is one of the armamentarium as an immunomodulator for use in patients of cytokine storm in COVID. Is quite cheap enough as compared to the other immunomodulators with less amount of side effects, less amount of secondary infections and secondary complications. Vis-a-vis, if you really compare it with the other immunomodulators of tocilizumab or bevacizumab, and plus if you really compare it with the standard of care from the interim analysis and other studies which are there, it also shows that it reduces the duration of hospitalization, produces a suppression of the inflammatory markers, and thus early introduction of Sepsivac within the first 3 days was definitely associated with a better mortality benefit. Thank you very much. And I'll open the house to questions. And I request Dr. Jirpe and Dr. Yatin Mehta to join me to discuss further. Thank you very much.
Thank you, Subal. Excellent presentation, overview of uses of Sepsivac, including the mechanism of action and what are the main indications. When the Sepsivac was introduced, I think the number of studies were a bit limited. But now there are randomized studies published in internationally peer-reviewed respected journals with positive results. I think it is quite significant, and it has been used. Basically, I think it was hastened, the whole procedure, because of the COVID crisis, but it has come out with pretty positive results in COVID. And obviously, yes, gram-negative sepsis, the role is reasonably well established now, beyond any doubt that it does modulate the immune response. It does not suppress immunity. So unlike certain other drugs which we used extensively in COVID, with the risk of secondary infections, bacterial as well as fungal, as you rightly pointed out, this does not do that. It only rebalances the pro and anti-inflammatory cytokines, does not suppress immunity as such. So yes, I think it's a very good drug in the armamentarium. And really the side effects, as you rightly said, there are hardly any side effects. Maybe a little pain on injection, maybe inappropriately given sub-Q injection can produce a bleb or pustule sort of thing. But I am also part of a study which is now, I think, finishing. We have used it intravenously and quite safely. I mean, we have not had any adverse events because of the intravenous route of administration. So obviously we are pooling the data and we'll analyze it. But in my center, 19 cases I've used, one more to go to finish my quota of the study protocol. But it is quite safe intravenously also, because that overcomes 3 injection sites. You know, the patient is very sick and sedated, then it's okay to give 3 intradermal injections. But in a conscious patient who is not so sick, it may be a little discomfort to the patient. And as you rightly said, give it earlier, the better, like most of the immunomodulators. But even if you give it late, it's okay. I mean, it is not going to do any harm. So even if the patient is in septic shock and very sick, you missed out a few days, patient has come from another hospital, it's okay to give it. I don't think there is any really problem. Kapil, would you like to add something? Yeah.
Yes, sir. We need to emphasize the three things. First thing, the timing of the drugs. When we say within 3 days, it's not from the admission of the 3 days. It should be the cytokine storm. When you suspect the cytokine storm or the worsening of the clinical condition in terms of hypoxia or oxygen requirements are increased or IL-6 is jumping. So one need to note down very clearly. It is within 3 days of the initial worsening from the stable condition. Second thing, no doubt about the easily available, not very costly, very less complications are associated, but that should not push it for the overuse or abuse of this injection. I'm concerned with that. It should not be landed with the left and right use of the Sepsiscon in first 3 days of the, or when there is a borderline this thing. Third most important thing, when you are showing the slide, it has to be the standard versus standard plus Sepsiscon. It is not the standard versus Sepsiscon comparison. So it is comparison is your standard treatment, which includes the antiviral steroids and the lomarcan, whatever this thing. And the other group is standard. That means the whatever your treatment offering in the first group, along with that, you are adding the Sepsiscon. So that need to be correct. But that will also give you the certain advantage. And what Dr. Mehta is adding, if it is IV available, then it will be the definitely additional age over the sub-intradermal, because if suppose patient are having the coagulopathy, his D dimers are high, he has a bleeding tendencies, DIC. I don't know that technique of the subcut and intradermal. There is very skill or a very thin line in between that. It should not landed with the more complications with the hematoma and this thing that need to be considered. But overall, what you shared our experience of the 180 plus cases, it was encouraging. We need to again do some more refining and before going for the presentation.
Absolutely.
Yes.
Dr. Mehta, one question. Sir, you are using the same dose intravenously or it's a separate kind of a pre-filled syringe?
No, same dose, 0.3 mils.
0.3 ml.
In one go. Yeah. Yeah.
In one go. They're not 0.1, 0.1, 0.1, just 0.3 stat.
No, 0.3 in 100 mils of saline and give it over half an hour, 1 hour.
Okay.
Then sir, what will be your timeline in gram-negative sepsis? Like for COVID, we know the cytokine storm and this thing. So in gram-negative sepsis, will go on a day 1 when there's organ involvement, or you need some biomarkers to add?
I don't know, because see, most of the studies, they have not been governed by the biomarkers as such.
Yeah.
And so it is not a specific particular IL-1 or IL-6 or TNF-alpha antagonist as such.
In
so
fact,
I think.
what
will be your indication? What will be your indication?
I'll use it in a gram-negative sepsis in the ICU.
No,
I will not use
I
it
personally, I think Kapil, see, like all other immunomodulators, like really, whether we are considering use of ulinastatin or we use activated protein C, which we nowadays don't use, every time the onset or the use indication was onset of organ dysfunction or the onset of septic shock. So I think that should be the same level where we should consider to use it, that yes, you have a gram-negative sepsis, he has an organ dysfunction, and that's the time where you should initiate it, I personally feel.
See, if the patient with gram-negative sepsis is admitted in the ICU, obviously he's going to be admitted with some organ dysfunction.
Yeah. So I think almost all patients, but early onset of organ dysfunction, you should use it.
Yeah, because see, we have to be very precise. Like in acute pancreatitis, there are clear indication for ulinastatin. We are talking about the steroids when there is a refractory shock. So that gives us a proper guide to when to add. It should not be the precision medicine or the everyone choice when they will add on a day 1, day 2, or day 3. And Dr. Mehta, you have mentioned that even if it is late, it has some additional benefit. So again, suppose in first 72 hours of the gram-negative sepsis, and if the patient is still not settling down, do you prefer Sepsiscon?
No, this is, as you rightly said, Kapil, that this is, one must understand that this is adjunctive therapy. This is not the main therapy. So your standard of care has to continue. These are additional things which you can use maybe in whichever way to benefit the progression or lack of progression of the disease. But these are adjunctive therapies. So, I mean, if you are using it in late stage of the disease, yes, you should realize that the possibility of mortality is higher. But not necessarily because of sepsivac, because of the patient's own disease, which has progressed beyond one organ to multi-organ or whatever. So, but I don't think there is any harm in doing that, because even in COVID, if you look at it, the cytokine storm appears a bit late in the disease, after about 7-8 days of the disease. So if it immunomodulates, I think particularly in COVID, you can use it after a week. I don't think 3 days we will use it. No, I mean, unless you really have a very high IL-6 levels.
Yeah, but what Subal has mentioned in COVID, definitely the results are encouraging in a few studies which are available. And this will be the Subal, most likely our real-time experience in an Indian scenario. I think
absolutely
that will add some additional value to the indications, as well as the where we can place these drugs in our day-to-day practice. Or
absolutely. In fact, once the complete analysis is being done, definitely is going to really throw a good picture into the exact indications and also help us to fine-tune the exact timing of initiation of it.
Okay.
And I think there should not be much difference between COVID or any other infection, non-COVID. It can the same kind of infection, whether it's a gram-negative, as I said, or a gram any infection. If there is a worsening up, definitely it should be considered and it should be used. Of course, not in the,
yeah, Subal, if you notice, this drug is already established for the gram-negative since more than 1 year or this thing.
I know that.
But probably COVID push this use of this drug in a right manner. So
absolutely,
let's see where we in a right way and encourage the use in certain population in a day-to-day practice.
And yes, in fact, these studies will really be helpful and they will be really good. Give us good messages, and it will increase our armamentarium for the management of sepsis. Let's hope for the best.
Okay, that's fine with me.
So I think this is the last session, no, Kapil? And
yes, sir. Yes, sir.
Yes, sir.
I think I must thank everybody. The meeting has gone off very well, very well attended, and the content was very good. And I think even the people who organized the audio-visual and things, I think excellent. There was absolutely no hiccup. Connecting and going in and sound, audio-visual, excellent. I think you must congratulate them.
Yeah.
Same good job. I think.
Same feeling.
And the second year consecutive, I think we are doing so far quite well. We must be happy. No.
Yes, sir.
And Subhash has also done a good job. I think everybody worked together quite well, I must say.
Thank you, sir. Thank
you, sir.
So
thank you,
everybody. Thank you.
Thank you, Cadila, for supporting in this session. And I hand over to Dr. Khalid Kapil, the moderator, for his closing remarks.
Thank you, everybody. So we have come to the end of the sessions, and we have come to end of Sepsiscon. So I take this moment to thank all the faculty, delegates, sponsors, as well as medevents. And I hope to see all of you next year. Thank you. Thank you very much.
Thank you. Thank you very much. Thank you. Stay safe.